And I have a great pleasure in inviting my teachers here. Dr. Vasanta Madam is here. My senior from SN, Dr. Madhuria, she is here today. So I have the pleasure of inviting my seniors, my colleagues, and my juniors. And I must say I'm really selfish because I have collected everybody who are close to me, dear to me. And in that way I should say I am selfish, because and I'm honored to have my teachers, my friends, and my colleagues and my juniors here today with me. So the idea of this particular competition is to bring us all together, and for people who have never had space sometime in presentation, to give them a podium space so they understand the idea of presentation, and the seniors, give them an experience of how to go about presenting. This is what is all about. And I must not take the individual credit here, because mainly all these things where, I have been involved in this by Dr. Ekta, and she was the one who actually put my name in it. But then I must thank her for what she did, because it is indeed it was a nice thing for me to get to know many people and their ideas and viewpoints. So it's been a great learning experience. So without undue delay, I would invite my friend Dr. Radha Annamalai, Professor of Ophthalmology in Sri Ramachandra Medical Institute of Medical Sciences, to introduce the speakers of this great particular session. Over to Dr. Radha Annamalai, please. Thank you.
Good morning. Thank you for the opportunity to be a part of WS, and thank you, Dr. Suguna, for roping me in, Dr. Ekta for roping me in to be a part of this. So it is, we would start directly with the speaker, Dr. Maya Heda. Ma'am, it's an honor to have you here with a, ma'am has a brilliant mind with many academic accomplishments. She has completed both her MBBS and MD from All India Institute of Medical Sciences and has passed out as a gold medalist in both. And she serves in the oncology, ocular oncology and oculoplasty services as the head right now. And she currently is with SMS Medical College. So she's a member of Women Ophthalmologists Worldwide, and she will be elaborating to us now on the current and future of women ophthalmologists. So ma'am, it's an honor to welcome you. We are waiting to listen to your talk.
Yeah, thank you. I was not able to unmute actually in between. Thank you. So I thanks the Tamil Nadu Ophthalmology Society State Chapter and Puducherry State Chapter, and also the Women Ophthalmology Society for having me here. Good morning, Madhu ma'am, and good morning all of you. So on behalf of our Secretary, Dr. Mohita Sharma, I'll be talking about the current activities and future prospects of Women Ophthalmology Society. So can you see the screen, please? Okay, fine. So we have a proud in saying that Women Ophthalmology Society is one of the fastest growing society in India. And over a span of 7 years, we have 2,500 members and 18 state chapters. And the motto or the concept of WOS is givers gain. That is, more you give, more you get. So here the members are supporting each other, helping each other, and uplifting each other rather than showcasing their own selves. And on the similar concept, we have the mentorship programs of WOS, and which are based upon the concept of you are not alone in your professional journey, and there is a mentor to guide throughout your professional journey. And it began with a galaxy of 25 mentors few years back, where the mentees can choose from these 25 mentors and can have one-on-one basis interaction with them throughout the year. And also they develop an association which carried out throughout their lifetime. And during the COVID time, we transformed this mentoring program into virtual sessions of Meet Your Mentor, which was having 10 participants per session, and their mentors can guide them virtually. After the mentoring programs, we have a mentored live surgery also during our annual conferences. Here, it is very a unique program of WAS where mentees perform live surgeries under the guidance of their mentors, and it help boosting their confidence, and it is such a unique program of WAS. Also, WAS has rendezvous with live series where men of substance, women of substance, they share their experiences, life journeys, and tips and tricks, which inspire WAS members to uplift themselves. Also, we see that though women constitute a substantial amount in ophthalmological society, but they're not there in leadership roles to that amount. So we have leadership sessions where the inspirational women can guide through us, because we believe that women can be a leader in all the aspects of their lives. And apart from that, we have regular academic session at WAS and Life Beyond Ophthalmology session where work-life balance is discussed. And today we are having a competitive virtual resident session, which is also one of its kind, a mentoring session, because residents have their mentors along with them to support them, to guide them and discuss their case. And very unique and flagship program of WAS is a WIN-R program, that is Women in Research program. So here we think that because women have a creative and perseverant kind of personality, and that is, these are the two qualities which are needed for research. And we have an untapped pool of large number of women ophthalmologists who are in research. Only a handful of women in institutes are there in research, many pursuing solo practice or in private eye care setups. They are not able to pursue research. So Women in Research program helps those women who wants to pursue career in research along with their clinical practice. And here we have closed door meetings of those who ever wants to present their ideas. So we have the expert panel from WAS. They guide them to modify their protocols and help pursue their research ideas. Also, we have GCP trainings, that is a good clinical practice training courses. These are the certified training courses which have been attended by 100 WAS members, and these are needed to pursue your research. If you want to do a clinical trial or anything, then you must have these training courses prior. Also, WAS has its own ethical committee. If somebody who is not in an institution and does not have any institutional review board, then he or she can present her research to the WAS ethics committee for further progress. And these are few WAS members who have presented their initial studies and completed their projects under the WIN-R project of WAS. Also, WAS collaborates with DST, that is Department of Science and Technology by Government of India, and the projects of WAS member can be funded by DST if it is approved. So they call for proposals, and our 3 members, including Dr. Swati, Dr. Nisha, and Dr. Maxine, they are pursuing research project with DST. And not only in clinical research, but WAS has extended its area into molecular research also. WAS has set up some biorepositories and conducted training sessions of WAS members. And these training sessions, they train about how to do the sample collection, storage, and it has collaborated with the core lab of Narayana Nethralaya. And now molecular research is also being launched at WAS. When our website is soon going to be launched in WAS, and where you will get all the information and opportunities for the national and international research. You can get research mentors, and there are special circumstances where which are meant only for women in research, and you can get access through this website for all those programs. Now, Red Group is a very unique and one of its kind program of WAS. And now recently, IGO has come up with this Red issue, that is a rare eye disease issue, which was started as a brainchild of WAS members, and especially Dr. Mohita. and Dr. Rohit Shetty. So this issue is comprised of all the rare eye disease articles. And now the second step in this RED project is to set up a registry, national registry for the rare eye diseases. For that, WAS has identified many leads, and it's working toward registry of these rare eye diseases. Now, we all are aware of the violence over doctors, and recently there has been a this misfortunate event in Rajasthan where Dr. Archana was harassed to that extent that she has to commit suicide. So WAS has launched a project Archana, where there are three activities which helps the doctors to deal with the crisis, and there are session experts which help you to deal with physically, mentally, and legally to protect yourselves from such crisis. And the second activity is a phone a friend, like emergency helpline number, where whenever you are in need, you can contact on these helpline numbers and get help. And the third activity is dealing with your local police and media. So this is one of its kind activity from WAS to help dealing with the crisis of such nature, so that such incidents may not be repeated in future. Also, WAS has extended its region not only to India, but it has collaborated with other women in ophthalmological society and created its own Women Ophthalmologist Worldwide Society. For that, also Dr. Mohita Sharma is its General Secretary, and we all invite you to collaborate, network, and be a member of WOW, that is a Women Ophthalmologist Worldwide Network. And the first annual conference of WOW is being held in November 4 to 6, and this will be along with the annual conference of WAS. So we all invite you to join in and get benefit and opportunities by being a member of WOW. So I congratulate you for organizing. I think for the first time we have such large number of participation from the residents, and we are looking forward to have a wonderful session. Thank you for having me here.
Thank you, ma'am. Thank you. That was very encouraging to all of us. So our next speaker is Professor Dr. K. Vasanta. Ma'am, it's an honor to introduce you. Vasanta ma'am, as all of us fondly call her, is a former director of RIO-GOH. She's an excellent surgeon and a brilliant clinician and a very passionate teacher. So she has actually inspired so many ophthalmologists, including myself, and her inspirations extend beyond academics. She has taught us integrity, compassion, and perseverance, and till today, ma'am, all that helps us. So she has been a pivot of Cornell Bank, iBank services, and ma'am, it would be great to listen to you on how to celebrate the legacy that you are. Please, we invite you, ma'am.
Thank you so much. Thank you, Radha, for an excellent introduction. And I thank the organizers for giving me an opportunity to talk about our institute, which all of us who have studied there, we are very passionate about our institute. Am I audible?
Yes, ma'am, perfectly.
And I heard Dr. Hada, and I'm really impressed with the work by WAS, their mentorship, and the way they are doing that research work. I'm really impressed, and particularly about the ethics committee, because I have had problems when I was trying to do some research work, and the ethics committee report given by, I don't want to name which one, so it was not accepted. So this is a very good work we are doing, Dr. Maya. I'm really impressed. Now I'll go on to talking about our institute, which is situated in I hope you all can see.
Yes, ma'am.
So our institute is situated in Chennai at Egmore. I'm living very close to it. That shows how I'm even more involved with GOH even now, because I have worked there for more than 30 years. So this hospital was started as an eye infirmary in 1890, and it's now a full-fledged 420-bedded hospital, so part of Madras Medical College. Because many people think, because the Madras Medical College is in Central and we are in Egmore, even people in Chennai, they don't know that we belong to the Madras Medical College. So I request everybody just listening to mute so that there's no interference. So, and we teach the MBBS students from Madras Medical College, and we get 30 MS postgraduates every year. So at a time, there will be 90 postgraduates studying in our hospital. This is possible because since it is a 420 bedded hospital, we have got that many teachers. 6 units are there with separate units for cornea, uvea, oculoplasty, retina, pediatric ophthalmology, everything. Okay, so this is the one of the old buildings, so which is like the Red Fort in Madras Medical College. So this is called the Lolly Ward, and the next one is our director's room is a really big one with all the photos of the previous superintendents, because initially they were only superintendents, and later on once our center was recognized as a regional institute, it is headed by a director now. So the list of directors, everybody is there, starting from 2018, 19. Those days, only lieutenant colonels were there as superintendents of our hospital. So because of that, our hospital is the only one which has got a very big house for the director, which is in 10.5 grounds house is there in Egmore for the director. Yes. Am I audible?
Ma'am, you're perfectly audible.
Okay. I heard my name being mentioned. Now we have a full-fledged library, which is more than nearly.
Request for everybody to mute their.
I request others to please mute. So a library which is goes around 1,000 square foot with all books. We have this is a place where we store all the old AJOs starting from 1900. So those old books are still being maintained. A whole set of old copy of Duke Elder, and every year we get all the latest journals, and the students can be can really use the library very well. And I use it still. And we have one of the museums meant for eye diseases. This is the entrance to the museum. And in the museum, those days they didn't have that much of photography skills, no? So all diseases will be painted like this. This is the entrance to the museum. And in the museum, we have lots of shelves and case sheets of those days in the 1800s. And the one done by our early superintendents, everything will be there. And we have models like this depicting the anatomy of the anatomy related to eye. It's not that we are just stuck there in the olden days. We have all the modern equipments, and here we have a optometry school which has completed nearly 60 years, and now we have the BSc optometry course also. So we have this is one of the opticians checking, and we have the both anterior and posterior OCT. This is thanks to our central government, because ours is a regional institute of ophthalmology. All the equipments are provided by them, and the latest phaco emulsifying machines, and then now we have even a 3D operating microscope in our library, and in the theater. And thanks to the Lions Club, we have a very good eye bank with a separate building for the cornea, separate theater and ward, everything is there, and we are well equipped with all the instruments because of that, because of the Lions Club. And in going a little bit back to the history, the first corneal transplant was done here in 1949. Here there is one interesting story. One of these days, not the first one, convict who was to be hanged wanted to donate his eyes, and that eye was transplanted to a man. That man got upset because he got a convict's eye. So that is one of the reasons now we don't tell the patients from whom they got the eye. One of those reasons. Of course, another one is because we don't use all the eyes. That also is a reason. So the yellow course was there even before diploma. The great Dr. Danda studied here. He did his yellow course here, and it is recognized for training other government medical colleges. This is because ours is an RIO, and we have from all over India, mainly from Uttar Pradesh, Bihar, Orissa, in those places, Andhra Pradesh, some from Kerala also came to our hospital for learning phacoemulsification, retina, pediatric ophthalmology, glaucoma, and corneal transplant. So, and our postgraduates, you all must be knowing that they win most of the quiz competitions. And our surgeries have been telecast live to international conferences in Moscow and East Africa. And our faculty has presented papers in international conferences. It was not so much in those days because as government servants, we just used to get our promotions without any problem. But now, of course, we have to present papers and publish papers. That has made everybody more interested in research work. Though we have used to get rare cases, we never bothered to publish. And that is another thing I am happy about was helping people to publish their rare cases also. I'm really happy that you're doing that. And we regularly present instruction courses in both state and national conferences. We have I myself have done instruction courses because I'm a cornea person, on corneal ulcers, contact lenses, and I'm interested in orthokeratology also. So we have presented more instruction courses on these subjects. As I told you again already that we have all those newer instruments, and we are not staying old. We have the latest building has been built in our campus itself. It's a very big campus. So thanks to our previous director, Dr. Anand Babu, we have got a new building now, fully air conditioned with the latest equipment and equipped in the sense all those theaters and other things. The newer surgical and investigational equipments have to be bought. I hope the government helps for that. So we have got a new building also, which shows that we are keeping up with the times. We are not staying in the old days alone. Thank you. I again thank the organizers for giving me this opportunity. Thank you so much.
Thank you, ma'am. It's always lovely to listen to you and anything about GOH. So I next welcome our speaker, Colonel Dr. Nadu Puducherry, the director of RIO GOH Hospital at Sitapur, UP. He has worked in AFMC Medical College in the capacity of a clinician, teacher, and researcher, a very versatile and accomplished anterior segment surgeon. He has been involved in extensive community service and is the recipient of the All India Achievers Foundation Award. Her dynamic leadership has transformed a rundown rural dispensary to a tertiary eye care system, no small job, for the people in UP. Ma'am, it would be absolutely wonderful to have you address us on this journey of revival of Sitapur Eye Hospital. Welcome, ma'am.
So much. Thank you, Ekta Subneshwari, for calling me up here. And it's a boss session, so it's very special to me. You all know as exactly why. And this is very close to my heart, the subject, and I'm very thankful to Dr. Basanta because she's given so many points so that I won't need to talk about them. I can just refer back to her. So we start from here. Founder of Sitapur Eye Hospital was Dr. M.P. Mehre, and the visionary learned his initial ophthalmology at GOH, and then he went to Austria for advanced ophthalmology. And imagine at that time in 1926, he had a vision of eye care for all. And finally, by 1960, Sitapur Eye Hospital became the center of excellence. You can see all his awards, Padma Shri, Padma Bhushan, etc., something we never bothered about. So what the model was, the base hospital, 1,200 bedded hospital, plus 32 centers, each center 200 bedded. You can just add the number of beds. Each center had 3 to 5 fixed clinics to what we call vision centers now. There were weekly, monthly clinics. Everybody had to do camps, pathology, research, animal labs. Things like Dimox, chloromycetin have been researched in Sitapur as the original molecule. They had the entire thing for the glass making instruments, blood bank, think of a thing, and that was there. So this is how he had started. From the small place, this was his camp vehicle. And Sir John Wilson, who is the founder of Royal Commonwealth Society, he called him the architect of modern eye care or structured eye care in India. His camps used to be huge. Thousands of people used to be operated in those camps. He started his retina department in 1956. Dr. Meher Shukrat came and started it. Oculoplasty in 57, Moorfield, Dr. Patni was brought to India for that. Orthoptics by Dr. Keith Lyell. Cornea and keratoplasty started the concept of outreach of cornea retrieval from Haridwar. The School of Optometry of ours is now 60 plus, 63 years old, and so is the School of Orthoptics started by Dr. Keith Lyell again. Regional Institute of Ophthalmology became later. Initially, it was 1965, Nehru Institute of Ophthalmology, because there was a need. And what you can see over here are Pahwa, Patni, and multiple people who were the stalwarts along with Dr. M.P. Mehre. First off, every Zeiss machine used to come to Sitapur first. So that is the glorious history. That didn't end there. He inspired so many people, and Dr. V was the most inspired person by him. And what you see now is a humongous Arvind eye care system. NPCB 1973 was brought in place by Dr. M.P. Mehre and his friends, and Dr. V and Sir John Wilson were part of that due to his proximity with Indira Gandhi and the need in the country. But everything that goes up comes down as well. So in 1974, he passed away. His son, who was a prolific teacher and a wonderful surgeon, made reasonably bad decisions, and the Sitapur went down the slopes. This is how it happened. If you see in 74, 73, it was peaks, then strikes, and this, that, a lot happened. And when we reached here, it was at the bottom that you see that 2009, where you see that thing, that is the time we entered in this hospital, and then onwards, there's been no looking back. So come down to why it all happened. System was built by a great leader on particular values. Successor could not imbibe those values and leaderships. Being a teacher, being a surgeon is not enough to enhance and restore or to continue institutions. So how it all happened was, he was a government medical college, KGMU professor and head. He tried to run Sitapur like a government medical college. Dissociated power, he had the power, he gave all the responsibility to CMO. Human beings are emotional beings and they need all the love and care. They were treated like objects. Infrastructure decayed, mafia came with the security, and then it just fell down like a leaf from the tree. As an institution builder, you need to have qualities. You got to have the power of it. Could be one person, one couple, one family, one group of people. They have to be driven by a calling or a purpose, triggered by a passion, competent, compassionate, jack of all, but most master of most, high risk taking capability, love, enjoy changes, sacrifice for self. All these you got to have to become an institution builder. So for me, it was undoing and then doing. And the biggest undoing was to tell my own professor and head, because of whom I came to Sitapur, was what was wrong with him. Believe me, try doing it to your parents. It's the most difficult task. But then I did it and delivered the quality what was required. And that was the turning point. The paradigm shifted and he started believing that it's not only about the finance, it's about the passionate leadership that can make a change. And then there was no going back. Though he was my teacher, whom I really loved, but my inspiration is chief. Whenever I was in any kind of dilemma, if I closed my eyes, chief was there. And so he came to Sitapur just for morale boosting. And believe me, it helped. It helped to the end that I could carry on. I'm carrying on till now. So first and foremost thing is you got to have a vision and you got to have a mission. Mission is vision broken into multiple pieces. So just the way Sitapur model earlier was, that they had community service, they had state-of-art equipment and facilities, they had self-sustained infrastructure, they had compassionate care delivery and free flow of funds. Exactly that same model I converted into more scientific and management terms. The worst thing about Sitapur was HR. Even chief had told me, if you're going there, think about it. HR is very bad over there. You can think of any bad quality. It was there along with mafias. So what was required? We assessed the critical needs, regrouped, motivated. We had to remove the bad guys and we had to face that music. We suffered, but doesn't matter. It worked. By 2011, in 2 years, a new culture was born. Is it easier to build strong children than repair broken men? And that's what we had to do. And another point I want everyone to know is that courage is the most important virtue. If you don't have it, no matter what virtues you have, you can't practice them at all. So coming to lessons, love and protect your people, move the group together, work in a team with compassion and transparency. Trust is the most important thing. If the people don't trust who are working for you, it's difficult to manage. So first and foremost thing is build relationship and put trust. The red flag is that manipulating and using employees can work for a while, but it cannot work for long term. The clientele was lost in Sitapur. The daily OPD when I went there was 35 a day, and now we have about 750, 800 a day. So you need to manage that with giving quality service and putting good practices. Demand generation is a task that can be delivered only by working hard and making your team have with you and work hard. So what is really required is empathetic attitude and quality care and service delivery. So everything has to be as per protocol, quality checks at every place, and also ease. So EMR and things, they're really helpful, and we had to do all that. So all the quality and systems over a period of time, and there for last 13 years plus, but now I can say everything that we had planned is now in place. Infrastructure was this, it was like I used to cry every night because seeing these buildings and how will they ever be anything worth living or worth working in. But by God's grace, all is well. Now we are reasonably well off. We have 19 tables OT, we have 10 phaco machines, lots of things like 19 tables running. You can just think of whatever is required, the best of equipment, best of doctors, best of staff. We have diagnostics for all the specialities. Ma'am Vasanta has already talked about. So all that, whatever she's talked about, we have that plus more. Other than that, we have LBAs, we have oculometry lab, we have pediatric. This pediatric clinic is very special clinic for not only amblyopia, even for multiple visual disabilities and also cognitive vision disorders. Then this is the way it is from 2009 onwards. And COVID, of course, troubled us in 2020. But in 2021, we were able to take it back to where we were before COVID. So that's the kind of resilience institutions need to have. So my inheritance was no community service. When I went there, by then all the camps and everything had stopped. So we had to start structured camps and everything end to end. So now the camps are comprehensive eye care. They're given all essential medicines, brought to hospital, food and everything is taken care of. For school, we don't do only school screening for glasses. The children for diseases are also selected, brought back to hospital under RBSK. We are doing all the surgeries for them. Other than that, keratomalacia is rampant, still around Sitapur. So that is another vitamin A scheme run side by side. Then we have 25 vision centers, the static facilities, 5 in Uttarakhand, and the highest one is in high altitude in Joshimath. Then all the basic services, glasses, and important is that our vision centers are doing all the screening for glaucoma, cataract, as they all have handheld cameras, fundus cameras. So this is training of the grassroots level workers in the villages and community level volunteers, so that if any person needs any care, they can at least give the first aid, or they can refer them to the vision centers or the hospitals. Various ways of awareness, and magic is one. We leave no one, from children to the old people to private partners to women who are not made aware, and they're covering about 9 districts, a population of about 4 crores. When COVID came, there was no way to reach. They were not able to reach us, we were not able to reach them. So we started this door-to-door screening, and we have made these 6 teams of having 2 people each, with trial set, trial frame, torch, retinoscope, auto-refractor EC, and mobile phones. And they were able to provide refraction services, spectacles, medicines, especially glaucoma medicines and all could be delivered to them in their homes, and referral services to hospital. Then, weather became bad. And then there was no choice. These mobile-borne people could not really work. Then we shifted to mobile vans. We purchased these vans. These are equipped clinics like hospitals with everything inside them. So whatever was needed to be seen inside, they were seen inside. But all the same, ultimately, they converted into mini camps where the patients would go with one line inside, with the other line they'll come out. And they have teleophthalmology as well with them. So now the good thing is that not only vision centers, wherever they go, it becomes a vision center. So this is the way screening goes in mobile van. They have a rebound tonometer, they have a fundus camera, slit lamp, conioscopy. So it's a good thing. And this what you see is they have the EMR built on the teleophthalmology thing. Now running all this needs money. And the money, normally people think patients' resources, but that's not the only way. We have to have multi-bank financing. And that is from patients, from government, donations, NGOs, INGOs, opticals, medicals, catering, training, everything. But red flags are government and donations. If we get too dependent on them, what happened to Sitapur actually, when it came down, their dependence was a lot more on these 2 red flags. So I always say good to have donations, but not much, not much. So our strategic partners are Arvind, Sightsavers, CBM, SightLife, USAID, LabSD, Vision Foundation India, Orbis, Perkins, Jeevdaya Foundation. They all have different roles in different areas of ophthalmology. Coming to medical education, Sitapur became RIO, one of the first RIOs to become in 1970, whatever time it happened, I don't know. They had only DOs. But now we have 15 MS seats, so we have 45 MS candidates. Diploma in optometry became diploma degree. Now it's bachelor optometry. So we have 160 students of that on the campus. Plus diploma in ophthalmic assistants, we have 60 of those. Plus we have some of those MLOP girls. So this is a vibrant campus with young people. Other than that, we have fellowships in ophthalmology, different subjects. Then we have fellowships in low vision, diagnostics, long-term clinical fellowship for optometrists, for orthoptists. There are lots of training going on. So now I can say we have become sort of, again, a full system that Sitapur probably was sometime. There have been multiple awards at this thing. Not that awards matter, but yes, they are a morale booster for the people who are working for you. So institutions can be built or lost, but who can do it? We, the doctors, and the women. I'm telling you, the women can do it. Leadership and doctors need opposing skills. There is a huge conflict. Leaders need to think big. They look at big picture. Doctors, I'm so sorry to say, I'm a doctor myself, but we think very small. Till I came to Sitapur, I was also patient, and only patient. But if we don't lead, we shall be led by someone else. So we got to choose at some time or the other. Now, how many doctors enjoy working under managers? I'm sure none. But if we don't learn ourselves, we are not leaders. Do we have a choice? We don't. So what should we do? We should start taking responsibilities. Look at the big picture and not only the clinical picture. Performance matters and not numbers. And performance means performance in terms of surgery, clinical skills, performance in terms of education, performance in terms of research, and in terms of administration. Unless until you have all this along with good soft skills, you're not a performer. Performance requires teamwork. And it can start right from the day one you start. It's like, say, fellows, residents can start from that level. Take smaller responsibilities, do them well. You will learn many things, how the institutions run. And over a period of time, you will accumulate so much. I never realized in army, I was slowly learning at every stage. And when I came to Sitapur, I realized there was so much inside me which did not know was there. And it just came out when it was needed. So, you are prepared by someone up above to do things that you're supposed to do. And then we have to have value systems. We need to work in value-based organizations. Valueless organizations can give you money, but they can't give you the life, they can't give you performance, they can't give you happiness. Another thing we are poor at is communication. Doctors think that they are gods and their patients, they are the only advocates. But believe me, each one who's working with us cares for patients and they're all patients advocates. So we should be inclusive of all the people who are working with us. We should have mutual respect. Believe me, I still remember Dr. Badrinath's driver employee number 1. And in SN, I was cared for as much by each employee, not for anything else, but it's just that it comes naturally to some people. No criticizing and bickering. Again, system talking is kind of enjoyed. But believe me, you are hurting yourself. You're not hurting the system, you're hurting yourself. Because if you don't have courage to come and talk to the leadership regarding what you think is not right, then it's not worth it. You can't change it. If you want to change it, then just walk out. Thoughts direct the speech. So think well. If you think well, you will speak well, you will do well. So the power of communication actually can build your relationships. It can give you values. More patients will come to you, more success will come, and obviously people will be loyal to you. So only constant thing in life is change. Embrace change and use it as an opportunity to learn. Resistance to change leads to stress. Anybody I hear, oh, I'm so stressed, I'm depressed. Why? Because resistance to change is exactly the cause. So we gain experiences. We learn leadership. Nothing is permanent, even troubles. And right now where we stand in this gray area, of leadership. As doctors, we come to move on to this. So don't make only buck, make a difference. Thank you so much.
Thank you, ma'am, for that very, very inspirational talk. Sometimes I just wonder how you did this journey by yourself. I next would like to invite Dr. Suguneshwari. She will be throwing a little bit of regulations and rules about today's program, and she'll also be telling us about the guidelines for each speaker to abide by. So please,
Suguneshwari, can I have just 1 minute, please?
Yes, ma'am.
Thank
Yes,
you so much.
Dr. Madhu, I don't know what to tell. You have proved that women can do whatever they want. You had leadership qualities in you. You didn't realize it till you went to Sitapur, and your achievement is really tremendous. Thank you for sharing your thoughts with us. Thank you.
I must indeed actually say Dr. Vasanta and Dr. Madhu Baduria, they are two great women whom I have real great respects for. And today to have them as the first speakers and to be the inspirational motivators, it is something simply phenomenal. So now I would like to brief upon the guidelines so that we have some kind of a clarity and we don't have confusion. So the presenters, the speakers are going to keep up their time for 4 minutes and they will not exceed 4 minutes. If they exceed 4 minutes, they should understand that there is going to be negative marking for them. Number 2, the questions are going to be asked by the panelists and they are also going to stick on to 4 minutes. The moderators will see to that once the 4 minutes is up, they can intervene and please tell us that yes, the time is up now, so that we keep up the time of the program as per the schedule, because we have around 3 sessions to go and we would like to stick on to the schedule on a Sunday. The third thing is the judges are going to be the ones who are going to be scoring. They will not be asking any questions because they are not from this particular state and we didn't want a bias, so that we wanted a uniform performance. And I must proudly say we have 19 institutions today on board with us, and in order to create a uniformity, what we have done is all institutions, whether small or big, they have been allowed to have only 2 speakers. So what the other major institutions did was, the RIO particularly had 19 speakers, and I must congratulate them, all of them, and they had shortlisted them to bring it to only 2 speakers down. So there was a preliminary rounds which we had to hold, and then the final rounds is today. So every institute had to hold one preliminary round in order to shortlist their candidates to 2. And I must thank Dr. Vinata Muralidharan and Dr. Meena Lakshmipati for shortlisting the Shankar Nathalya candidates. And I'm sure all the others institutes also did the same to shortlist. So now, without undue delay, I would invite our moderators to take over, Dr. Shruti Suresh and Dr. Sinisha, young ladies, and who will be doing the phenomenal job of moderating the panelists and the speakers today. Over to you, Dr. Sinisha and Dr. Shruti Suresh.
Thank you, ma'am. Good morning, one and all. We, Dr. Sinisha and Dr. Shruti Suresh, will be moderating the session. So I take this opportunity to introduce our honorable judges of the session. First, I would like to introduce Dr. Kalpana Badami, ma'am. She is the professor and medical superintendent, head of Vitreoretinal Department of Minto Regional Institute of Ophthalmology, Bangalore. She did a VR fellowship in AIMS, and she has also completed her FRCS and FRRF. Our next judge is Dr. Padmaja Kumari Rani. She is the network head of ophthalmology and vitreoretinal surgeon in LV Prasad Eye Institute. She is also the author of Shankara Nethralaya Atlas of Retinal Diseases. Next, I would like to introduce Dr. Shailaja Bashanoy, who is currently working as Retina Consultant and Associate Professor at Kasturibai Medical College. She has completed her FDR Fellowship from Shankara Nethralaya and MS Ophthalmology from Mysore Medical College. It's my honor and pleasure to welcome all our judges. Thank you. Over to you, Dr. Shruti.
It gives us great pleasure to invite each and every member of the esteemed panelists to join this session. A little extra tinge of happiness there because many of them are my teachers. So without further ado, let me welcome Dr. M. Rajakumari, Professor of Ophthalmology, Chettinad Medical College and Research Institute. Dr. Thanashri Ratra, Senior Consultant, Vitreoretina Services, Shankar Nethralaya, Chennai. Dr. Girish Shiv Rao, Senior Consultant, Shankar Nethralaya Vitreoretina Services and President of the Medical Research Foundation, Shankar Nethralaya, Chennai. Dr. V. Savitri, Associate Professor, Anna Medical College. Dr. Hannah, Professor of Ophthalmology at Pondicherry Institute of Medical Sciences. Dr. Alpama Pappal, Associate Medical Retina Services, Janapoya Medical University. Dr. Suganeshwari, Senior Consultant, Vitreoretina Services, Shankar Nethralaya, Chennai. And Dr. Radha Annamalai, Professor of Ophthalmology, Uveitis and Inflammation, and Sri Ramachandra Institute of Higher Education and Research, Chennai. We welcome one and all of you to the session.
Our first speaker is by Dr. Sethu Lakshmi. She'll be presenting on a rare case of sympathetic ophthalmia. Over to Dr. Sethu Lakshmi.
Is my slides visible now?
Yes, your slides are visible.
Okay. Good morning, one and all, dignitaries in the meeting, co-presenters and other friends. I'm here, good morning to one and all. I'm here to present a rare case of sympathetic ophthalmia. I'm Dr. Sethu Lakshmi PR from Coimbatore Medical College, and my mentor is Professor Dr. Thangarani Rajashekharan. The background: sympathetic ophthalmia is a bilateral, diffuse, non-necrotizing randomatous panuveitis. It occurs mostly due to penetrating injuries to the ciliary region and wounds with incarceration of the ciliary body, the prevalence of which is 0.2%, and secondary to intraocular surgeries, the prevalence of which is 0.01%. The uveal pigments that get exposed, which were previously immune-privileged ocular antigens, induces a bilateral autoimmune response. And there is a diffuse lymphocytic infiltration of the uveal tract with epithelial cell nest in response to this. The time of onset of symptoms will be 2 weeks to 3 months following an injury classically. This is the case of a 36-year-old male patient who presented to the OPD with complaints of defective vision and pain in the left eye since past 2 weeks. There was a history of past injury to the right eye, that is scleral tear with uveal tissue collapse 6 weeks back, for which repair was done. On general examination, the vitals were stable and systems within normal limits. On examination, ocular examination, right eye was pre-physical with no perception of light. Left eye vision was 660. It had normal IOP. The anterior segment showed granulomatous anterior uveitis. The fundus had vitritis, papillitis, exudative detachments in all quadrants, and few subductal precipitates inferior to macula. There was no view for OCT and FFA in the right eye. Left eye OCT showed multiple precipitates at the Brooks membrane level, such as balloon nodules, multiple exudative detachments, and NRR thickening. FFA left eye showed multiple pinpoint decays in the posterior pole, with hyperfluorescence in the early phase and pooling of dye in the late phase. B-scan of right eye showed dense vitreous hemorrhage and retinochoroidal thickening, and left eye showed retinochoroidal thickening, exudative detachments, and dryness. Here the treatment was initiated with IV methotrexate pulse therapy, 500 mg BD for 5 days, after which oral steroids were started. Prednisolone 1.5 to 2 mg per kg body weight was given. Topical steroids with antibiotic cover was given. Topical cycloplegics, that is 2% haemometropin and NSAIDs, neperfinag was given. Visual acuity post-treatment with IV steroids was left eye 618. Enucleation of the exciting eye was done and sent for histopathological examination, which confirmed the diagnosis of sympathetic ophthalmia. These are the clinical pearls. First, sympathetic ophthalmia is a rare and potentially visually devastating bilateral fan uveitis that is typically following a penetrating injury to one eye or intraocular surgeries. Early enucleation of a severely traumatized exciting eye that has no visual function is prudent to prevent sympathetic ophthalmia. High index of suspicion is vital for early detection. Like a patient with penetrating eye injuries post-repair can be advised to report immediately if they notice defective near vision in the healthy eye, or post-surgical follow-up cases should be evaluated to rule out pan-uveitis. Prompt and effective management with systemic immunosuppressive agents, that is both systemic steroids and steroid-sparing agents, may control the disease and retain good visual acuity in the fellow eye. Thank you.
Hello. Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. First of all, I should thank host team to give me an opportunity to be a panelist in this wonderful forum. It's a marathon program with 30 speakers. Without any preamble, because I have given only 4 minutes time, it's a very good presentation by Dr. Sedu Lakshmi, and I must I must appreciate her mentor, Dr. Tangarani, for producing this very good presentation. Okay. My question is, like, she has been talking about, she has given a pulse therapy with the immunosuppressant, with the steroids. Doctor, how long, what was the duration of your treatment, doctor? How long you had given this steroid therapy? Because after giving methylprednisolone, you're supposed to maintain with the steroids. And in fact, sympathetic ophthalmitis is one of the disease where you can start other immunomodulators also along with the steroids. So I just wanted to know how long you had given steroids. That's my first question.
Actually, IV methylprednisolone was given only for 3 days, and it was later converted to oral steroids. It was maintained over 4 weeks, 4 to 6 weeks. 6 weeks course of oral steroids were given and a tapering schedule. Other immunomodulators like azathioprine was started, but the patient was not tolerating it, so it was stopped after some time. Only 3 days of azathioprine was given.
No, the thing is, I just want to know for how long, because once you stop in the middle, no, chances of recurrence are more. That's why I just wanted to know for how long you put her on steroids. Is it for
6 weeks, ma'am. 6 weeks, ma'am. Actually, the patient he has to come for review now. It happened one month ago, one and a half months ago.
Okay. And another question was, because already when you had seen the patient was already on, the other eye had inflammatory disease. So yes, I just wanted to know whether you are justified in enucleating. I just wanted to know.
Actually,
especially he was in the pre-thysical state, not in the complete thysis. That's I just wanted to know.
It is actually controversial whether to enucleate or not after sympathetic ophthalmia had set in. So just to make the course of the sympathetic ophthalmia in the other eye a benign one, and to turn it less progressive, we decided to enucleate the other eye.
Okay, and it would have been better if you had put the post-treatment OCT picture also, because you said the
Yes.
vision had a wonderful recovery of 6
Yes, ma'am.
8
Yes,
because
ma'am. Yes,
very
ma'am.
good. Because in my 30 years of ophthalmic experience, I have seen only 2 or 3. That too in RAO GOH only I had seen sympathetic ophthalmia case. Thanks, doctor. Very good. Your presentation was very good. Thank you, doctor.
Thank you, ma'am. Thank you, ma'am. Thank you so much.
Thank you, Dr. Setu Lakshmi. Thank you, Dr. Rajkumari, madam. We can move on to the next speaker now. This is Dr. Priyanka from Jawaharlal Nehru Institute of Postgraduate and Research.
Good morning, one and all. Can you hear me, please?
Yes, you're audible.
I'm Priyanka. I'm from JIPMER. I'll be presenting on choroidal neovascular membrane in a young male with angioid streak. Angioid streaks are defect in the calcified degenerative Brooks membrane that occurs because of various disorders. Most common systemic disorder associated is pseudoxanthoma elasticum. That is an inheritable disorder occurs because of the ABCC6 gene mutation. Other systemic associations are Ehlers-Danlos syndrome, Marfan syndrome, Paget's disease, sickle cell disease, A-beta lipoproteinemia, and can rarely be idiopathic also. These lesions are present as a irregular radiating lines which are brownish gray in color around the optic disc that is radiating outwards, and they remain in size. Sometimes they remain in the same size or may increase in length and width over time. The new streaks may develop adjacent to the old ones. These angioid streaks are usually asymptomatic unless any secondary complication occurs, like choroidal neovascular membrane or any trivial trauma that causes choroidal rupture, leading to vision loss, which may require treatment later on. Coming to our case history, the patient of 43-year-old male came to us with a diminution of vision in the form of distortion of images in the right eye for 10 days. No other significant ocular complaints were given by the patient. No significant ocular trauma were present in the past. On examination of the right eye, visual acuity was 6/9, which was not improving further with pinhole. And on fundus examination, we can see that there is a irregular concentric line present around the optic disc, which is suggestive of angioid streaks. And we can also see that subretinal plaque is present, which is suggestive of CNVM, and subretinal macular bleed is also present. Coming to the left eye examination, patient had uncorrected visual acuity of 6/6 parts, which are improving with minus 0.5 cylinder at 170 degree. And on fundus examination, there was angioid streak present around the optic disc, and no other significant ocular findings were present. We did a spectral domain OCT, and in right eye it showed a subretinal bleed and subretinal fluid and intraretinal fluid, along with the hyperreflective white material present in the subretinal space, which is suggestive of type 2 CNVM complex because it's present above the RP layer. And left eye OCT shows normal foveal counter, and the right eye also had increase in the central macular thickness. On systemic examination, we found that there was a plucked chicken skin appearance, which is suggestive of pseudoxanthoma elasticum. It can also be present in other flexure surface areas in the body. And other systemic examination, including cardiovascular examination, were within normal limits. Although angioid streaks is a clinical diagnosis, we may require OCT look for choroidal neovascular membrane. Angioid streaks are most commonly present in pseudoxanthoma elasticum fibers through the body. The first early clinical feature will be present as a skin lesion, which is present in our patient as chicken skin appearance. This is an early feature that can be present even in childhood. This can be confirmed with biopsy. Biopsy may show clumped fragmented elastic fibers present in the dermis. Early ocular findings will be purity orange, which is a yellowish mottling appearance present in the fundus, which is not seen in our patient. And most commonly, angial streak will be present in both the eyes. Comatal lesions may be is a pathognomic sign of pseudoxanthoma elasticum, which is also not present in our patient. Optic nerve drusen can also be present and pattern dystrophy-like changes. And this disease can also affect internal elastic lamina of the medium-sized arteries. So it may affect coronary artery, leading to myocardial infarction, hypertension, reduced heart rate. Because
Dr. Priyanka, as we're running short of time, requesting you to wrap up faster so that we can move on to the discussion.
Because of calcific arteriosclerosis. Causes of other causes of CMM in young are pathological myopia, ocular histoplasmosis syndrome, angial streak, choroidal rupture, and other causes will be like hereditary changes like vitelliform maculopathy and fundus flavi maculatus. And these CMM young patient may very well respond to anti-VEGF treatment. As in our patient, we gave brolucizumab intravitreally, and he very well responded in follow-up visit. So prompt diagnosis is required to start early treatment. As a ophthalmologist, we should start with anti-VEGF. Thank you.
Thank you, Dr. Priyanka. Requesting Dr. Dhanashri Ratra Madam to take over the discussion from here.
Thank you, Shruti, and thank you, Priyanka. Am I audible?
Ma'am. Yes,
okay, a very good case presentation and a very good case that you have presented, Dr. Priyanka. I would like to ask you, you have mentioned pathological myopia as one of the differential diagnoses, and you know that there are these lacquer cracks which are very common in pathological myopia. How would you differentiate between a lacquer crack and an angioid streak?
Lacquer in angioid streak it will be present concentric to the optic disc in both eyes, but in lacquer class will not be like concentric like in angioid streak. And other features will be like temporal crescent and foster fixed pause may also be present.
So in your patient, actually the angioid streaks is there along the peripapillary area, circumferential. Also there are radiating, also you can see some radiating black grayish lines. So especially in the left eye where your arrow is pointing, just above the arrow and below the arrow you can see some radiating lines from that semicircular line. So angioid streaks can be even radiating also. Okay. Whereas of course, as you said, the lacquer cracks will be present in the macular area, and you will have other signs of pathological myopia. And lacquer cracks are generally small cracks which are not very much visible, clinically. Whereas angioid streaks can be very wide and very big and very large and quite almost up to the equator they can enlarge. And in your patient, you have treated with brolucizumab. Was there any special consideration while choosing brolucizumab, or why did you choose brolucizumab as your agent of choice?
In young patient, actually, they very well respond to anti-VEGF. Since brolucizumab is a newly approved FDA drug, we tried with the brolucizumab, and he very well responded to the treatment.
The connection failed.
Hello.
Hello.
Yeah. So see, brolucizumab. This is a young patient, 43-year-old, and you need to rule out any inflammatory pathology. Okay, brolucizumab has got. Brolucizumab has. Can everyone else please mute themselves?
Disconnected.
So brolucizumab has the side effects.
Request everyone to mute other than the presenter and the
so brolucizumab can produce intraocular inflammation, and you need to be careful. But in your patient, what is the location? Can the administrator please mute this particular participant? So Priyanka, I would like to ask you, in your patient, the location of the CNVM, based on the location, can you think of any other modality of treatment?
You can try laser, but more than anti-VEGF is more respondable treatment.
Sorry, what can you try?
Laser.
Yes, laser it can be tried because basically your pathology, the CNVM is quite away from the fovea. It is almost juxtafoveal or even extrafoveal. The only problem is it's in the papillomacular bundle. So if you do laser, it can cause a scotoma in the papillomacular bundle. So preferably avoid laser and can try anti-VEGF. And as you have mentioned, a lot of systemic associations. Did you do any investigations to look for any other associations?
We have taken a cardiovascular opinion that he doesn't have any hypertension or myocardial infarction risk.
So there is one mnemonic which has been given. It's called Pepsi. So Pepsi stands for Paget's disease, pseudoxanthoma elasticum, Ehlers-Danlos, Paget's disease, and sickle cell anemia and idiopathic. Yeah. But there are other hemoglobinopathies which can be involved, and even hyperphosphatemia, hypercalcemia also can be there. So if necessary, you can investigate the patient to rule out all these things.
Okay, ma'am.
Thank you, Dr. Dhanashree, ma'am. Thank you, Dr. Priyanka.
Thank
We'll
you.
move on to the next presenter by Dr. M. Abirami. She'll be presenting on central retinal vein occlusion in iron deficiency anemia. Over to you, Dr. Abirami.
Good morning all. I will be presenting on central retinal vein occlusion in iron deficiency anemia. Coming to the background, central retinal vein occlusion is the second most common retinal vascular disease following diabetic retinopathy, and iron deficiency anemia is a known cause of central retinal vein occlusion. The underlying mechanisms are inhibits thrombopoiesis. So, in a state of iron deficiency anemia, there is a reactive thrombocytosis, thus leading to hypercoagulability. Then, hypoxia from anemia leading to injury of endothelial cells in the retinochoroidal circulation, and a weaker antioxidant defense in iron deficiency anemia results in increased platelet aggregation. Then, there will be dysregulation of coagulation. Red cell deformability is also reduced in iron deficiency anemia, resulting in increased viscosity. Coming to the case, a 37-year-old female presented with the chief complaints of defective vision in right eye with 1 day duration to our OPD. She had history of headache and tiredness, and she had history of menorrhagia. There was no history of trauma. She is not a known case of diabetes, hypertension, and other comorbidities. Coming to general examination, patient was anemic. This pallor was present. Her BP was 1 per minute. Coming to ocular examination, in right eye, vision in right eye was hand movements, and conjunctiva was normal, cornea was clear, antechamber was normal in depth, and relative afferent pupillary defect grade 2 was present in right eye, and the lens was clear. Coming to the fundus, media was clear, the optic disc margins was blurred, and vessels are dilated and tortuous. Deep retinal hemorrhages present in all 4 quadrants in the right eye, and the macula foveal reflex was dull. Extraocular movements was full in all directions in right eye. Coming to the left eye, vision was 6/6 in left eye, and left eye anti-segment was normal. That is, cornea was clear, and pupil was 3 mm reacting to light. Lens was clear, and left eye fundus was normal. Extraocular movements in left eye was full in all directions. Intraocular pressure in right eye was 12 millimeters of mercury, and left eye was 14 millimeters of mercury. Coming to the investigation, so we did a complete blood count, peripheral smear, and a serum iron profile. Her hemoglobin was 5.5 milligram percentage, and mean corpuscular volume was 68 femtoliter, and mean corpuscular hemoglobin was 26 picograms, and mean corpuscular hemoglobin concentration was 34 grams per deciliter. And peripheral smear showed microcytic hypochromic anemia. Her serum ferritin level was 28 milligram per deciliter, and total iron binding capacity was 460 milligram per deciliter. Her coagulation profile was normal. Cardiology opinion was obtained, and carotid Doppler was done, which was normal. So we concluded that this patient had iron deficiency anemia induced central retinal vein occlusion. So we referred the patient to physician for systemic management. Currently, the patient was under systemic management. 2 units of blood transfusion was done. Then we will follow the patient for further investigations like FFA or OCT for further management. Coming to the first, this case report shows a young woman with iron deficiency anemia presented with CRVO, central retinal vein occlusion. So, if a young female presented with a central retinal vein occlusion, we should evaluate for anemia and serum iron profile, so that we can refer the patient for systemic management to prevent life-threatening complications. So, it seems very important to investigate serum iron levels in young females with a central retinal vein occlusion. Nutritional evaluation and supplementation should be considered in these patients. Thank you.
Over to you, Dr. Girish Rao, sir, for the discussion.
Yeah. So, first of all, congratulations to WAS and the WOW members, and my best wishes to all of you all. And thanks for having me in this panel. Dr. Abhirami, good presentation. I want to have a couple of questions for you. Do you think that the fundus image corresponds with the actual visual acuity that the patient presents?
Yes, sir.
You feel the hand movement vision, because you can see the macula. There is no blood covering the macular area. There's not much of hemorrhage at the posterior pole. So what I'd like to highlight here is that the visual acuity which the patient presented is disproportionate to the clinical presentation itself. So maybe you can consider that in addition to the vein occlusion, there could be an arterial component also to this. It could be a cerebroretinal artery occlusion or a combined CRA or CRBO picture, which is common in these kind of conditions. So maybe your subsequent investigations that you are planning, the FFA, might throw some more light, because the importance of this is more in terms of prognosticating the visual recovery that the patient could have. So if there is an arterial component to it, the visual recovery will be very regarded.
Yes, sir.
So, this is a relatively young patient. So how would you investigate a young patient presenting with a CRBO?
We can do serum lipid profiles and serum homocysteine level. We can investigate for a protein C and protein S deficiency, and coagulation profile factor 12.
Yes. So as opposed to the elderly group where you would like to investigate more in terms of the cardiac and the diabetes status or the hemoglobinopathies, in the young you would look more at the systemic factors, more of the inflammatory causes. So the patients, so the investigations really is a matter of ruling out one of the others before you actually come to a peripheral smear. So peripheral smear as a routine is not taken as the first line of investigation, but definitely hemoglobin is taken as one of the first tests, and subsequent to the hemoglobin being so low, the investigations for the type of anemia is very significant. So I think that highlights that one need not just be in a narrow field thinking that it's only diabetes or hypertension which can cause a CRBO. There could be multiple causes to this. And you said in the treatment that you have referred the patient to the physicians for treating the anemia itself. Anything else that you would like to do from the ophthalmic point of view right now? Or would you wait for the national course to take its course in improving the vision?
After the patient's general condition improves, we can do FFA or OCT for further management.
So that is one line of thinking, but I would suggest that immediately after a complete systemic evaluation, without waiting, if there are no other contraindications, at least you can do an OCT, which is not a invasive procedure. You can do an OCT to see if there is a lot of red edema or a subretinal fluid collection, in which case you could intervene with an earlier therapy. And also these patients, as you said, are more prone to thrombotic episodes. So maybe the physician can also add in an antiplatelet to prevent other complications.
Yes.
Thank you very much.
Thanks.
Thank you, Dr. Abhirami. Thank you, Dr. Girish Rao, sir. We can move on to the next speaker now. The next speaker is Dr. Himani Manglik from Shankar Netralaya. She'll be speaking on blunt ocular injury.
Good morning, ma'am. I hope my screen is visible. Am I audible?
Yeah, you're audible. Screen is also visible.
Okay, thank you. A very good morning to all the dignitaries and my colleagues present here today. I am Dr. Himani Manglik and I will be presenting a case on blunt ocular injury. A little bit of background about blunt ocular injuries seen in our country. Studies have shown that significant vision loss is caused by closed globe injuries, which is more prevalent in males and in children under the age of 10 years. Other studies have shown that blunt ocular injuries are seen with firecrackers, and these are more common in bystanders who are not actively involved in lighting the cracker. While most of the patients are aware of firecracker-related ocular injuries, none use any protective equipment. Our patient was a 12-year-old male brought to the OPD by his father with history of sudden, painful diminution of vision following firecracker injury as a bystander with a cracker lit about 10 feet away 4 days back. There was no history of ENT bleed or loss of consciousness. They had consulted locally before coming to us and were already started on topical steroids, cycloplegic agents, and antibiotics. Developmental and family history in this case are non-contributory. On ocular examination of the right eye, his best-corrected visual acuity was presence of perception of light with accurate projection of rays, with near vision less than N36. External examination showed small burn marks over medial aspect of lower lid with loss of eyelashes. Orbital margins were intact and non-tender. Extraocular movements were full and free. Slit lamp examination showed conjunctival congestion. Cornea was clear and compact. Anterior chamber was well formed with dispersed heme. Pupil was irregularly dilated. There were pigments on the anterior lens capsule, indicating partially broken posterior synecdoche, and lens was clear with no phacodonesis. Intraocular pressure measured with Goldman's applanation tonometer was 9 mm of mercury. Gonioscopy showed 360 degrees of angle recession and cyclodialysis cleft in 3 angles. Left eye examination was within normal limits with presence of an inverse relative afferent pupillary defect. This is a pseudo-color optos image of the right eye in which we can see that the media is hazy because of presence of fresh pre-retinal heme. Disc is pale. Macula shows a full thickness macular hole with heme, which was confirmed on an SSOCT showing hyperreflective dots in the vitreous cavity, loss of tissue in inner and outer retinal layers suggestive of a full thickness macular hole, and subretinal hyperreflective lesions at the fovea suggestive of subfoveal heme. Peripheral retina shows intraretinal hemorrhages, and nasally we can see choroidal rupture. Ultrasound was done to rule out a retinal detachment under the vitreous hemorrhage, in which we can see retina is attached throughout and ocular coats are intact. The patient was managed conservatively and was on close follow-up to look for spontaneous closure of macular hole, but on subsequent visit, a subtotal retinal detachment was noted and was managed surgically. There are a number of things that can be learned from this case, but the 3 pearls I would like to highlight are: a thorough clinical history and examination are extremely important in any case of ocular trauma, and care should be given to distinguish a closed globe injury from an open globe injury as their managements differ dramatically. Close follow-up in these cases is a must, and a suspicion of post-trauma complications should always be at the back of our minds. Had the child not been on close follow-up, we would have missed the retinal detachment and not been able to intervene early. Awareness of firecracker injury is plenty, but use of protective gear is non-existent, which should be emphasized on, and children must light firecrackers only under adult supervision. Thank you.
Thank you, Dr. Himani. Requesting Dr. V. Savitri, Madam, to take on the discussion from here.
Good morning, one and all. I thank Dr. Sugneshwari and Dr. Radha Annamlai and Dr. Shruti and Sunisha for giving me the opportunity. It was a good presentation of blunt ocular injury. Dr. Himani, I have a few questions. And
Yes.
In the history, so what was the duration of, what is the onset of injury?
Ma'am, the child was a
Only
bystander.
4 days, bystander. Okay, what was the type of firecracker, even that has effect on the injuries? So what was the type of firecracker?
Ma'am, it was a small,
fountain?
It was a
Yeah?
small bomb that was lit by some older children, and one of the projectiles
Yeah.
had.
Okay,
Yes.
this child was a bystander. Yeah, that is very common in bystanders. And how did you say this is blunt ocular injury? So how was it classified as blunt or it's closed or open globe? So what is the classification?
Ma'am, there was no evidence of any full thickness defect in the cornea, sclera, or ocular coats. That's why.
Yeah, what is the name of the classification which you had
Birmingham
followed?
Birmingham
Yeah.
eye trauma terminology, ma'am.
Yeah. So what is the ocular trauma score for this?
For this patient, we
Yeah.
calculated at 11%, ma'am. After calculating the raw score, the
Yeah.
percentage was 11%.
It was 11%,
Yeah,
11% or
11%.
11? Okay. So what does it say about the visual prognosis? This 11?
Poor visual prognosis for this patient, ma'am.
Okay. So how did you suspect this cyclodialysis, and was the child cooperative for gonioscopy?
Yes, ma'am. The child was
Because
actually.
I'm not able to see a gonioscopy image in your presentation. I think, yeah. So was the child cooperative for gonioscopy?
Yes, ma'am.
And how did you suspect cyclodialysis?
Ma'am, the child was cooperative for gonioscopy examination. Well,
Yes.
We, however, did not take any images with the gonioscopy. And we could see, first of all, there was, in all 4 quadrants, there was widened ciliary, there was a widening of ciliary body band with detachment of the ciliary body from the scleral spur. That is why we said cyclodialysis cleft in 3 of the angles.
No, is it? Okay, it is angle recession or a cleft was there? Angle recession or a cleft?
Angle recession
okay.
Anteriorly and cleft superior temporal and nasally.
Okay, no, when you see a case of blunt injury, when do you suspect a cyclodialysis? What made, the points which... yes,
hypotony,
yeah. Hypotony, yeah.
Yes.
Yeah.
There can be a shallow anterior chamber.
Very good.
In the cornea.
But here there was no shallow anterior chamber, no? Only
no,
hypotony was there. Yeah. So the anterior chamber was normal, you said, no?
Yes, ma'am.
Okay. So how do you manage this cyclodialysis?
Ma'am, usually since his pressure was 9 mm of Hg on measurement, it's not in the hypotenuse range. But if there is hypotony, then patients are observed and they can be medically managed or surgically managed. For medical management, we can give them cycloplegic agents which help in relaxing the ciliary muscles, and they can aid in the opposition of the ciliary body with the scleral spur. For surgical management, it can be intraocular or extraocular approach. In the extraocular approach, we can do a transconjunctival cryotherapy or a transscleral diathermy. And in the intraocular approach, we can do cyclopexy procedure can be done.
Okay, good. So
thank you,
about
Dr. Savitri, ma'am.
Yeah, okay. Thank you. Thank you, Dr. Shruti. Yeah.
Thank you, Dr. Himani. We'll move on to the next presenter, Dr. Sharada. She'll be presenting on retinal astrocytoma with retinitis pigmentosa. Over to you, Dr. Sharada. Dr. Sharada? Dr. Sharada, are you available?
Ma'am, yes, ma'am. My file is not supported, ma'am. 1 minute, ma'am. Will you please? Shall I log in one more phone and present, ma'am? 2 minutes.
Okay, in that case, we'll move on to the next presentation. Maybe after the next presentation, you can continue with this.
Yes.
The next speaker is Dr. Atira. Dr. Atira from Madurai Medical College, and she'll be presenting on vitreous amyloidosis. Over to you, Dr. Atira. Dr. Atira, are you there?
Yes, ma'am.
Oh, you can start your presentation.
Ma'am, is my screen visible, ma'am?
Not actually, not seen yet.
Hello, ma'am.
Yeah, are you able to load the presentation? Your screen is visible now. Yeah.
Okay, thank you. Am I audible, ma'am?
Yeah, you're audible. You can start.
Good morning, everyone. Today I'll be presenting a case report on a rare and interesting case of vitreous amyloidosis. So the case background, a 65-year-old male patient came to our OPD with complaints of defective vision in both his eyes for the past 8 months, which was more severe in left eye compared to his right eye. It was a gradual, painless, and progressive diminution of vision. He had no other significant ocular or systemic complaints, and he was not on any treatment for any other systemic conditions. On ocular examination, the uncorrected visual acuity of right eye was 6/60. The anterior segment examination was found to be normal, with a normal pupil reacting to both direct and indirect light reflex, and the lens showed immature cataract. And examination of left eye showed uncorrected visual acuity of 2/60 in left eye. The lids were normal, conjunctiva normal, cornea clear, anterior chamber normal depth, iris color and pattern was normal, and pupil was normal 3 mm round, reacting to both direct and indirect light reflex, and the lens showed an immature cataract. And a slit lamp examination following pupillary dilatation of right eye showed normal lids, normal conjunctiva, normal cornea, clear cornea, and anterior chamber depth was more than 1/4 of the peripheral corneal thickness. Iris color and pattern was normal, pupil was pharmacologically dilated, and lens showed grade 2 nuclear sclerosis with a central posterior subcapsular cataract. And examination of left eye showed normal lids, conjunctiva normal, cornea clear. The peripheral anterior chamber depth was more than 1/4 of the peripheral corneal thickness. Iris color and pattern was normal. Pupil was pharmacologically dilated. And lens showed a grade 2 nuclear sclerosis with central posterior subcapsular cataract. And there were white fringes or wisps of vitreous opacities seen adherent to the posterior lens capsule. So the left-hand side image shows the slit lamp image of left eye. You can see white
or on retroillumination, there are bright wisps or fringes of vitreous opacities, which were seen adherent to the posterior lens capsule, which are also known as foot plates. And on the right-hand side is the B-scan image of left eye. It shows glass wool opacities of mild to moderate echogenicity, which is seen separated from the retina, which is both these findings are typical of vitreous amyloidosis. A few clinical pearls. Ocular amyloidosis, it is characterized by deposition of hyaline extracellular material, which is a misfolded protein. It can be seen in any compartment of the eye from the and the ocular adnexa, including the extraocular muscles, even the lacrimal gland, the lids, conjunctiva, cornea, and including the vitreous body. So vitreous amyloidosis is confirmed by biopsy and a histopathological examination, which should demonstrate a positive Congo red staining. And as in our patient, the treatment of choice was vitrectomy, which can offer a significant improvement in vision, but there is a chance of recurrence. Thank you.
Thank you, Dr. Atira. Requesting Dr. Anupama Bappal ma'am to take over the discussion from here.
Well presented, Atira, and good morning to all. Atira, you have not made a note of the fundus examination. Did you make an attempt to look at the fundus?
Yes, ma'am, but the fundus view was obscured due to the vitreous, dense vitreous opacities, ma'am.
So that is in the left eye, right?
Yes, ma'am.
And what about the right eye?
Right eye fundus was normal. It was just hazy because of the nuclear sclerosis and posterior subcapsular cataract, ma'am. But the details made out were normal, ma'am.
Okay, so it was only in the left eye that you could see this
Yes,
vitreous opacities. And on retroillumination, the lens appears to be clear. Was there any posterior subcapsular cataract in the left eye?
Yes, ma'am. Left eye also it was there, ma'am.
Okay, fine. So amyloidosis is quite rare. What are the other differential diagnoses you can think of?
It can be an asteroid hyalosis, ma'am, dense asteroid hyalosis, or syncytial scintillans, or long-standing vitreous hemorrhage, ma'am.
Okay, so how would you differentiate it from vitreous hemorrhage, long-standing vitreous hemorrhage?
The B-scan image can show, in here it will be a glass wool opacities, it will be occupying whole of the vitreous area of the vitreous body, ma'am, and it will be mild to moderate echogenicity, ma'am, in case of...
Okay, apart from B-scan, clinically will you be able to differentiate it from vitreous hemorrhage?
The typical foot plate appearance or pseudopodia lens is seen attached to the posterior lens capsule is seen, ma'am, in this condition, ma'am, in vitreous amyloidosis, ma'am.
Okay, what are the features that you would see in vitreous hemorrhage?
It will be a hazy...
Is it a fresh vitreous hemorrhage, or would you want to...
No, ma'am, it will be usually a dehemoglobinized long-standing vitreous hemorrhage, ma'am.
Okay, okay, very good. So how would you differentiate it from asteroid hyalosis?
Asteroid hyalosis is usually it won't be vision threatening, ma'am, and there will be yellow to white oval opacities instead of these fringes like amyloidosis, and since they are calcium deposits on B-scan, it will be hyper reflective foci, ma'am.
And you have mentioned uncorrected visual acuity in the right eye to be 6/60. What is the reason for decreased vision in the right eye?
Right eye also had nuclear sclerosis and posterior subcapsular
cataract. And in the left eye, what is responsible?
Both the cataract and the vitreous amyloidosis, ma'am. Both can obscure the vision, ma'am.
Okay. So, are there any other ocular manifestations of amyloidosis apart from vitreous amyloidosis?
In this patient, there were no.
No. Otherwise, what else would you look for?
Okay, it can affect any of the structures, ma'am. If it is in the extraocular muscles, it can present with a mass lesion causing diplopia, ptosis, or extraocular movement restriction, ma'am. And in conjunctiva, it can present as abnormal conjunctival vessels or a diffuse mass in conjunctiva.
So, in conjunctival amyloidosis, what is the usual presentation?
Diffuse mass or yellowish mass will be
Anything
present.
Else they would present as? They present as recurrent subconjunctival hemorrhage. Okay, fine. What are the systemic associations and why it is important? You haven't mentioned about the systemic association, or have you worked up this patient for systemic association?
Yes, ma'am. We had done. It may be associated with polyneuropathy, ma'am, and the cardiomyopathy. In the absence of ischemia, we have.
Is it important to do a systemic evaluation in these patients?
Yes, ma'am. It is.
Why?
Vitreous amyloidosis can be sometimes it can be an initial presentation of systemic amyloidosis, ma'am. So we have to do the workup, ma'am, cardiac and neurological workup.
Yeah, you should do it because it is life-threatening. That is more important. Yes. Okay. So anything about tips about? I mean, how easy? I mean, have you done vitrectomy in this patient?
Yes, ma'am.
Okay. Then how did you do a Congo red staining also?
We have sent, ma'am, but the report.
Okay. How is it done? Do you know how this is done and what are the features?
In Congo red staining, it will be positive Congo red staining, ma'am, and the apple green bifringence will be seen in Polaroid microscopy, ma'am.
Okay, very good. So on vitrectomy, how easy or difficult? Yeah. Thank you very much. Yeah, thank you, Atira. It was a well done presentation.
Thank you.
Yeah, thank you.
Dr. Sharada, are you ready with your presentation? Dr. Sharada?
Now only I am correcting, ma'am. Shall I present one more present later?
Sure, okay. So
thank you.
The next presentation will be by Dr. Sujita. She'll be presenting on combined retinal vascular occlusion in acute myeloid leukemia. Dr. Sujita?
Yes, ma'am. Able to see my slide, ma'am?
Yes, we are able to see.
A very good morning to one and all. I am Dr. Sujita from Rajan Eye Care Hospital. My topic is on combined retinal vascular occlusion in acute myeloid leukemia. My mentor is Dr. Sujata Mohan, ma'am. Leukemia are a group of neoplasm arising due to malignant transformation of the blood-forming cells. Leukemic retinopathy occurs around 35.4% of the patients. It was first described by Liebrecht in 1861 as a proliferative and non-proliferative leukemic retinopathy. Retinal manifestation could be either due to indirect or the direct complications. Indirect are the most common and due to hematological abnormalities. That is leukostasis retinopathy. That is increased number of circulating platelets increases the blood viscosity, reduces the blood flow, thereby leading to the capillary dropout and mitoaneurysm formation, leading to proliferative retinopathy.
Dr. Sujita, yes, your slides are not moving.
I'll start from again, ma'am. Hello?
Yeah, you can start, please.
Yes. Leukemia are a group of neoplasm arising due to malignant transformation of the blood-forming cells. Leukemic retinopathy occurs around 35.4% of the patients. It was first described by Liebrecht in 1861 as a proliferative and non-proliferative leukemic retinopathy. Retinal manifestation could be either due to direct or the indirect complications. Indirect or the hematological abnormalities, that is leukostasis retinopathy, that is increasing number of platelets, increases the blood viscosity, reduces the blood flow and vascular stagnation, leading to the capillary dropout and mitoaneurysm formation, leading to proliferative retinopathy. And the direct is leukemic infiltration into the optic nerve and the retina and choroidal structures. Here we see a direct complication. A 45-year-old male presented with a sudden painless loss of vision right eye for the past 8 hours is a known case of acute myeloid leukemia currently in a remission period for more than 2 years and completed 8 cycles of chemotherapy. On examination, left eye was normal. Right eye perception of the light and projection of the rays. Anterior segment examination was normal except for the grade 3 relative afferent pupillary defect in the right eye. Fundus examination on day 1 initial presentation, right eye showed optic disc edema with a cattle tracking appearance and the cherry red spot mimicking a CRAO-like picture, and the left eye was normal. Patient has been started on intravenous methylprednisolone 3 days. After starting IVMP, the 3rd day, patient presented with multiple hemorrhages with the macular edema and the disc edema started resolving. The left eye was normal. This is due to after starting IVMP, the disc edema started resolving, the perfusion got improved and hence the artery occlusion started to resolve, but the perfusion for the vein did not improve and hence the vein occlusion started occurring. FFA was not possible due to the general condition of the patient. Optical coherence tomography showed hyperreflectivity of the inner retinal layers with the leukemic infiltration. MRI brain showed optic nerve infiltration with the leukemic infiltration. Patient has been referred back to the oncologist and confirmed the recurrence of the acute myeloid leukemia in a blast crisis with the CNS involvement and advised for palliative intrathecal chemotherapy and intravenous steroids for the optic nerve head decompression. Patient succumbed to AML before the intrathecal chemotherapy could be initiated. Take-home messages. Ocular involvement is the most common in leukemia and has been described up to 50%. So the diagnosis of the leukemia based on the ocular findings is life-saving as the survival rate is increased with the chemotherapy. Optic nerve involvement raises the suspicious for the CNS involvement. Hence, the earlier the diagnosis and the prompt referral is needed as the eye serves as a window for many of the systemic diseases. Thank you, ma'am.
Thank you. That was an excellent presentation. Now, you have said your patient in the right eye had RAPD.
Yes,
so, RAPD is something which we all kind of detected subjectively, isn't it? So,
yes,
is there a way of quantifying RAPD?
Yes, ma'am.
How would you do that?
We have to RAPD. We have to quantify with the filter.
How exactly do you do that?
Neutral density filter we have to trace, ma'am. We have to place the neutral density filter and we have to look for the pupil dilatation, ma'am. It measures in the log units, ma'am.
Okay. So, which eye would you do? The normal eye or the abnormal eye?
In the abnormal eye, ma'am.
Yeah, that is wrong. You should do it in front of the normal eye. Okay. Okay. Now, coming to the next point, your mechanism in this patient was leukostosis. Was it purely leukostasis, or do you think there are any other mechanisms which has caused the problem in your patient?
Mainly because of the director, ma'am, because when the presentation itself, patient had the MRI report which showed the optic nerve infiltration and the patient presented with the central retinal artery occlusion and with the disc edema. So we came to a conclusion it's a neuropathy because of the optic nerve compression, ma'am.
Okay. So, see, for us to say whether it is purely direct or it is indirect, we have to have certain clues. Like, I agree it is leukostasis, but you have not given the relevant information of how much is the hemoglobin, because anemia is yet another factor, and your total leukocyte count, that is important, and your platelet count. So these are three triads one must look for, and to say that whether we are dealing with purely leukostasis or anything else in addition. Mostly, yeah.
Patient had the reports, ma'am. His leukocytes reports were 1,69,000 and his platelets was 20,000, ma'am.
Okay. And what was the blast ratio for him? What was the blast?
It was 94%, ma'am. The blast cells were 94%.
So what is the cutoff for blast in acute myeloid leukemia? What is the safe cutoff? Is there a safe cutoff also?
Yes, ma'am. There is a safe cutoff for the blast, ma'am.
How much is it?
It's around 20%, ma'am.
Okay. So now coming to the next thing, what are the other commonest features of patients presenting with leukemia? What are the features in the postage segment?
A patient will have cottonelle spots, rot spot, any exudative detachment.
That's very nice. And what are the differentials? If you have a patient presenting to you with rot spots, yes, what would be your differentials?
Anemic retinopathy.
Yes.
Any cardiovascular diseases, ma'am. And blood viscosity syndromes like protein C, protein S deficiency, sickle cell anemia, ma'am.
Okay. So what is the pathogenesis behind rot spots?
There'll be a microaneurysm formation leading to the retinal capillary rupture, ma'am, leading to the intraretinal hemorrhage formation.
that is the mechanism in most of the leukemias. What are the other causes of rod spots? Because there are other mechanisms, because rod spots will not present only with a simple mechanism of the rupture, and there are other things also. What are the other mechanisms?
There will be a change in plasma viscosity, ma'am, leading to the thrombus formation, ma'am.
Yes, that is one. The other things?
There will be a coagulation of the fibrin ischemia formation will be there, ma'am.
Yes, very good. That's the coagulation and the ischemia, and the most importantly, the neoplastic cells itself. In your situation, the neoplastic cells.
Yes, ma'am.
Your patient did not survive. That is a very bad thing. But what if your patient had survived? How would you monitor your patient? What is the important risk this patient has if he survived?
Patient would have developed multiple bleeding hemorrhages spots, ma'am, in multiple organs, ma'am.
I'm talking about the ocular risk factors.
Patient would have developed a macular edema, ma'am.
Macular edema on a patient who had a central retinal artery occlusion?
Ma'am, we are exceeding the time limit, ma'am.
Yeah, thank you. That was a wonderful presentation. Thank you.
Thank you.
Thank you, Dr. Suchita. Thank you, Sugneshwari, ma'am. We'll move on to the next presenter now. Next presenter is Dr. Shastika from Mohan Kumara Mangalam Medical College, Salem. She is presenting on isolated ocular VKH syndrome, new perspective.
Good afternoon, Anand. Ma'am, is my screen is being shared, ma'am?
Not seen, not seen.
Now, ma'am?
Yeah. Listen.
Good morning to all gathered here. Isolated ocular Koyanagi-Harada disease from a new perspective by Dr. Shastika. VKH syndrome is still an enigmatic condition to most of the ophthalmologists as it affects all age group of 5 to 80 years. Women are more commonly affected. Red et al. He revised the new criteria as the old criteria was inadequate. The first complete VKH should have 5 criteria such as no history of penetrating ocular trauma or surgery preceding the initial onset of uveitis. There is no clinical or lab evidence suggestive of other ocular disease entities. Bilateral ocular involvement with early manifestation showing focal areas of subretinal fluid, bullous retinal detachment. Late manifestation shows ocular depigmentation, whereas the neurological and auditory findings shows meningismus, tinnitus, or CSF pleocytosis, and integumentary findings such as alopecia, poliosis, and vitiligo. So, in incomplete VKH, criteria 1 to 3 must be present, either 4 or 5 must be present. In probable VKH, it is an isolated ocular disease where criteria 1 to 3 alone must be present. On moving on to discussion, here we discuss about a case of a 24-year-old female who came with complaint of defective vision in both eyes for the past 1 month with right eye predominance and associated headache and swelling in front of the ear. So she had no history of weight loss or hair loss or hearing loss, no depigmentation of the skin, no history of fever, malaise, abdominal pain, neck ache or backache, no history of penetrating ocular trauma or surgery, or no other comorbidities. USG bilated parotid was done, which showed normal steady, and FNAC showed styloidinitis. USG abdomen showed mild hepatosplenomegaly, whereas the rheumatology opinion was obtained showing elevated ESR and RA factor was negative, and anti-histamine antibodies was positive, which suggested inflammatory polyarthritis. Echo was normal and other lumbar puncture was normal. So, on moving on to the ocular examination, her visual acuity was found to be right eye 2/60 and left eye 6/12, whereas the intraocular pressure of both the eyes were normal, and anti-segment was also normal. So, fundus examination, it showed both eyes media was clear, whereas disc found to be hyperemic, and macular, macular serous retinal detachment with choroidal folds was also seen in right eye, which is more predominant compared to the left eye. We can see the fundus autofluorescence. It showed macular hyperfluorescence in macula, and fundus fluorescent angiography was done. We can find an early irregular focal fluorescence of the choroidal circulation with various early pinpoint peripapillary hyperfluorescence at the level of retinal pigment epithelium, and we can also see the pooling of subretinal fluid. and optic nerve staining was also seen. So with all these features and as per the revised diagnostic criteria by Red et al., we concluded it as a case of isolated ocular probable Vogt-Koyanagi-Harada disease with acute manifestation. And as she was in the early uveitic phase, she was treated with 1 gram IV methylprednisolone for 3 days. Followed by tablet prednisolone 1 milligram per kg per day. With further dose tapering was also done. We can see within starting couple of days of methylprednisolone, her vision was drastically improved from right eye 2/60 to right eye 6/9 with pinhole 6/6, whereas the left eye also vision improved from 6/12 to 6/6. OCT was done, which showed if unless there was a gradual subretinal fluid absorption was also there. Now the patient is on oral maintenance dose of steroids. So with this, I conclude that early diagnosis and multidisciplinary approach, it helps us to understand and manage the complex disease. And the goal of treatment of VKH is to suppress the active ocular inflammation, and we can prevent the disease relapse, and we can also avoid the life-threatening complication. With aggressive corticosteroid therapy, we can preserve vision in the young patient, and we can also prevent the further recurrence. Thank you.
Thank you, Dr. Shastika. May I request Dr. Radha Annamalai ma'am to take over the discussion from here.
Presentation, Dr. Shastika. I just have a couple of things to ask you.
Yes,
so, based on the clinical features, is there anything else you need to have looked for in the anterior segment in a patient with VKH?
Ma'am, anterior uveitis, iris nodules, conjunctival lesions.
Is it important to record the intraocular pressures and look at the anterior chamber also in these patients? Is there a correlation?
Yes, ma'am. Because differential diagnosis we should rule out, ma'am, such as if it is having acute anterior uveitis or scleritis, it may be a uveal effusion syndrome.
Okay. So based on your macular edema itself, there is a differential diagnosis you can consider, right? If a patient has a bilateral exudative retinal detachment, what else is important to think of, especially in this age group?
Central serous corridor retinopathy or acute posterior multifocal placoid pigment epitheliopathy, ma'am.
And it's a good idea to think of posterior scleritis as well.
Yes, ma'am.
Okay. And also, so based on your patient, you said it's the first attack. So there are some predictors of recurrence, isn't it? You need to worry about recurrence. So
yes, ma'am.
What are the predictors of recurrence?
Ma'am, in FFA, if it is the early pinpoint peripapillary hyperfluorescence, it showed it is an acute early phase, ma'am. If it is absent, it is a sign she's a chronic and it is on chronic phase, ma'am.
No, I'm asking if you want to predict recurrence. What are the indicators that the VKH is likely, VKH uveitis is likely to recur?
Iris nodules or anterior uveitis will be there, ma'am.
Yeah, the presence of anterior chamber
anterior
reaction.
uveitis.
Anything else? It's important
sunset
to look for.
glow.
Sorry?
She will have depigmentations of choroid.
That's a late feature, no? Chronic. At the first presentation, if the patient has very poor visual acuity, like in your patient, visual acuity of 260, or if you have done a rapid tapering of steroids, okay?
Yes,
steroids alone may not be enough in all the patients. So you may have to, when you have poor prognostic indicators, it may be a good idea to follow up and start on
immunosuppressants.
Yeah.
Okay, ma'am.
So the other thing that, is there any other investigation that you could have done for your patient apart from FFA alone? I mean, FFA, yes, it is required, but anything else you could have done?
ICG, ma'am.
Okay, then anything else from the treatment perspective?
ERG, treatment perspective, we could have started
to assess for the extent of edema,
lumbar,
the amount of exudative retinal detachment. Anything else could have helped you?
USG, ma'am.
Yeah, USG, yes. USG will tell you about the presence of
diffuse choroidal thickening.
Yeah, but anything else to look for fluid? Something very specific to look for fluid. The height of
OCT.
Fluid. Yeah, it would have been
OCT
good.
was done, ma'am, which showed that repeat OCT was done, ma'am. After follow-up, it showed reduction in subretinal fluid was observed, ma'am. There was a gradual reduction.
Right, good. So if you
OCT was done, ma'am.
it would have been even better. Yeah. And
okay,
the other thing that I wanted to ask you is, in the history, is there anything you could have asked the patient? Basically, what is what is the pathogenesis of VKH? Is there some trigger to VKH?
Yes, ma'am. The trigger is associated autoimmune reaction.
Yeah, so what sets it off? VKH, we believe, is an abnormal response of the immune system to something. So
yes, ma'am. To tyrosinase and tyrosin-related proteins and melanocytes, ma'am.
Yeah, that is the pathogenesis, but usually it's a viral
HLA-DR.
Viral infection triggers off this abnormal immune
acute
response.
virus illness.
Okay, right. And another question is, what is the? We're out of time. Okay, thank you. Good
Thank you,
presentation.
Dr. Radhanamai, ma'am. Dr. Shastika.
Thank you, ma'am. Thank you, ma'am.
Yeah, now we'll move on to Dr. Sharada. Dr. Sharada, you're ready. And I request the presenters to keep your video on.
Shall I start, ma'am?
You can start.
Yes, ma'am. Good afternoon, ma'am. I am Sharada from Tirunelveli Medical College. Sorry for the technical error, ma'am. I am going to present a rare case report of retinal astrocytoma with retinitis pigmentosa patient. Background, retinal astrocytomas are benign glial cell tumors. It is typically diagnosed as an asymptomatic lesion in patients with tuberous sclerosis complex normally. Other associations of retinal astrocytic hematomas include neurofibromatosis, both 1 and 2, and retinitis pigmentosa, and Usher syndrome, and Stargardt's disease. Then case description. This is a rare case report of retinitis pigmentosa with retinal astrocytoma in a neurofibromatosis patient. A 38-year-old female patient who is a known case of neurofibromatosis type 2. She is presented with a history of defective vision in both eyes for the past 20 years. The defective vision was insidious onset and progressive, but not associated with pain, more for distant vision, more and during night time. And history of using spectacle for the past 20 years. And on ocular first general examination, neurofibromatosis nodules present all over the body. On ocular examination of right eye, vision 5/60, miscorrected visual acuity 6/18, lids neurofibromatosis nodules present, conjunctiva normal, cornea clear, anterior chamber is normal depth, iris normal color and pattern, no leash nodules, pupil 3 mm sluggishly reacting to light, and lens is clear. And left eye, vision 3/60, miscorrected visual acuity 6/36, lids neurofibromatosis nodules present, conjunctiva normal, cornea clear, anterior chamber normal depth, iris normal color and pattern, no leash nodules, and pupil 3 mm sluggishly reacting to both the direct and indirect light reflex, lens clear, and IOP is normal. Then fundus examination of right eye, media clear, disc temporal failure present, vessels arteriolar attenuation present, cup disc ratio was 0.4, and foveal reflex absent. Background retina shows bony speckles present in mid-peripheral region. Fundus examination of left eye, media clear, disc paler present, vessels arteriolar attenuation, cup disc ratio could not be assessed since the disc is pale, foveal reflex absent, and background 3x4 mulberry-like growth present just above the disc, and bony spicules present in the mid-peripheral region. Field both ways, tubular vision is present. And coming to clinical pulse, retinal astrocytic hematomas are asymptomatic and are stable with age. There are 3 types of retinal astrocytomas are there. Type 1, which are flat, smooth and non-calcified lesions, and type 2, they are raised multinodular mulberry-like calcified lesions present. Type 3, they are transitional lesion with having features of both type 1 and type 2. And treatment, mTOR inhibitors such as sirolimus, everolimus cause regression of retinal astrocytic hematomas. Thank you.
Thank you, Dr. Hannah, for the discussion.
Thank you, Dr. Sinisha. That was a good presentation of an unusual case with some very rare associations. Dr. Sharada, what were you more surprised to find in this neurofibromatosis patient? Retinal astrocytoma or retinitis pigmentosa?
Ma'am, in neurofibromatosis patient, retinal astrocytomas are commonly associated, ma'am. Specifically in neurofibromatosis type 2, ma'am.
Yes. So retinal hematomas are more common. Can you tell us the different types of retinal hematomas you can find in neurofibromatosis?
Yes, ma'am. Basically, there are 3 types are there, ma'am. Type 1 is flat and smooth, ma'am. They are non-calcified, ma'am. And type 2, it is some mulberry-like lesion, ma'am. They are rock hard in consistency, ma'am. And type 3, transitional lesion, but type 2 is more.
Yeah, not the types of retinal astrocytomas. Are there other hematomas you can expect to find?
Yes, ma'am. They are optic nerve gliomas, schwannomas, and meningiomas can be present, ma'am.
Any combined hematomas?
Combined hematomas of optic nerve glioma and meningioma. Combined.
Of retina and RPE. Did your patient have any history of blindness or night blindness?
Yes, ma'am. She has history of night blindness, ma'am, since 20 years of this age, ma'am.
Dr. Sharada, was there family history? Anyone in the family?
Yes, ma'am. Family history also there, ma'am. In his maternal side history is there, ma'am. But his daughter is screened, ma'am. She is not having now any retinitis pigmentosa changes, ma'am. Now time, ma'am.
So what do you know about the association between neurofibromatosis and retinitis pigmentosa?
Actually, retinal astrocytic hematomas can be associated with the neurofibromatosis and retinitis pigmentosa, ma'am. But it is very rare, ma'am. Actually, the incidence is only in NF2 patients. Retinal astrocytoma incidence is nearly 22%. It is given, ma'am.
So does your lady have low vision?
Yes, ma'am. She is myope, high myope, ma'am. 5/60 with minus 5 diopter spherical. She is improving to 618 in right eye, and minus 6 diopter spherical. She is improving to 636 in left eye, ma'am.
And she also has tubular fields.
Yes, ma'am. She has tubular
How do
fields,
you
ma'am.
visually rehabilitate this lady? What have you done for her?
Ma'am, I just counsel her, ma'am. She's her tubular vision will be maintained for this time. No visual prognosis. Not it won't good. I counsel her, ma'am. And the screening of that.
She may benefit from some low vision aids and field expanders. Did you do an OCT for this lady?
Yes, ma'am. I did, ma'am. But not.
What was the CMT, central macular thickness?
Central macular thickness is normal only, ma'am. It is somewhat 250 to 260 only, ma'am. Not increased CMT, ma'am.
What would you expect in a patient with retinal astrocytoma, central macular thickness?
Ma'am, in case of central macular thickness will be normal only in case of astrocytic hematoma. The tumor will be present in that site that some hyperdense lesion will be seen. Inside that some cystic spaces will be seen, ma'am. Due to that calcification, optically empty spaces will be seen in spectral domain OCT, ma'am.
Sorry, ma'am. We have exceeded the time limit, ma'am.
Okay. Thank you. Very nice case. Please write it up with the OCT. Thank you.
Thank you, Dr. Sharada. Thank you, Dr. Hassan. We can move on to the next speaker now. The next speaker is Dr. M.S. Joshmita from SRMC. She'll be speaking on vitreous pearls and waves.
Can you see my screen now?
Yeah, it's in.
Good morning to all the dignitaries and my colleagues present here. I'm Dr. Joshmita from Sri Ramchandra Institute of Higher Education and Research. My co-presenter is Dr. Sanjana under the guidance of Professor Dr. Radha Annamalai. I'm going to talk about vitreous pearls and waves. Coming to the background, neurocysticercosis is a parasitic infestation caused by Cysticercus cellulosae, a larval form of Taenia solium. Cysts called the cysticerci develop in the muscles, eye, brain, spinal cord, and is a common cause of epilepsy. Parasite reaches the posterior segment of the eye via the high flow choroidal circulation through the short ciliary arteries. Predilection to localize in the macula because it's the thinnest and most vascularized. The larva enters the macula and lodges in the subretinal space where it perforates and enters the vitreous cavity. The cysts and scolex show undulating movements. Severe inflammatory response is elicited due to the leakage of the toxins from the microperforations of the cyst wall. Coming to the clinical presentation of a patient, here is an 11-year-old male child who came with complaints of diminution of vision in the right eye, insidious in onset and progressive in nature since 2 weeks, associated with redness and floaters. He also complains of parieto-temporal headache since 2 weeks. Vision in the right eye was counting fingers close to face and the left eye was 6-6. Extraocular movements were full and free. The anterior segment examination of the right eye showed circumcorneal congestion, anterior chamber cells 2+ and flare. There was no hypopia noted. The posterior segment of the right eye showed multiple large cysts translucent with dense white spot formed by the invaginated scolex, showing typical undulating movements in the vitreous and subretinal. On further investigating the child, on A scan we found high amplitude spikes corresponding to the cyst wall and scolex was appreciated. On B scan we could see a well-defined cyst which were with a hyper-echoic scolex suggesting intravitreal cysticercosis and a complete PVD with RD. On MRI there were few ring-enhancing lesions with perilesional edema in bilateral parietal and left medial temporal lobe and the right lobe. So we had started the patient on eye drop homide, eye drop Predford, systemic prednisolone and albendazole, and then had planned for right eye pars plana vitrectomy. This is the sequence of events of vitrectomy. The sequelae of the infection, the ocular cysticercosis was treated and the patient was symptomatically better and the vision had improved. However, one of the cysts was buried subretinally and had become a retinal granulome. Ocular and orbital cysticercosis has varied presentation depending upon the site of involvement, the number of lesions and the host immune response. Pars plana vitrectomy is the safest and effective technique to remove the cyst by creating a retinotomy and bringing the cyst into the vitreous cavity. Small subretinal cysts can be removed by xenon or argon photocoagulation. We can remove them transcranially if it's anterior to the equator and transvitreally if it is posterior to the equator. Thank you.
Thank you, Dr. Joshmita. Requesting Dr. Rajkumari Madam to take over the discussion.
Yeah, it was a very good presentation, Doctor, and I should congratulate your mentor, Professor Radha Annamlai, also regarding this. Why do you call it as pearls and veils, Doctor?
Because we could see a scolex as a hyper reflective lesion, ma'am, and the cyst wall is encompassing it like a veil. So we thought it would be interesting to call it a pearl and a veil.
Pearl is, in fact, of course, when it is in the cystic form, it is veil. Pearls, and when it ruptures and produces an intense vitreous reaction, and when it heals, it forms severe scarring and fibrosis. So that's why when we call it as veils. Anyway, can you tell me what is teniasis? What is the uniqueness about this teniasis? Can you tell me what is, in fact, teniasis means what? It's an infection by, what are the
Taenia solium, ma'am. It's a cystode that Taenia solium.
Is it Taenia solium alone or
Taenia solium and Taenia saginata also, ma'am.
Anything else?
Pigs, it's called Taenia solium, and
recently they discovered another Taenia. Can you tell me?
Taenia asiatica, ma'am.
Very good. But what is the uniqueness of the solium than saginata?
It is usually transmitted by uncooked pork, ma'am, meat or unwashed vegetables. the larval form will be on it, and then when we are ingested, it will go into the intestine and then perforate the intestine and go into the circulation. Then through the circulation, it can get spread to the brain, muscles, then spinal cord.
Yeah, the same thing can happen to saginata also, uncooked beef or undercooked. But what is the uniqueness of solium? Why it is, in fact, it is said to be in WHO's classification, it's one of the most underdiagnosed. So much of health problems, burden, and underdiagnosed rather than saginata. Can you tell me? Yeah,
it will form a cysticerci and then
it has got more than saginata. This has got more wide damage spread involving the brain, mostly the brain, then your skin, muscles, and of course ocular. Can you tell me the percentage of ocular involvement?
Ocular involvement is mostly the posterior segment, ma'am. 80% of it affects the posterior segment, then the anterior. On whole, it is about 60% ocular involvement, ma'am.
Okay, what are the various stages of this cysticercus cellulose? Generally, what are the stages? What are the 3 stages?
We have the vesicular form, ma'am, where we can see the scolex and the cyst and the scolex, ma'am. Then we have the colloidal stage, where we can see the enhancement lesion and the edema. Then the nodular and the granular stage, where this enhancement is decreased and there will be mild calcification. Then the final is the calcific stage.
Suppose, please, others can you mute? Others, I want others to mute. I want to listen to what the presenter is telling. Suppose this patient, any patient who is coming in the colloidal stage, in ocular colloidal stage, what will be the clinical presentation?
We can, on fundus examination, we can see scolex with a
colloidal stage.
Yes, ma'am. We can see systemic features like epilepsy, ma'am.
Ocular, I'm talking of ocular. See, you told me 3 stages, no? One is the vesicular stage, where it will not produce much of reaction, no?
Yes,
when in the colloidal stage, what happens? The worm dies. That is, the larva dies and releases lot of inflammatory reaction. So that is the thing where what will be your ocular finding? If it is very severe inflammation, what will happen? The eye can become even. You told there was no hypopion in your case, no? There can be a hypopion, severe hypopion. It can lead to even phthisis also, no? Sometimes. So much. Yeah. Okay.
Thank you, ma'am. Thank you, Rajkumari, ma'am.
Okay, thank you.
Thank you, Dr. Joshmita. I congratulate all the presenters for the wonderful presentation. I also thank our judges and the panelists. Thank you, one and all. I now request Dr. Meena to take over. Over to Dr. Meena.
Am I audible right now? Am I audible to everybody?
No, ma'am, you're not audible. Could you ma'am? Okay, there is some problem with the network and from Dr. Meena's side, so I will be starting. First, I'd like to thank the organizers for this opportunity, and we will start with Dr. Veenashree's presentation. Dr. Veenashree is a senior cornea practitioner from Chennai, and she will be talking to us on choosing the right antibiotic in ocular infections. Dr. Veenashree, over to you.
சொல்லு.
Yeah, Dr. Veenashree, but your voice is a little less.
Am I audible right now?
Yeah.
Yes,
Meena,
I'm audible. I would just like to introduce Dr. Veenashree for the benefit of the audience. Dr. Veenashree is the medical director of Dhanvantri Eye Care. She completed her medical graduation from Madras Medical College, and she went on to complete her post-graduation from Shankar Nethralaya. She has a passion both for cornea and glaucoma, and she stood as the best outgoing fellow from L.V. Prasad Eye Institute, completing her cornea fellowship there. And she's been passionate about cornea ever since I have met her, and it's a pleasure to introduce her today for giving her talk on resistant to resistant. Thank you so much. Veenashree, you have to be a little louder.
Ma'am, we can't hear you, ma'am. It's very faint, actually.
I think there's some connectivity problem, Ramya. I had to restart and do it. Veenashree, you remove the speaker, I think the microphone, to speak directly.
Can you hear me now?
Yeah, very nice. Yes.
All right. Thanks, Dr. Meena, for the kind words. It has been a wonderful session from the morning with a lot of difficult and different cases. So my duty now to talk a little bit about choosing the right antibiotic in ocular infections. So why is it so difficult to make a choice to choose the right antibiotic? It is because the pathogen that causes the infection has a propensity to keep on changing geographically. The sensitivity pattern keeps changing temporarily, and resistance to the antibiotic drug keeps developing gradually over time. To understand how to choose the right antibiotic, we need to understand about the disease severity, and this in fact is an interplay of three factors: the susceptibility of the host, the potency of the pathogen, and the efficacy of the drug. These three factors, in fact, are linked by a triangular relationship. The pharmacokinetics links the response of the host and the drug, and the pharmacodynamics dictates the interaction between the drug and the pathogen. During the course of this discussion, we will consider three factors each separately: the host factors, pathogen factors, and the drug factors, which will help us understand and make the right choice of the antibiotic in a clinical scenario. The host factors: an intact globe that is protected by the ocular surface with its enzymes is usually resistant to infections. You definitely need a breach in the surface in the form of a trauma, a surgery, or an injection to result in infections. It is also important to understand the extent of the infection, whether is it an innocuous conjunctival infection to a site-threatening vitreous-involved endophthalmitis. Based on the extent of infection, one has to choose the route of administration of the drug. Most often, we use topical medications, which can be with or without preservatives. They can be fortified medications or those available off shelf. The indications for systemic medications in our scenario are usually limited, especially when there is perforation, progression of the infection rapidly to the limbus, or a vision-threatening endophthalmitis. Frequency of the dosing of the drug is determined by the pharmacokinetics and the pharmacodynamics of the drug. After understanding the host factors, we will look at the pathogen factors which help us to make the choice. It is important for us first to identify which is the probable pathogen causing the infection, what is the epidemiology and which pathogen is prevalent in our area of work. And we heavily depend upon periodic surveillance data by institutes and peer-reviewed literature to tell us about the susceptibility pattern of the antibiotics. And with this updating knowledge from time to time, as practitioners, we are able to practice evidence-based medicine. When ocular infections were looked at on the whole, this data, which came from New York School of Medicine, told us that in ocular infection, out of all the ocular isolates, Staph aureus constituted 23% of the infections and P. aeruginosa accounted for 37.7%. When they looked at corneal isolates alone, they identified that the vast majority was because of P. aeruginosa. If we look at the parallel trends from our own Indian subcontinent, this study, which came in the IJO February 2022, told us that Staph aureus was the commonest organism of both conjunctivitis and keratitis, and in keratitis, Pseudomonas ran a low third. The predisposition of Western literature towards P. aeruginosa is mostly because of their contact lens-induced trauma. Since keratitis is actually a flagship model to study antibiotic resistance and sensitivity patterns, we will look at more of the keratitis patterns in the discussion to follow. So in India, Sujata Das et al. Reported sensitivity patterns which they studied over 8 years in this study, which showed a gradual increase in the gram-positive organisms and a gradual decreasing trend of the gram-negative pathogens over time. If we look at further data from our subcontinent, looking across the institutes, we can see that gram-positive cocci are common across board, across all areas of study, and gram-negative bacilli is actually running a low second. If we subspeciate this infection and look, we found that the Madurai data has a propensity to have more streptococci, while the LVPI data had more propensity to have more Staph aureus, Staph species. The North India data had a propensity to have Pseudomonas infections. So after looking at the keratitis trends in India, we will consider points as to when empirical treatment can be tried at all. Most infections are bacterial. Most antibiotics available are bactericidal. And so majority of the infections heal without much microbiological support. Monotherapy can be tried for small central ulcers with the caution to have close follow-up and to be ready to refer if clinical worsening occurs. So what do you do when there is worsening? Microbiological support is sought for to look at the pathogen and also to look at the most susceptible antibiotic. Microbiology has taught us that gram-positive organisms are mostly susceptible to this group of drugs, starting from cefazolin going down to the 4th generation fluoroquinolones. The gram-negative ones again are susceptible, starting from tobramycin up to colistin, even in multi-drug resistant cases. So to confirm this data, LVPI looked at their susceptibility data and told us that gram-positive cocci were actually susceptible to cefazolin in 91.4% of the cases, and gram-negative bacilli were susceptible to ciprofloxacin in 86% of the cases. So what is the role of fortified medications then? Fortified medications are used in large ulcers when the infection is reaching the limbus, when there is a threat to perforation. While using fortified antibiotics, it is important to monitor surface toxicity of these drugs. After looking at the host and the pathogen factors, we now look at the drug factors which is going to influence our decision. Drug factors are dictated by the pharmacokinetics and the pharmacodynamics of the drug. Pharmacokinetics is actually host related and talks about the distribution and the intraocular penetration of the drug, while the pharmacodynamics is more drug related and tells us about the therapeutic effect that the drug produces. So based on the PK and the PD dynamics, we look at this triangle again, which tells us that the host drug interaction guided by the pharmacokinetics is actually responsible to tell us about the toxicity of the drug on the surface, and the pharmacodynamics tells us about the resistance patterns developing between the drug and the bacteria. Based on the pharmacokinetics and dynamics, we are able to generate some indicators which are based mainly on the concentration or time-dependent activity of the antibiotics. To elucidate this further, we take a model of fluoroquinolones when the concentration is plotted along the y-axis and the time duration after administration is plotted on the y-axis. And here we see that the Cmax is the point of maximum concentration of the drug reached inside the tissue at a particular time zone. This plots a graph called the area under the curve and generates a data called the minimum inhibitory concentration, about which we'll talk subsequently, and various indices are generated taking the ratio of the AUC and the Cmax, the AUC and the MIC, which tell us about how potent a drug is. So talking more about the minimum inhibitory concentration and the mutation prevention concentrations, which are of great importance in selecting a drug, the MIC, or the minimum inhibitory concentration, actually talks about the least concentration of a drug that kills a microbe in vitro. So looking again at this graph, which is plotting the concentration of the drug along one axis and the time along one axis, this actually is a cohort of pathogens containing susceptible and resistant organisms. When we plot a graph, at the points below the minimum inhibitory concentrations, the pathogens which are susceptible get killed by the bacteria, but still the first step mutation continues. Resistant pathogens still exist in this cohort. As and how we raise the concentration and reach within the minimum inhibitory concentration, the susceptible organisms get killed and the first step mutant organisms survive and mutate. Minimum inhibitory concentration indeed is not just a number, but it is a range of concentration across which the mutation selection window occurs, and in this window, selection, mutation and propagation of the resistant mutants keep happening. It is said, according to the pharmacokinetics of the drug, that to choose a drug, you have to choose it high above the minimum inhibitory concentration. To talk now about the mutation prevention concentration, if we look at this graph further, if we look at this data of the antibiotic concentration above this mutation prevention concentration, there are no organisms either susceptible or resistant available, indicating that everything has got killed by the antibiotic that is acting. So to explain this clinically, an example of fluoroquinolones was taken, which showed that as and how the concentration of the fluoroquinolones increased, it increased the propensity of the drug to kill more and more organisms. The dosing frequency and the concentration of the drugs increased the AUC by MIC ratio and made this drug more potent. Interestingly, it was also found that when preservatives were used along with the antibiotic, the strains of MRSA had lower MPCs and they had better propensity to act. So next, talking about drug resistance. What is resistance? Resistance is just the survival fight. It is the fight of the organism somehow to beat the onslaught of the antibiotic. Resistance mechanisms can be both genetic and mutation mediated. Fluoroquinolones, for example, have the higher fluoroquinolones acting against the topoisomerase and the DNA gyrase enzymes, while the first and the second generation fluoroquinolones act against the efflux pump mechanism, preventing the drug from entering inside the bacterial cell. The resistance patterns can happen because of transduction, conjugation, and transformation of the genetic material that is there within the cells by and large. So after understanding about the mechanism of resistance, this paper looked at increasing trends of staph epidermis resistance when identified from the conjunctival flora, as and how the fluoroquinolone concentration increased, the resistance of the S. epidermidis decreased. So why is there resistance? Ophthalmologists actually have this false sense of security and comfort that they are not actually contributing in any way to the indiscriminate systemic use and contributing in any way to the resistance. And this is actually being done by their physician and veterinary colleagues. This is not fully true because it has been proven by studies that overuse of topical medication, improper dosing of topical medications will also contribute a lot to the development of resistance. So once antibiotic resistance develops, it becomes the responsibility of the treating clinicians to monitor how this antibiotic resistance is progressing. Various surveillance activities have been set up which look at how the antibiotic resistance is progressing over time. These two studies, which were done in the Western world, are classic studies, the ARMOR study and the TRUST study, which are monitoring antibiotic resistance patterns across various species of microorganisms. In India, however, the surveillance is available only for systemic drugs, and we don't have it for ocular isolates as yet. So this was a very good study, which was done from 2009 to 2018, and it showed us that whenever Staph aureus was methicillin resistant, it would show multi-drug resistance too. It showed us that Strep pneumoniae was resistant to azithromycin, and its resistance was the highest. The ARMOR study showed us that resistance to one or more drugs is prevalent more among bacterial pathogens across time. So how does one combat antibiotic resistance? It is our responsibility to see that we use antibiotics only for bacterial infections. We don't use antibiotics in allergic or viral conjunctivitis indiscriminately, should not taper the use of antibiotics, finish the full course of the antibiotics once started, and do not prefer antibiotic-steroid combination as the tapering regime is not good for the antibiotics. Like we saw in the MIC graph, lower concentration of the antibiotic also predisposes to higher mutation of the pathogen. So this is a new term that has been coined about antibiotic stewardship. This tells us and makes us aware about our individual responsibilities at a national and a global level. It tells us how to promote appropriate antibiotic usage, how to administer antibiotics at the optimal dose and at the optimal duration. It also tells us to use combination therapy for improving the efficacy of the drug regimen. So what then is the ideal antibiotic? You would use an antibiotic which would have a faster action, as was shown by the pharmacokinetics of the drug. You would want to use a drug which has a stronger efficacy, like what was shown by the better tissue penetration and tissue concentration. You would use a drug which has a broader spectrum of activity, which is dictated by the susceptibility data across your region of practice. You would definitely have to use a drug which has a higher safety profile to prevent adverse reactions of the drug. You would like to use a drug which has a low resistance as dictated by the pharmacodynamics of the drug. Thank you for your attention. I thank WS for giving me this opportunity and Allergan for making me do this talk.
Thank you, Dr. Veenashri. I'm sure all the faculty and all the youngsters will now think twice before they prescribe an antibiotic. I'll request you to stay for the session as you're also part of the panel. I will just like to introduce the judges for this session of cornea and glaucoma: Dr. Meeta Joshi, Dr. Nidhi Gupta, and Dr. Uma Sridhar. And I'll ask my co-moderator now, Dr. Ramya, to take over for the session.
Thank you, ma'am. It's a pleasure to be here. And we welcome the judges and the panelists for today's session. The panelists are Dr. Chitra Ramamurthy, Dr. Subhashini, Dr. Pramila, Dr. Radhika Natarajan, Dr. Parvata Sundari, Dr. Mona Krona, and Dr. Veenashri. Welcome. And all the best to the speakers. We start with the first speaker, Dr. Madhumita from Agarwal's Eye Hospital. Repair of DMD, air is enough. Dr. Madhumita, you're on.
Yes, ma'am.
I'll be starting your time, doctor, for 4 minutes.
Okay, ma'am. My screen is visible, ma'am?
Yes.
Good afternoon, all dignitaries, my seniors and my colleagues. Myself, Dr. Madhumita Prasad from Dr. Agarwal's Eye Hospital and Research Center, Chennai. My mentor is Dr. Preeti ma'am. My topic for today is repair of DMD. The air is enough. As we know, Descemet's membrane detachment is relatively common after cataract surgery, and most do not have any doesn't require any treatment. However, if larger DMDs
Are you in full screen mode? Yes.
Ma'am, actually the side view is hiding, ma'am.
You can minimize that.
Yes, ma'am.
There's a minus sign, no?
Yeah. So spontaneous reattachment of the Descemet's membrane with conservative management may occur in many cases with small peripheral planar DMD with non-scrolled edges. However, cases with non-planar central DMDs, scrolled edges and length more than 2 millimeters have to be managed surgically. So in these cases, descemetopexy is the gold standard for the management of DM detachments. However, other management options include suture fixation of the DMs, descemetopexy and keratoplasty. Prompt diagnosis and timely management often leads to a good visual outcome. So my case report is a 62-year-old female patient came to the cornea OPD with complaints of reduced visual acuity. She underwent phacoemulsification with IOL implantation in the right eye in our hospital 2 weeks back. She was using topical steroids, antibiotics, and she was also started on sodium chloride, that is hypersol eye drops. Her preoperative specular count was 2180 cells per millimeter square. On examination, the best visual acuity was counting fingers 3 meters and the intraocular pressure with NCT was 10 millimeter of mercury. Her left eye was pseudophakic, ma'am. On slit lamp examination, the diffuse corneal edema with striate keratopathy in quill-like pattern was noted and DMD was also observed, but extent was not seen. On ASOCT, MS39, it was helpful in confirming the extent of the DM detachment. It revealed extensive DM detachment. Since the DMD was large and non-planar and visual impairment was severe, we opted for surgical intervention and she was treated with intracameral air injection. The patient was maintained in the supine position after the procedure for 1 hour, ma'am. So on slit lamp examination, this is a clinical photograph of the patient of the right eye, ma'am. Here we can see the striate keratopathy with diffuse edema in a quill-like pattern and the Descemet's fold also seen. The IL reflex can be seen. On ASOCT, we can see the extensive Descemet's detachment. This was taken in the temporal part of the eye. After the air injection, ma'am, intracameral air injection post of day 1, we can see 80% air injection in the anterior chamber, ma'am. And on the same day, ASOCT was taken, and we can see the DM which is attached properly, ma'am. On post air injection day 5, her visual acuity improved to 20/40. With pinhole, it was 20/20. And this is the other case which was referred from the branch. It also had a same situation with extensive Descemet's membrane detachment. And it also had as we can see, different ports are present, ma'am, because in this air pump was also used because Descemet's membrane was scrolled. So ma'am used a Regosinski also to iron the Descemet's membrane with the help of air pump inserted, and then we injected air, and subsequently the ASOCT was taken, which showed and the DM was attached. So the main clinical pearls here are the predisposing factors for DMD can be while introducing instruments into the eye, or when hydrating if the patient is having dense arcus or shagreen with endothelial diseases like Fuchs' corneal dystrophy and advanced age of the patient. So preventing DM detachment and during surgery, do not use blunt instruments to make corneal incisions, and we should not make an incision in a hypertonic eye. And for the treatment of Descemet's membrane detachment, the injection of air, expandable gases in the anterior chamber, and suturing the DM to the stroma can be an option. However, expandable gases also
The time is
causes
up, doctor.
raised IOP or okay, ma'am. Thank you, ma'am.
Invite Dr. Chitra for being a panel for this case. Thank you, ma'am.
Congratulations, Madhumita, for a very nice presentation. Why was it in the first instance there were sutures placed on the side ports? You all do routinely put sutures, side port and main port? I mean, it doesn't.
After post ear injection, we suture all the ports.
It was pre-op, no?
Okay. In the pre-op also.
Okay, that doesn't matter. Actually,
Ma'am,
they
must actually we do not put any suture.
Yeah. Okay, so it has been a well discussed case and shown well, and prompt treatment has been taken. As she very beautifully explained that DM detachment occurs essentially in certain eyes which have some amount of endothelial disease, and they say even dense arcus and some Sjagren disease, and eyes which have a peripheral thickening are prone to it, but corneas. But more importantly, it is seen that if you're using a blunt instrument, so you're actually tenting up or using a loose sleeve, you tent up the area of the DM and then create the detachment. So it's very important, as she beautifully said, we should not be making an incision in a shallow anterior chamber or in a hypotonous eye. And it's also important, as she said, that we need to take a port right in before you open up the infusion. Even hydrating the sign foods, you need to ensure that the needle is hugging the wound, the side wound against the stroma and not entering through the port, because even fluid going in like that can open up a small DM which has got initiated. So there are many reasons, and again, in these cases, when there's so much of visibility issues, of course, here you could even use hypertonic saline or oral glycerol. Very rarely, I suppose, you may have to scrape the epithelium, but again, invariably, I think air is a solution. In the way you need to inject the air opposite to the area of the DM detachment and ensure that you have a 3/4 fill. I think role of non-expansile gases are very minimal, largely for maybe a recurrent detachment, because injection of air should suffice largely, and that too you should use a 14% C3F8 gas in those situations. And planar flaps all do well. Even a superior DM detachments do well. And of course, if there are tears, we need to be immediate intervention is mandatory. And of course, there is also sometimes these detached areas can get fibrous. So you could have a late detachment. So whenever there's an unexplained corneal edema, we need to get cautious. And sometimes you may not be able to differentiate, then you actually need to examine it in a dilated pupil and do a retroillumination and go about it, and very rarely suturing. And of course, it makes sense to suture up all the ports once you have injected the air bubble. I think nearly all of it, she has said it, and I think I just further enlarged upon it. And the results are so dramatic, and they do so well the very next day and within a week or so. Yes. Anything else?
Yes, I think we are done with this case, Dr. Chitra. We will go on to the second case. Dr. Ramya, can you just introduce?
Yes, ma'am. So the next case is by Dr. Namita Mohan. She's going to speak to us on anterior segment complications in sutureless vitrectomy with silicone oil from Rajan Eye Care. Dr. Namita, you're up.
Yes, ma'am. My screen is visible, right?
You've started screen. Yeah, now it's visible.
Okay,
you can just go to the full screen mode and you can start.
So good afternoon to one and all. I'm myself Dr. Namita Mohan from Rajan Eye Care. My mentors Dr. Suchata Mohan and Dr. Aarti. So I'm here to present a unique case of anterior segment complication in sutureless vitrectomy with silicone oil. So the background, as we know, the silicone oil has been successfully used by the retinal surgeons as a tamponade agent. In spite of its merits, it is also known to cause some complications, including both anterior and posterior segment manifestations. One of the anterior segment complications is the migration of silicone oil into the subconjunctival space, leading to various ocular surface disturbances, including Dellen formation. So Dellen, which was first described by Ernst Fuchs in 1911 as a saucer-like excavations at the corneal margin with intact epithelium and thinned out stroma. So here we gonna present a case of corneal Dellen secondary to subconjunctival silicone oil granuloma following microincision vitrectomy.
So my case is a 52-year-old male presented to us with pain, redness, photophobia, and watering in the right
Dr.
eye.
Namita, can you put it in the full screen? Like, can you put the PowerPoint presentation mode? Because I can only see the first slide.
Slides are not moving. Okay, ma'am.
The slides are not moving. It's still on the title slide.
Yeah.
Put it in full screen.
Yeah. I mean, put it on full slideshow.
This is
No. You
Slideshow. You should go to slideshow, bottom to the right corner. You can see a button called slideshow. Yeah, that one. Click that. Or you can go to the top. There's slideshow and just click that and say start show.
Or you have to keep sliding each slide. I mean, be conscious when you're talking if you're not able to do the slideshow.
Yeah, ma'am, it's not moving in when I keep it in slideshow mode, ma'am.
So then why don't you just click on each slide as you talk?
Yes.
Okay, so you can continue that way.
Okay, I'll start with case discussion, ma'am.
Yeah.
I'm just going to retime you for an extra 1 minute, doctor. Okay? Yeah.
Okay, ma'am. Thank you. A 52-year-old male presented to us with pain, redness, photophobia, and watering in the right eye for the past 1 week. He's not diabetic or hypertensive. He had a past history of past plantar vitrectomy surgery done with silicone oil injection for the pseudophakic retinal detachment, which was done 3 months back. On examination, his best corrected visual acuity in the right eye was 660 and in the left eye 69. On slit lamp examination, it showed multiple cystic transparent elevated lesions on the bulbar conjunctiva close to the temporal limbus and pseudophakic in the right eye and left eye was within normal limits. So in the right eye, the lesions was suggestive of subconjunctival silicone oil induced granuloma, and the corresponding area of the cornea, which is close to the silicone oil, revealed a Dellen of 6 × 3 mm size with a deep-seated, well-circumscribed infiltrate measuring about 3 × 4 mm size. Fundus examination showed silicone oil filled right eye and retina was on, and in left eye it was normal. So the poor ocular surface lubrications causing mucus layer instability in the tear film secondary to the raised paralimbal elevation had resulted in the Dellen with a secondary infection. So this is the picture showing the subconjunctival silicone oil with that Dellen close to it and an infiltrate over the Dellen. And ASOCT picture of the same area showed a thinned out cornea, and there is a silicone oil lump close to that thinned out cornea. So treatment, actually we have started with aggressive lubrication every 1 hourly, and also we have started on antibiotics. So this is the pre-treatment photo, and after 1 week of antibiotic instillation, the infiltrate has reduced completely. And after 1 week of the antibiotic treatment, we have excised the silicone oil granuloma with tissue adhesive application, that is cyanoacrylated glue over the Dellen, and the bandage contact lens was placed. On the histopathology examination of the excised tissue, it revealed a multiple lipid droplets which are silicone oil material and surrounded by foreign body giant cells, which tells that it is an inflammatory condition. On post-operative visits, he was doing well. So the take-home messages are silicone oil in the subconjunctival space presents mainly as a cosmetic issue, but might lead to severe complications also. So avoiding silicone oil in the subconjunctival space requires a good scleral closure with suturing or with the use of a small gauge vitrectomy needle. Tear film instability following the formation of granuloma should be treated carefully to avoid Dellen formation and subsequent corneal ulcer and perforation. Thank you.
Should I take over?
Yes, Dr. Chitra, you're the panel for this.
Yes, she's done. Thank you, ma'am.
That's a very, very interesting, nice case. And I don't think it's a very common incidence now with the use of small gauge vitrectomies. Because that indicates the need of ensuring that all these ports are well sutured. So this was a case which happened at your hospital, or it was a patient who came from elsewhere?
It happened in our hospital, ma'am.
Okay, then you must have used a small gauge vitrectomy only, no? Needle only, no?
Yeah, yes, ma'am. 25 gauge.
25 gauge, yeah. So I suppose what you all did was the best way of managing with this kind of a tear film instability and that infiltrate which occurred. But just generally discussing it, I think it's not a a common occurrence at all. And the take-home message is, if it is just very small, localized, a diffuse kind of infiltration in the subconjunctival space, you could even conservatively observe these eyes and not treat them unless it progresses on to become a Dellen and the architectural change occurs that it becomes a granuloma, when you need to do all that we have done. So I think the only important message here is that we need to suture up all the ports so that this occurrence does not happen. I don't think there's much more to add to it, and a very well managed case. Thank you.
Thank you, ma'am. Thank you. So we can move on to the next case by Dr. Yes, ma'am.
And yes, thanks so much for obliging me when I made such a last minute request. I need to go and join for my webinar shortly. Thank you very much. Very impressed.
Thank you so much for being here, ma'am.
What's going on? Thank you.
So the third presentation for today is by Dr. Shweta Ravichandran, a case of fungal corneal ulcer. Dr. Shweta, are you here?
Yes, ma'am. Ma'am, am I audible, ma'am?
You're
Yes,
audible.
you're audible.
Please share your screen. And the panelist for this is Dr. Radhika Natarajan.
Ma'am, is my screen visible, ma'am?
Not yet. Could you share your screen?
Yeah.
Shall I start presenting, ma'am?
Yeah, your time starts now, ma'am. It's for 4 minutes.
Yes, ma'am. So good morning to one and all present here, my respected seniors, for giving me this golden opportunity. So myself, Dr. Shweta Ravichandran, and my mentor is Dr. Preeti Naveen Madam from Dr. Agarwal's Eye Hospital and Research Center, Chennai. So the topic by case will be a case of a fungal corneal ulcer, a color of suspicion. So moving on to the introduction of background, fungal keratitis is a serious ocular infection.
Is your slide moving, doctor? The slide is moving. Have you gone to the next slide?
Yes, ma'am.
It's still showing the first slide. Yeah. Yes.
Is it okay, ma'am?
Yes, yes.
Fungal keratitis is a serious ocular infection with potentially catastrophic visual results. It's caused by many species of fungi capable of colonizing the human tissue. It occurs worldwide and its incidence is increasing in frequency. Most commonly includes Fusarium, Aspergillus, and Candida. Symptoms include the eye pain, redness, blurred vision, sensitivity of light, excessive tearing, and eye discharge. And patients who are more prone will be who had a recent eye trauma, and particularly with the thorns in the sticks and the underlying eye disease, weakened immune system, and contact lens. So dermatitious fungal keratitis presents typically as pigmented plaques that prevent the penetration of the drugs. So the infection mainly starts when the epithelial integrity is broken due to a trauma, the ocular surface infection. So this fungal keratitis will poorly, actually doesn't respond much faster to the antifungal medicine. So they most frequently they need a surgical intervention. So moving on to my case, Mr. Krishnan, 43-year-old gentleman from Kanchipuram.
Slides are not moving, ma. It's still in the background slide. Yes.
Could you go to the slideshow, because we are seeing the panel also.
Ma'am, I'm already in the slideshow, ma'am. Put it in the slideshow only, ma'am.
Maybe double click and see. Yes, next slide. This is second slide.
Ma'am, now, ma'am.
You're in the second slide. Yes. After background.
I'm now moving on to case presentation, ma'am.
Yeah, you're on the case presentation slide. Please carry on.
Yes, ma'am. Mr. Krishnan, a 43-year-old male from Kanchipuram, who's a known diabetic for the past 3 years on treatment, came to our hospital on May 5th, 2022 with chief complaints of blurring and diminution of the vision in the left eye for the past 2 weeks. Patient had pain and redness in the left eye since 2 weeks, and dust contact he had 2 weeks back, and itching in the left eye. Moving on to the history of present illness, patient developed all these symptoms and signs of redness and irritation following the dust contact. He had a pain which was sudden in onset and pricking type, no aggravating and relieving factors. Patient is a chronic smoker for the past 10 years. On ocular examination, visual acuity in the left eye was uncorrected visual acuity was hand movements, and digital tension was normal, and conjunctiva circle corneal condition was present with mucoid discharge. Anterior chamber flare 3+ was present, and droplast was negative, and corneal sensations were diminished. And on examination of the anterior segment with the slit lamp, showed an 18 to 8 millimeter ring-shaped infiltrate with the feathery margins with a brown pigmented corneal infiltrate in the center, and a 2 mm hypopyon was present, which was a thick hypopyon and it was immobile. So we actually the patient was already treated in the peripheral center for 2 weeks, and he was already on topical antifungals for which he was not responding, and the ulcer seemed to be progressive, so he was referred to a tertiary center. So once the patient has come, we didn't want to delay, so we did a corneal scraping and we sent it for an microscopic examination as well as for an culture. So this is the lactophenol cotton blue, the first slide. So this is going to show the sporangiospores, which is going to be suggestive of an
Doctor, you are still on the previous slide.
Ma'am, the slides are actually...
Yeah, now it's fine.
Ma'am, is it visible now, ma'am?
Yes, yes.
The
Yes,
lactophenol cotton blue. So these are going to be the primary spreading matter which is surrounded by the sporangiospores, which is suggestive of Aspergillus niger. The STA agar, which is showing the powder pepper colonies, which is powdery in its consistency, and the KOH mount showing the fungal hyphae. So this is, since it was a pigmented, we thought of a dermatitious fungi, but it turned out to be an Aspergillus niger. So whenever we see a pigmented ulcer, we have to have a differential diagnosis of both. So if it's going to be an dermatitious, the lactophenol, on the SDA agar, the colonies will be very hard. So the management part, ma'am, is the next slide visible, ma'am? Management.
I suggest you move the slide and then talk. Yes. Yes.
Yes, ma'am.
Yeah.
So
Yes,
now
now it's
moving on to the management. So since the patient was already treated 2 weeks outside, so we didn't want to delay. So he was already on topical natamycin eye drops 5%. Hourly he was using, and homemade eye drops for 3 times a day in its left eye. And so we started on the patient with oral. So we we didn't give any drug holiday. So we just started the patient we just gave the scraping, and we didn't want to wait for much delay should not be given. So we just started the patient on oral antifungals. So we started the patient on tablet ketoconazole 200 milligrams and oriconazole eye drops for 1 week hourly. So following which the 2 weeks also the patient does not respond well to this treatment, and we felt that the ulcer was progressing than what he was initially presenting. So we put the patient for an therapeutic penetrating keratoplasty, and patient was doing well for 3 weeks in the post-operative period, and the patient showed a graft failure in the 4th week of the post-operative period. So moving on to my clinical pearls. So Aspergillus keratitis frequently occurs following the traumatic inoculation of the Aspergillus conidia into the cornea through the injury. So it's not responsive and mostly refractive to the medical therapy. So patient usually needs some therapeutic penetrating keratoplasty. Keratomycotic malignant glaucoma in which the HC will be uniformly shallow is the most common, it's not more common, it's a complication of Aspergillus keratitis. Clinical improvement occurs very slowly, so the patient will need a prolonged treatment with the antifungals. Pigmented corneal ulcer, whenever we see in the OPD, should arise as a suspicion of dermatitious fungal keratitis and Aspergillus niger, and bipolaris.
Your time is up, doctor. Yeah.
Yes, ma'am. And also they exhibit dichotomous branching whenever we see an dermatitious fungi. Thank you, ma'am.
Yes. Dr. Radhika.
Thank you. Now we call upon Dr. Radhika, who's a panelist for this particular talk, to ask any questions set.
Thanks, Ramya and Meena. That was a very nice case, Dr. Shweta. Before we even go to the discussion, I want to gently point out 2 things. You have presented a wonderful case with a lot of learning points. If you're competing for a prize, you must ensure that the patient name is never there in the presentation. Okay, so that is not done because we are not supposed to disclose the identity of the patient. whenever you're using any, don't use stock internet pictures unnecessarily. There's no need to demonstrate somebody putting eye drops and all that. And if you do, you need to mention that you've taken it from the net, because these things distract from the core of the presentation while somebody is judging it. Anyway, that was just some points for you to remember for the future. So, what do you mean by demeticious fungus?
Demeticious
qualifies a fungus as demeticious?
Demeticious fungi or a group of fungi, they include the Curvilinia type of species, ma'am. They are usually pigmented and they contain the melanin in their cell wall, and they usually
So that's all I wanted. You answer to the point so that we can ask you more questions to earn you more marks. Okay. So they produce pigment, and the pigment is melanin. Okay. And you already started giving me some examples, but how common is demeticious fungal infection? Is it common or rare? And name a few organisms which produce this kind of infection.
Ma'am, demeticious fungi is not as common as the other fungal infections, ma'am. It's quite uncommon. And the other things that produces the such type of pigmented will be the Bacillus havaensis. It's also a type of the hypomycete type of fungal infection.
Name a few types of demeticious fungi.
Ma'am, Curvilinia.
Correct. Anything else? Alternaria, bipolars, you already
bipolaris,
Cladosporium, Cladorhinum, these are all some of the demeticious fungi. So clinically, what is the difference between demeticious fungal ulcer and non-pigmented fungal ulcer? Very broadly speaking.
Ma'am, demeticious ulcer, mainly they have a typical blackish brown pigment, ma'am, in the infiltrate, whereas the non-pigmented ulcer won't be having a much of this pigmentation won't be
the clinical course, Dr. Shweta, you have already mentioned the clinical description in your presentation. How about the course of the ulcer between the two sets of organisms?
Ma'am, demeticious ulcer doesn't respond much well to the topicals, ma'am. So mostly we start the patient on systemic and
okay.
And
systemic, I would decide not based on whether it is demeticious or not. I would decide based on the depth of involvement, presence of endoexudates and hypopyon, which is when the organism will be affected by the systemic antibiotic. A superficial infection, whether it is demeticious or non-demeticious, the systemic antibiotic will not affect it. So I think you made a point that it is a kind of a chronic infection. Correct? Yes, chronic indolent kind of infection as opposed to fulminant infection, which can sometimes be set up by other fungi. Microbiologically, what is the difference? This organism also produces pigment, and the Aspergillus niger that you showed, and the demeticious fungi also produce pigment. So microbiologically, can you distinguish one from the other? Are all pigment producers termed as demeticious fungi?
Ma'am, actually on this lactophenol, when we saw that this Aspergillus will be producing this stigmata and the sporangiospores, ma'am, whereas the demeticious will be producing the conidia, and the conidiospores are more characteristic of demeticious, ma'am. And also the colonies on the STA agar will be very hard and blackish for a demeticious, whereas it will be powdery and peppery consistency in an Aspergillus niger.
Anything about the pigment itself? Where is the pigment present in either of the two? The pigment in demeticious fungus is within the cell, whereas the pigment in Aspergillus niger comes because of the circumstance in which it produces the infection, and it is usually outside the cell. So that seems to be also one distinguishing factor. But you brought upon one important point that we
come to the end of this
we should not just focus on the pigment, but the appearance of the hyphae and the conidia are also widely different between the two sets of organisms. Well done, Dr. Shweta.
Thank you so much, Dr. Radhika.
Thank you, ma'am. So we move on to the next speaker, Dr. Jagdishwari from JIPMA. She's going to talk to us on HSV keratitis in a renal transplant patient. Dr. Jagdishwari.
The screen sharing is on, so I cannot share my screen.
Sorry?
Yeah, she wants the previous speaker to stop sharing.
Okay.
Dr.
Dr. Shweta, can you stop sharing your screen, please?
Dr. Shweta?
Dr. Shweta?
Yeah, you have to call her, I think.
Yes, I will do it.
Yeah. Dr. Jagdishwari? I'll be starting your time from your first slide, Doctor.
Good afternoon, all. I am Dr. Jagdishwari from JIPMA. My mentor is Dr. Geeta Begramlal from JIPMA. I'll be presenting on a case of HSV keratitis in a renal transplant patient. Renal transplant patients have high risk of infections due to lifelong immunosuppression. Herpetic keratitis in these patients are rarely reported and they have an atypical presentation, and these patients may require prolonged systemic and topical antivirals, and they may also end up in having corneal scarring. Usually these keratitis will subside on withholding of axillary immunosuppressive drugs in these patients. The available case reports of herpetic keratitis in renal transplant patients are very old, where the immunosuppressions used were prednisolone, azathioprine and cyclosporin, and antivirals used were edoxyridine, acyclovir. Coming to our case, this is a case of a 45-year-old woman who was referred to us with redness, watering, and photophobia of the right eye for 2 days. She was a known case of chronic renal disease who had underwent a renal transplant 8 months back, and she was currently admitted that time with the signs of acute graft rejection, and she has been initiated on systemic immunosuppression with plasma exchange and intravenous immunoglobulins. Exactly 10 days after the initiation of systemic immunosuppression, she presented to us with these symptoms. She is a case of hypothyroid, hypertensive, fibroid uterus, and diabetes mellitus. She had underwent a renal transplant 8 months back, and she was on basic immunosuppression of tacrolimus, mycophenolate mofetil, and prednisolone. Post-transplant, she has developed diabetes mellitus, and she also had pheohypomycosis of the left ankle. And 6 months later, she had severe anemia, for which she received treatment with blood Paxil transfusion, and bone marrow biopsy showed she had a parvovirus-induced pure red cell aplasia. And 6 months later, she developed COVID pneumonia with pulmonary tuberculosis, and she was started on anti-tuberculous treatment. When she presented to us, she was on the 4th month of anti-tuberculous. In September 2021, she presented with the signs of acute graft rejection. Coming to the ocular examination of a right eye, her best corrected visual acuity was 6/12. Her extraocular movements were full and free in all directions. Her conjunctiva was showing congestion with white patches over the limbus, and her cornea was showing linear dendritic pattern with linear branching with terminal bulbs, and her corneal sensations were reduced. Coming to the left eye examination, her best corrected visual acuity was 6/9. Her conjunctiva was normal. Her cornea was clear, and her corneal sensation was intact in the left eye. Coming to both eyes, her anterior chamber depth was normal and it was quiet, and pupils were round and regular. Direct and consensual reactions were brisk, and lens was showing nuclear sclerosis grade 2 cataract, and fundus was showing both mild non-proliferative diabetic retinopathy changes. So this is the picture showing the right eye, which has a dendritic ulcer with the white patches over the limbus in the inferior 3 to 8 clock hours. She was started on topical ganciclovir 0.15% eye ointment 5 times a day, and refresh tears eye drops Q1 hourly, and moxifloxacin eye ointment 3 times a day. And she continued with the systemic management of intravenous immunoglobulins 6 cycles and plasma exchange. After 1 week, her lesions were healed after 1 week of topical antiviral treatment. So learning points from these cases: viral hepatitis may present in post-renal transplant patients who are on immunosuppression and with minimal symptoms, making the early detection very difficult. Clinically, these patients will have very mild conjunctival hyperemia, but they may have extensive herpetic dendritic lesions involving the limbal cornea. Rapid progression to stromal involvement may necessitate prolonged antiviral therapy and subsequent corneal scarring. So ophthalmology referral with high index of suspicion and institution of early treatment may be crucial in preventing vision impairing sequelae in these immunosuppressive patients. Thank you.
Very good, doctor. You stuck to your time. Very nice. Dr. Veenashri is your panelist.
Can you hear me?
Yes, ma'am.
Yeah, that was a nice presentation, doctor. So I want to know, in your patient, can you hear me?
Yes, ma'am, I can
Yes,
hear.
ma'am. Yes, Veenashri.
Yeah. Suppose the stromal involvement had progressed further, what would you have done in this patient?
In this patient, if there is a stromal involvement, I would have started on topical steroids along with the under the cover of antivirals. And since it's a immunosuppressive patient, I would also consider starting on oral acyclovir for this patient.
This is a renal transplant patient, and we know that antivirals are all nephrotoxic.
Yes.
So what would you do in this case? What options would you have, and how would you look at these options? In this patient, you had given ganciclovir, isn't it?
Topical ganciclovir.
Yeah.
She was already on immunosuppressive.
Yeah, but your point that you were going to use oral antivirals in the setting of a patient who had already a compromised renal status.
Yes.
So would there be any other drugs, anything else that would you have to do in these patients?
We can renal dose adjusted or neuro.
I think in these cases you have to use drugs, prodrugs like malacyclovir. Yeah, which are better, and this you definitely have to do it with a renal opinion and nephrologist consent. The next point is what other organisms would you think this patient could be bothered by?
Mostly post-renal transplant patients will have a high risk of any opportunistic infections with the CMV and Cryptococcus and Candidiasis.
So serial follow-up.
Even sorry.
Serial follow-up is important. You would also have to keep looking if VZV also can get activated.
Varicella zoster, doctor.
No, sorry, I couldn't. Varicella zoster, and they also prone for other infections, other herpes infections, and CMV Epstein-Barr virus, and varicella zoster, and even hepatitis, are the most common post-renal transplant infections.
Okay. Very rare case, though.
Thank you.
Should we go on to the next case?
Yes, ma'am.
Any more questions, Dr. Veenashri?
No, nothing from my side.
Oh. You can stop sharing your presentation, doctor.
Yes, ma'am.
The next presenter is Dr. S. Neela Priyadarshini from Meenakshi Medical College, Kanchipuram. Are you able to share your slide, doctor?
Ma'am, I'm trying, ma'am. Yes, ma'am. I think I can, ma'am.
Okay. If you can't, then I will send the presentation.
Yeah, sure, ma'am. Ma'am, kindly send the presentation, ma'am. I couldn't.
Shall I share your presentation?
Yeah, sure, ma'am. Sure, ma'am.
I'll try one more. Is it now visible?
Yes, ma'am. Visible.
No, ma'am. This is yes, ma'am. Now it's visible.
Yeah, it's in full screen mode. You can tell me when to I'm change the slide. I will do that. Okay, I'm starting your time. You can start now.
Thank you, ma'am. A very good afternoon to all the judges, panelists, and moderators, and my colleagues present here. My case is I'm presenting a case of Sjogren syndrome. Myself, a presenter, Dr. S. Neela Priyadarshini, a first year MS PG Aftal from Meenakshi Medical College, Kanchipuram, and my mentor is Professor Dr. K. Namita Bhuvaneshwari, ma'am. Ma'am, next slide. And Sjogren syndrome is a chronic, slowly progressive autoimmune disease characterized by the lymphocytic infiltrations of the exocrine glands mainly. It is an involvement of the lacrimal as well as salivary glands, which leads to keratoconjunctivitis sicca and xerostomia. Swedish ophthalmologist Henrik Sjogren first described it in 1933. Sjogren syndrome can be primary as well as secondary, with a prevalence rate of about 0.5 to 1%. Ratio is female is to male is 9:1, where female is predominantly affected. Pathogenesis include lymphocytic infiltrations of the exocrine glands and its lymphocytic hyperactivity. Next slide, ma'am.
I'm here presenting a case of 57-year-old female housewife attended our medical OP with a history of giddiness in Meenakshi Medical College, Kanchipuram. She was diagnosed with xerostomia and referred to our ophthalmology department for further evaluation. Patient had a history of dryness of mouth, blurring of vision, foreign body sensation of the eye, photophobia, and giddiness for the past 2 months. And patient was a known systemic hypertensive and was on treatment with ACE inhibitors for past 8 months. On admission, diabetes mellitus was detected and routine checkup was under routine checkup and treatment was started as a. Next slide. On ocular examination, visual acuity, right eye is 6/9, left eye is 6/9, NCT is 18/18, lid is normal in both eye, conjunctiva, both eye looks muddy as well as dry, cornea central clear with peripheral staining seen, anterior chamber normal, iris normal, pupil reacting to light, lens clear, fundus seems to be normal. Next slide, ma'am. An investigating skin test was done. Right eye was 1 mm, whereas left eye is 3 mm. Fluorescent stain positive, and the tear film breakup test is 3 seconds. Other investigations: hemoglobin is found to be 10 gram per deciliter. ESR is 170 mm in 1 hour. Peripheral smear is microcytic hypochromic anemia. Random blood sugar found to be 197 milligram per deciliter. Urine protein pulses was seen 12 to 15 and bacteria plus. And other suggested investigation for this patient is RA factor, ANA, anti-SSARO, and anti-SSBLA. Next slide, ma'am. Management: the patient was started on carboxymethyl cellulose eye drops 6 times daily for both the eye, and the patient was also started on lubricant eye gel twice daily. The patient is being treated with xerostomia with sips of water and also advised to reduce the caffeine intake and flavored sugar flavored things. Anemia was treated with the tablet Levogen and advised to review after fortnight for follow-up. The patient condition was improving. Conclusion: the aim of my presentation is to emphasize as early diagnosis and treatment of secondary Sjogren's syndrome in patient who is on antihypertensive drugs will prevent corneal blindness. This study also emphasizes screening of all the antihypertensive patients for any dry eye symptoms in an early state, which will prevent any precipitating Sjogren's syndrome as well as preventing the corneal blindness. Thank you.
Thank you, doctor. You kept your time. Thank you.
Now we call upon the panelists, Dr. Parvata Sundari, to ask questions to Dr.
Thank you, Dr. Meena. It was an excellent presentation, Dr. Neela.
Thank you.
Can you hear me?
Yeah, ma'am, I can hear now.
Yeah. So my question is, what are the other antihypertensive drugs that can cause dry eye disease?
Ma'am, mainly antihypertensive drugs such as alpha blocker, beta blocker, and ACE inhibitors are more prone to get into dry eye symptoms, ma'am.
Is there any other ocular side effect of antihypertensive drugs? An important side effect?
Mainly corneal dryness, ma'am, and it reduces the secretions, mainly antihypertensive
Not
drugs.
about the cornea, something else. Anything else?
Ocular side effects such as
especially beta blockers.
Ma'am, in case of asthmatic patient, beta blockers is a side effects, ma'am. It will
No, it can decrease the intraocular pressure. Sometimes it can masquerade as a normal tension glaucoma.
Yes, ma'am.
Okay. So the next thing is, so why can't this be a primary Sjogren's, which has worsened after your antihypertensive treatment?
Ma'am, primary Sjogren's, there will be it will be within the gland, ma'am. First of all, and the criteria
have you done a biopsy of any gland?
No, ma'am, not ma'am. The salivary glands, everything was atrophied in this patient. There was no parotid gland enlargement or anything visible right now in this patient, ma'am. So we couldn't do anything, ma'am.
You have to do a minor salivary gland biopsy. Okay,
yes,
so in primary, because we should not miss the primary Sjogren's. That is more important.
Yes.
And next thing is, are you justified in calling this a secondary Sjogren's? Because when you say it's secondary Sjogren's, you have systemic associations. Okay, here you don't have any systemic associations. So how do you say that this is secondary Sjogren's?
Ma'am, according to the revised international classifications, there are ocular symptoms is there, and oral symptoms also there, ocular signs also there, and we had suggested the patient to go for further investigations for any confirmatory test for antibodies also, ma'am. So with this data available here, we are concluding it as a secondary Sjogren's, ma'am. Because patient who was on antihypertensive, diuretics, and anticholinergic drugs are more prone to get into systemic hypertension, secondary Sjogren's syndrome. Like,
do you have any research supporting that?
Ma'am, the patient, only the positive history over this patient is the patient was on hypertensive for the past 8 months, and all of a sudden she is developing all the symptoms for the dry eye, ma'am. So apart from that, she must test everything.
So this is drug induced, isn't it? It is
Yes,
drug
ma'am.
induced. So your management ideally should be, is it right? Or would you want to do something else?
Ma'am, I want to change the patient's antihypertensive drug into calcium channel blocker or something else, ma'am, which drugs will
That should be
reduce
the first choice. So you have to discuss with the physician
physician,
to
and I'm
change the
going,
drug. This
my
is all it is
treatment plan.
possible.
Yes, ma'am. Yes, ma'am.
Yeah.
That is the plan, ma'am.
That is more important, because if the drug is the inciting agent, then it is going to cause
It
more
is a big
damage. Okay, the lubricants
damage,
are
ma'am.
not going to help much.
Yes,
Okay,
ma'am.
and what is the severity scale did you use? Grade dry eye disease.
Ma'am, grading revised to international classification criteria for Sjogren's syndrome we used to for
So
the
what is the
classification.
grade now? What was the grade? Was it mild, moderate, or severe?
Ma'am, according to this, the skimmers was like my skimmers, everything is.
Yes.
Sorry, ma'am.
No, you just tell me the answer. Yeah.
Ma'am, the skimmers, it's 10 to 15 is moderate, more than 15 is mild, ma'am. Here it is 0 to 5. So I'm, according to, with my test done, skimmers as well as T-bird test, I'm concluding it as a severe dry eye, ma'am.
Yeah, this is a severe. Based on your investigations, your
My
finding,
investigation.
it seems
It's
to
a
be a
severe
severe case of dry eye disease.
Yes,
So
ma'am.
definitely you should discuss with the physician to change the drug. That would be more
Definitely,
ideal option.
because I have no other positive identification apart from the patient is on antihypertensive drugs, ma'am. So my plan is to discuss with the physician and change the drugs into any calcium channel or something which is not none other than alpha beta blocker and AC inhibitor, ma'am. That is the plan.
Did you do a rose Bengal staining too?
Ma'am, actually I could do a rose Bengal staining, but in this patient I didn't do, ma'am. I just did a fluorescence staining.
What is the advantage of using a rose Bengal over corneal fluorescence stain?
Ma'am, rose Bengal stain, more than 4 according to Van World scoring system, we can pick up it easily, ma'am. Like it will be
Because
finalized.
even before the cells are shed off, even the devitalized tissues, the cells will be picked up by the rose Bengal. So even before they shed off, it is
we have come to the end of the.
will be picked up by the rose Bengal. Thank you.
The time is up, madam.
Thank you, ma'am.
So now we go on to the next case by Dr. Mridula Vijayaraghavan, topical chemotherapy for OSSN. Can you put up your slides?
Yes, ma'am.
Your time will start from the first slide.
Ma'am, are my slides visible?
Yes, yes.
Yes.
Start.
Sit in full screen, ma'am.
Yes.
Yes. Good afternoon, everyone. Today, I will be presenting an interesting case where topical chemotherapy was used in the treatment of ocular surface squamous neoplasia. I am Dr. Mridula Vijayaraghavan, and my mentor is Dr. Geeta Ma. OSSN is an uncommon differential of many common indolent lesions like pterygium. Corneal and conjunctival squamous lesions are uncommon but important because of their potential for causing ocular and even systemic morbidity and mortality. So in this case, we will discuss how the patient can be given a choice of surgical excision versus topical chemotherapy. So a 49-year-old male presented to us with a history of growth in the right eye since 4 months. So his best corrected visual acuity was seen to be 6/N6 in both eyes. On slit lamp examination, we see that there is a conjunctival growth in the right eye, which is in the temporal aspect of the right eye. It is unifocal, gelatinous, 4 to 5 mm in size with well-defined margins, a visible posterior edge, which is variably pigmented, brown, raised, mobile, and soft in consistency. There was presence of tortuous feeder vessels and it was rose Bengal stain positive. The rest of the ocular examination was found to be within normal limits, and we see that on gonioscopy, there was no angle extension. There was also no preauricular, submandibular, or deep cervical lymphadenopathy. So we came to a provisional diagnosis of right eye pigmented OSSN or any other melanocytic lesion. This patient underwent an ASOCT scan, and it was found on the ASOCT that there was increased epithelial thickness, a hyperreflective epithelium, and an abrupt transition from the normal to the hyperreflective epithelium, which was suggestive of OSSN without deeper involvement. So the patient was explained about the management options, that he could have had surgical or topical chemotherapy, and the pros and cons were explained. Since the patient was billing for topical chemotherapy, temporary punctal occlusion was carried out with catgut, following which mitomycin C 0.04% drops were instilled 4 times a day, 1 week off and 1 week off. 1 week on and 1 week off, and serial ASOCT scans were done to monitor the response. So here we have the outcomes. There was significant resolution of the lesion both clinically and on ASOCT at 1 month after 2 cycles. And at the second follow-up at 2 months, we can see clinically and on ASOCT there is complete resolution of the lesion with no evidence of mitomycin C toxicity. So the take-home message is that there is a definitive role of topical chemotherapy or chemo reduction in OSSN, but mandatory compliance with the therapy and follow-up has to be ensured. There is a very important role of ASOCT in the diagnosis and follow-up. One disadvantage of the histopathological is that there is no histopathological diagnosis. It is very important to be aware regarding the pigmented variant of OSSN because we have to clinically differentiate it from other pigmented lesions like a nevus based on the age of onset, an elevated lesion, we can differentiate it from a PAM, and based on the ASOCT features, we can differentiate it from a melanoma. Finally, we look for resolution of the lesion with chemotherapy, which is highly suggestive of OSSN. So OSSN does not always require surgical management. We can give the patient a choice of topical chemotherapy versus surgical management. Thank you.
Can you hear me?
Thanks.
Yes, ma'am.
Yeah, nice presentation, doctor. A few questions for you.
Thank you, ma'am.
First, on the slide, can you point out and show us exactly where the epithelial thickness is changing? Because this has the pigmented melanocytes also. Yeah, okay.
Sure.
Okay. Usually this is seen on high resolution ASOCT pictures.
Yes.
Okay. The second question for you is what other topical chemotherapeutic agents can you use in treating OSSN?
Yes, ma'am. So we can also use trifluorouracil and we can also use interferon alpha 2B, ma'am.
So which would you think would be a better drug? Why did you not use interferon in this patient except for the cost? Was there any other reason why you did not use it?
Ma'am, we can use interferon, but with mitomycin, we see that there is a quicker resolution of the lesion. With interferon, we'll have to give the therapy for a longer duration of time to see for any resolution.
So if this lesion had not resolved with your 2 cycles of treatment,
yes,
how long would you be continuing the treatment and what is the protocol to follow the patient up?
Ma'am, if there is no resolution of the lesion with mitomycin, we can switch to interferon alpha. With interferon alpha, we again see if there is resolution of the lesion. So we generally wait for 6 to 8 weeks to see if there is any response. If there is no response, we can either switch to a different topical agent or we can go for surgical management.
So after you have seen resolution in this patient, how often are you going to call him back for follow-up?
Ma'am, we will call him back for follow-up initially for 3 months. So we give the mitomycin C for 2 more cycles after we see clinical resolution of the lesion. And then after that, we stop the topical chemotherapy. So till he completes his topical chemotherapy, we will see him on a 3-monthly basis. And then after that, we can see him on a 6-monthly basis.
If there is the toxicity of the mitomycin on the surface, how will you tackle that? Because that is what you're very much worried about, isn't it?
Yes, ma'am. So we are also giving the patient lubricants as well as soft steroids. And if there is some evidence of mitomycin C toxicity, also we can consider changing the topical chemo.
How do you prepare the topical mitomycin C?
So we use 0.04% mitomycin C. So it is available as 2 milligram per ml or 10 milligram per ml. So since we're using 0.04%, we take the 2 milligram per ml and we reconstitute it with 5 ml of distilled water, ma'am.
So any other instructions you give the patient? How do they carry it? How do they preserve it?
Yes, ma'am. So they also need to refrigerate the agent, and it has a shelf life of only 1 week, so they cannot use it beyond that. And we also tell them that there is some risk of periocular allergic dermatitis, so we should make sure that there is minimal contact with the
How
skin.
do you know it is healed clinically? And the pigmented.
Sorry, ma'am. Can you repeat your question?
No, I was just asking, will you tell this to the patient that every week he has to come back to take his drug supplement? The patient has to be accessible to you. Any other drugs other than the mitomycin C? And interferon, anything else have you tried?
5-fluorouracil can also be given.
So how is that prepared and what is the concentration of that?
5-fluorouracil, it is 50 milligram per ml. 50 milligram in 5 ml, ma'am.
Yeah. Okay. With regard to the pigmentation, so what are the ASOCT pictures of a melanoma? How would you differentiate that?
So in a melanoma, we'll see that there is a subepithelial hyperreflective lesion, and there will be some amount of epithelial thickening as well. And the epithelium, we'll see the basement epithelium, we can see presence of atypical melanocytes. There'll be variable hyperreflectivity.
Yeah, on the ASOCT you can see melanocytes, isn't
We
it?
can't see the melanocytes, you can see the variable hyperreflectivity.
Okay. How common is this like? What does the literature say about the incidence of this, the pigmented OSSN?
Ma'am, OSSN, the incidence varies.
The time is up for this case.
Okay.
Dr.
Time is
Mishri, thank you so much.
Okay, thank you.
Thank you, ma'am.
You can unshare yourself. You can unshare your slide, Pratila.
Yes.
You can stop sharing. Yeah. Thank you. So we can call upon the speaker, Dr. Aishwarya, the eye foundation, who's going to present induced angle closure attack with scleritis and choroidal effusion. Dr. Aishwarya, can you start sharing your slides?
Yes, ma'am. Is my slide
Yeah,
visible
your
now?
slide is visible. So we're going to set the timer now.
Good afternoon, everyone. Today we shall discuss a case of topiramate-induced angle closure with scleritis and choroidal effusion. And my mentor is Dr. Thanarasan sir and Dr. Vaishnavi ma'am. A 36-year-old female presented to her OPD with a diminution of vision in both eyes and headache for 3 days. She was initially treated at an outside hospital as a case of primary angle closure attack with anti-glaucoma medications, pilocarpine, and patient showed no improvement with the treatment with it. Patient came to our hospital for further management. When patient presented to us on examination, her uncorrected visual acuity was 6/24 in one eye and 6/60 in the other eye. Corneal examination showed edema. Anterior segment was shallow with myotic pupil and was grade 1 as per Von Herrick grading. And Goldman applanation tonometry recorded an IOP of 32 in the right eye and 44 mmHg in the left eye. And gonioscopy was performed and it showed closed angle in all 4 quadrants. On detailed history, it was found that patient was on topiramate for 3 days for the treatment of headache and epilepsy. So the diagnosis of topiramate-induced angle closure attack was made. So the first management what we offered for the patient was to stop the topiramate use. And then patient was asked to stop pilocarpine and patient was started on a combination AGM of brimonidine and timolol topical dose and lotipred eye drops was started and atropine eye ointment was started. On next day, patient was examined and IOP was reduced to 9 mmHg in right eye and 10 mmHg in the left eye. But refraction showed myopic shift and gonioscopy showed persistent closed angles in all four quadrants. And patient also had persistent congestion, which was diagnosed to be scleritis, and B scan was done for the patient, which showed thickening of the retinochoroidal scleral complex with choroidal effusion in the periphery. This led to the confirmation of the diagnosis of secondary angle closure due to topiramate. The same line of management was continued to the patient, and the patient was followed up. And on the third day of follow-up, patient's refraction showed hyperopic shift in both the eyes. IOP was well controlled, cornea was clear, and scleritis was gradually resolving, and angles were open, and disc showed resolving edema. So this is an ASOCT picture of eye showing open angles. So the clinical pearls, always we have to get in detailed history. Rule out secondary causes before diagnosing primary angle closure attack. B-scan, UBM, ASOCT will be key in understanding the pathophysiology of the angle closure attack. So adverse effects of topiramate would be abnormal vision, secondary angle closure glaucoma, myopia, suprachoroidal effusion, and scleritis. And the incidence has been noted to be 3 per 1 lakh patients taking the medication. The mechanism of myopia and secondary angle closure in choroidal effusion is choroidal effusion and anterior rotation of the lens iris diaphragm and forward displacement. So the management would be cessation of topiramate use and use of aqueous suppressants with either use of acetazolamide and topical cycloplegics, topical steroids and systemic steroids in the refractory cases. Prostaglandins and miotics should be avoided and laser PI should not be done in these cases. Thank you.
Thank you, Doctor. That was a very good presentation. Now we call upon Dr. Mona to ask questions from the speaker.
First of all, I'd like to congratulate WS on the wonderful session, and I thank for including me in the panel. So that was a very interesting presentation, and glad you recognized it to be a topiramate-induced angle closure. So in a patient coming with bilateral angle closure, acute angle closure attack, what history would you take from the patient, Dr. Aishwarya?
First, we'll have to ask for a detailed history to the patient if patient had been on any drugs. There had been any. Sorry, ma'am, not audible, ma'am.
Yeah, which medications, what history would you take specifically? Apart from drugs, are there any other causes? That's what I want to ask.
If there had been any similar history or similar attack before, ma'am, and any drugs like antipsychotics, antidepressants, anti-Parkinson drugs, and sulfa drugs usage history can be asked in detail, ma'am.
Okay. Anything not related to drugs?
Any family history to be ruled out, ma'am?
Family history for what condition?
Any family history of glaucoma, ma'am?
Okay.
Any laser procedure being done, ma'am?
Okay, so what do you think are the causes of bilateral acute angle closure apart from drugs? Would there any inflammatory cause come to your mind? Would an inflammatory cause come to your mind?
Any history of uveitis in the patient, ma'am?
Which specifically pertaining to what uveitis?
Anterior uveitis.
Pan
uveitis. Yeah.
Which one specific uveitis is known to cause bilateral acute angle closure crisis? It would mostly be in the posterior part. Okay, so what is the mechanism in these eyes of myopic shift and angle closure?
It is mainly the edema in the ciliary body and suprachoroidal effusion, ma'am, which causes anterior rotation of the ciliary body and anterior displacement of the iris lens diaphragm, causing myopic shift and shallow EC and secondary.
Okay. So you said hyperopic and myopic shift. What was the refraction? I think that's not been mentioned in the slides. So already the patient was on medication when they came to you, right?
Yes, ma'am.
Yeah,
Initially,
so
when patient
how much was the
presented
refraction?
on the first day, only uncorrected visual acuity was done.
Yeah,
On
that
the next
time,
day, when next day when it was done, it was -4 in the right eye, ma'am, and -5 in the left eye, ma'am. And after the treatment course was finished, it was +0.25 in right eye and +0.5 in the left eye, ma'am.
So apart from the topiramate, anything else could have been the cause of the myopic shift? And then back to the
pilocarpine use could have caused for the myopic.
So once the that could have additionally added to the myopic shift. So once it was stopped, then it would have also reverted to a normal or emetropia or whatever the fraction you were getting. So
we just have to wind up little quick.
Okay, so what specific investigation one you name which would clinch the diagnosis in this case? One imaging technique.
UBM or ASOCT, visualizing the
Which would you
ciliary
prefer?
body. UBM.
Okay. And any systemic?
Ma'am, we've come to the end of this talk.
Okay.
So
okay, then nice presentation. Okay.
Thank you, ma'am. Doctor, can you quickly stop sharing your screen?
Yes, ma'am.
Yeah, so now we move on to the next talk by Dr. Aniksha, Sparkle in the Eye. She's from the Sri Ramchandra Institute of Higher Education and Research. Dr. Aniksha, you're up now.
Yes.
Please start sharing your screen.
Yes, ma'am.
We'll start timing you from your first slide.
Yes, ma'am. Are you able to see my screen, ma'am?
Yes. Yes, please start.
Yes, good afternoon to one and all present here. I am Dr. Aniksha from Sri Ramchandra Medical College. My co-author is Dr. Amrita. My mentor is Professor Dr. Radha Annamalai. I thank my mentor, panelists, judges, and moderators for giving me this opportunity. I'm going to present a case today. Waardenburg syndrome is an auditory pigmentary syndrome with sensory neural hearing loss, patchy abnormal pigmentation of eyes, hair and skin with neural crest defects. There are 4 recognized types of Waardenburg syndrome, distinguished by physical appearance and genetic cause. Type 1 and type 2 have similar features except for widely spaced eyes in type 1. Type 3 has abnormalities of arms and hands. Type 4 has associated Hirschsprung's disease. A 21-year-old female came with complaints of hypogonadotropic hypogonadism with primary amenorrhea, sensory neural deafness, premature graying of hair, with a diminution of vision in both eyes for 6 months. No family history of any genetic diseases or glaucoma. On ocular examination, telecanthus and cyanophores was present, and the patient was orthophoric. Right eye best corrected visual acuity was 612 N6. Anterior segment showed a posterior embryotoxin, heterochromia iridis. Anterior chamber was normal depth with no evidence of anterior uveitis. Pupil was 3 mm brisk. Lens was clear. IOP measured by Goldman applanation tonometer at 10 am was 12 millimeters of mercury, and gonioscopy showed open angles. Left eye best corrected visual acuity was 618 N6. Anterior segment showed posterior embryotoxin, heterochromia iridis, AC normal depth with no evidence of anterior uveitis, pupil 3 mm brisk, lens was clear, IOP 14 millimeters of mercury, and gonioscopy showed open angles. A picture of the patient showing the heterochromia iridis with segmented blue pigmentation, cyanophores, and telecanthus. On fundus examination, media was clear. Dish showed temporal pallor. Vessels were normal. Macula showed central hypopigmented atrophic changes surrounded by hyperpigmentation with a halo of hypopigmentation. Flecked retina with RPE changes were seen with no gliosis. Color vision and arm slits were within normal limits. This is a fundus picture showing temporal pallor. Macula showing a central hypopigmentation surrounded by a hyperpigmentation and a halo of hypopigmentation. The flecked retina and RPE changes. At this point, based on the fundus picture, a differential diagnosis of crystalline retinopathy and other causes of atrophic maculopathy was considered. The patient had been advised for FFA and fundus autofluorescence, and we are waiting for her review. This is a unique case of heterochromia iridis with pigment distributed in iris and retina with no signs of inflammation. A diagnosis of Waardenburg syndrome was made only after ophthalmological evaluation. Based on the ophthalmic findings, the likely nature of genetic mutation was classified as type 1. Thank you.
Thank you. Now we call upon the panelist, Dr. Pramila, to ask questions to Dr. Anisha.
Stop sharing your slide, doctor. Thank you.
Yes, ma'am.
Hello. So can you hear me? I'm Pramila.
Yes, ma'am, we can hear you.
Presentation, Dr. Anisha.
Ma'am, you're very, it's very light.
Can you hear me now?
Yes.
Hello.
Yes, ma'am, you can go ahead.
I have, a very nice presentation, doctor. I have a few questions here. Here, the patient have a defective vision for the past 6 months only, and the macula shows like some pigmentary maculopathy or bullseye maculopathy-like features. Why don't you do the macular OCT or investigation regarding sudden dip in vision for the past 6 months? If the patient is on any treatment for primary amenorrhea and hypogonadism, like the top things I want to clarify with you.
She came first to the endocrinologist, ma'am, for primary amenorrhea. From there, also she had diminution of vision, so she was referred from there to ophthalmology, ma'am. They were about to start her on hormone and therapy for primary amenorrhea, ma'am. We called her for investigations, but she's yet to review, ma'am.
Because the already patient is deaf, and she started developing defective vision also. So this is like any other drugs, so they are on. It's not the history is not sensitive of that, no.
Yes, ma'am.
So why don't you do the OCT, no? Yeah, OCT or some fields to rule out macular problems like 10-2 program or or ERG, multifocal ERG, is mandate for this patient. And why not?
Yes, ma'am. We are planning to do OCT, ma'am, and also FFA and fundus autofluorescence, ma'am.
Okay, fine. Okay, what is the kind of presentation? Like in this patient, no, you told like this is the and rest of the features are present. No, what are the? Is there any GAT problem? Is there any other ocular other than systemic features the patient have?
Other systemic features was not there other than amenorrhea, ma'am. There was no GI symptoms or any hand or arms deformity or no neurological symptoms also, ma'am. Ocular, she had diminution of vision with heterochromia iridis and telecanthus, ma'am, and cynophils was there. And the fundus showed that flecked retina picture, ma'am.
Okay. Is it like retina suggestive of this is associated with the pigmentary changes of this syndrome, Waardenburg syndrome?
No, ma'am. Flecked retina won't be there. There may be choroidal depigmentation, ma'am. But this was a unique case presented with us with
this
flecked
is
retina.
presentations are more common than this. And what about the audiometry findings? Because it's the one of the major thing which we, one of the major thing you're supposed to see, no? This what is the audiometry picture?
She had a sensory neural deafness, ma'am. Bilateral.
Okay. This is severe or
not very severe, ma'am. But she had sensory neural deafness, ma'am.
Oh, she is wearing anything like the audio auditory aid for that? Okay, she can go for because maybe later she was diagnosed as a deaf, because there are a lot of things are available, no, to improve the auditory function.
You have last 20 seconds to conclude this case.
Yes, fine. So nothing else to add in this case. It's a very nice presentation.
Thank you.
So we have the next case presentation by Dr. Loveleen Rose Paul from the Eye Foundation. management of a case of complicated cataract in a microphthalmos eye. Dr. Lovely, you can start sharing your presentation.
Ma'am, can you see my presentation? Hello, ma'am.
Yes, it's visible. Yeah.
Yes, we can see it. Please carry on.
Good afternoon, all. Myself, Dr. Lavin Rospol from Eye Foundation. Today, my topic of discussion is management of a case of complicated cataract in microphthalmos eye. My moderator is Dr. Tennessen sir. A 33-year-old female patient came to our OPD with complaints of blurred vision since childhood. She was a known case of hypothyroidism and was on medication. Her general and systemic examination were within normal limits. Cardiac evaluation were also within normal limits. Her uncorrected visual acuity was hand movements on right eye and no PL on left eye. We did an anti-segment examination and microphthalmos with nystagmus was seen on the right eye, anophthalmos with the nystagmus on the left eye. Conjunctiva was normal, cornea was microcornea, and anterior chamber was shallow, and there was an iris coloboma, and the patient was a case of advanced cataract. Fundus no view was there due to cataract. This was the preoperative picture of the patient with the complicated cataract. We did a B scan on right eye, and in B scan, vitreous cavity was clear with retina colloid and coloboma. Retina attached with intercalary membrane detachment. Axial length was 12 millimeter. We made a diagnosis of right eye microphthalmos with microcornea with complicated cataract, and treatment advised was right eye pars plana vitrectomy with pars plana lensectomy, phacophagmentation under guarded visual prognosis. This was the preoperative picture of the patient. The cornea, size of the cornea was so small.
How to download that either?
Size of the cornea was so small with infusion, and we put an infusion 27 gauge infusion port and lighter port and 25 gauge cutter port, and vitrectomy was done. Later, MVR entry was made for phacophagmentation, but we had to change our infusion port to 25 gauge for completing phacophagmentation. Nucleus was divided into parts and removed. Complete vitrectomy was done. And we can see the retina-provided coloboma involving the disc and the macula. Tricot was injected to remove the remaining vitreous. Intercalary membrane detachment was dealt with laser. Port entry was closed. And this was the post-operative picture of the patient. And follow-up was done on 1 week, after 1 week, and uncorrected visual acuity was improved to counting fingers 1 meter, and best corrected visual acuity was counting fingers 5 meter with the +8 diopter lens. Microphthalmos with nystagmus was seen on the right eye, and ophthalmos with nystagmus on the left eye. Conjunctiva was normal, cornea was microcornea, and iris and anterior chamber was normal. Iris coloboma was seen, and we left the patient aphakic. And this was the fundus picture of the patient with the retina colloidal coloboma involving the disc and the macula. Retina was attached, and you can see the laser marks. Microphthalmos, anophthalmos, and coloboma represent a spectrum of developmental ocular defects that can occur in isolation or as a part of multi-system syndrome. Microphthalmia can be associated with ocular anomalies, craniofacial malformations, mental retardation, malformations of the hands, and multiple congenital anomalies, chromosomal anomalies, and intrauterine insults. Cataract in microphthalmos can be approached safely through posterior segment by pars plana vitrectomy and pars plana lensectomy.
Your time is up, though. Thanks.
Thank you.
You can stop sharing, doctor.
Now we call upon Dr. Subhashini to ask questions to Dr. Lovely.
Thank you, Dr. Ramya. Dr. Loveen, that was a very interesting presentation. So I just need a few clarifications. Actually, as you said, the microphthalmos can have some syndromic features. Did you look for anything in this patient?
Cardiac evaluation was done, ma'am. Cardiac evaluation was within normal limits. And the patient didn't complain of any other symptoms also.
Okay.
We actually inquired about the renal symptoms, central nervous system involving, we examined central nervous system, but everything was normal.
Okay, fine. So in your ocular examination, you didn't mention about facial symmetry, if it was maintained, the head position. So is facial symmetry important, especially in this case?
Facial symmetry was maintained in this patient, ma'am.
What about the orbital volume?
Actually, we should look for microphthalmos.
That is what you have diagnosed, no? Microphthalmos.
Yeah.
The other eye picture also you haven't shown in your presentation, the anophthalmos eye. So what has that to do? So what happens with a small eye? Does the orbit develop well?
The orbit development is there is problem, optic vesicle formation, and there's problem.
No,
anterior
for the orbit to grow, you need a good ocular volume. So here, in a very small eye, the orbit itself can be small. So if you had shown the picture, it was only the eye picture that was there. Okay. So, and even about the nystagmus, what type of nystagmus did this patient have? So you didn't mention anything about a little detail also was not given about the nystagmus. Cornea cornea, was there any pannus? Even the corneal shape, it's not round.
It was 4 into 4 mm cornea.
Yeah, was it? It's not the proper shape, no? It's more
not
ovalish.
Yeah, yes, ma'am. Some more obliques.
And was it a white total cataract, or was it a dense nuclear cataract that the patient had?
It was almost total cataract, ma'am.
Okay. Because you had mentioned only advanced cataract, so I could not make out. And even in the history, is the family history important?
Family history is important, ma'am. But this patient didn't have any family history like that. But it can be due to some chromosomal anomalies.
Yeah, you have few seconds to wind up.
Okay. So what is this simple microphthalmos or complex microphthalmos?
It is a complicated microphthalmos, ma'am.
Why do you say so?
As it is associated with complicated cataract.
Okay. So why this was not managed with a simple extracapsular cataract extraction? Why PPV was planned?
Because it will be so difficult to manipulate everything through this microcornea.
Actually, PPV will be more complicated and can result in retinal detachment also. So a simple just
the patient.
Can we wind up this?
Yes, ma'am.
Thank you so much.
Okay.
Thank you, Dr.
Thank you, ma'am.
Thank you.
Thank you. So now I call upon the last speaker for today, Dr. Sheila Priya from Chettinad Hospital and Research Institute. She's going to speak to us on spontaneous corneal perforation in a HIV patient. Dr. Sheila, you can start sharing the screen.
Yes, ma'am. Ma'am, I'm not able to add my slide, ma'am.
Who's doctor? What is your presentation?
Spontaneous corneal perforation in a HIV patient.
Yours is. What your Sheila? Oh, you're Dr. Sheila, right?
Yes, ma'am.
I'll share the presentation, doctor.
Yes,
Can you
ma'am.
see
Thank you,
now?
ma'am.
Can you see?
No, ma'am. It's not visible.
Not yet, ma'am. Wait. Okay. Hmm. I have to share screen. Sorry, I'm so sorry. 1 minute. Is this the one? Correct?
Yes,
No,
ma'am.
ma'am.
Yes,
Yes, so
ma'am.
this is the
one.
one, ma'am. Yeah.
Yes, ma'am.
Okay. I will change the slide, and I'm starting your time now.
Yes, ma'am. Thank you, ma'am. Good afternoon to everyone. I'm Dr. Sheila Priya from Chettinad Hospital and Research Institute. I'll be presenting a case on spontaneous corneal perforation in a HIV patient. My mentor is Professor Dr. Rajkumari, ma'am. Next slide, ma'am. Background of this study: a middle-aged woman presented to our OPD with complaints of defective vision in her right eye for 2 days, associated with photophobia in her right eye for 2 days, no other comorbidities, and the patient gave a history of she's taking antiretroviral therapy for 7 years and she was on regular treatment. Next slide, ma'am. Case description: the patient presented with a best corrected visual acuity of 2/60 in her right eye and 612 with pinhole 6.9 in her left eye. On examination, the right eye of the cornea, it showed central part of the cornea was taking up fluorescent stain of 3 × 2 mm, and DM folds were noted. Central corneal thinning was noted. No active leakage or perforation was observed. AC was shallow. The pupils were mid-dilated and irregular. Lens had early lens changes. On examination of the other eye, the anterior segment was within normal limits. The patient was managed conservatively. On day 2, the patient presented with spontaneous corneal perforation of 1 mm in size, which was evident by a positive Siedel's test. AC was shallow and the bandage contact lens was applied. I've added a slit lamp image of the same. The one to the left showing the positive Siedel's test and the other image showing the shallow anterior chamber. Next slide, ma'am. Case description. Since the patient was on antiretroviral therapy for a long duration, we wanted to know if it led to impaired liver function, which could have further caused vitamin A deficiency, leading to keratomalacia. However, serum vitamin A level was tested in this patient, and it was 0.3 milligram per liter, which was the lower limit of the normal reference interval. And also, the LFT was done in this patient, which was normal. In this case, the patient was diagnosed to have dry eye, which could have also been a precipitating factor. As a precaution, lubricants were prescribed for the other eye and protective goggles were given. We would like to collect more data on the correlation between the immunosuppression and the corneal thinning. I would like to conclude that lacrimal deficiency due to HIV could have been the culprit in this case. Thank you.
Thank you, Dr. Sheila. Now we call upon Dr. Dr. Radhika, if you could ask Dr. Sheila a few questions.
Yeah, Sheila Priya, thanks for that case. Interesting as it was, I would like you to address some gaps over here.
Yes,
forget about the HIV background for a second. When the patient came to you on the first day,
Yes,
neither the photograph nor your description told me how much the corneal thinning was. It looked pretty thin to me. So, and what do you mean by conservative management when you have a thinned out cornea with an ulcer like that?
Ma'am, the patient, we managed with lubricants, antibiotics, and BCL was applied, ma'am.
Don't you think at that point itself, when there is about 80 to 90% thinning of the cornea, some fortification of the corneal stroma should have been done along with this conservative treatment of yours? In other words, what is the extent of corneal thinning that you can manage conservatively, and how much more thinning would you start building the tissue?
In size is more than 2 mm, ma'am.
Does it depend on the size or does it depend on the depth of the thinning?
Depends on the depth of the thinning, ma'am.
So I would feel that such an extensively thin bed of the ulcer, some fortification of the stroma should have gone along with the medication as well as with the bandage contact lens. If not a patch graft, at least cyanoacrylate glue or a tenon graft or something might have prevented the perforation that you saw on the next day. Huh?
Yes.
And what are the common, even assuming that we can link the HIV to your case, what are the common corneal and external surface conditions that are associated with HIV-related immunosuppression?
Ma'am, the patient can present with dry eye keratomalacia, ma'am.
So did you do a workup for dry eye? I understand it's difficult in the eye of involvement, but in the fellow eye, did you do a dry eye workup? If not,
yes, ma'am.
If so, it was not revealed in your presentation. So what did the dry eye workup show in the other eye?
Ma'am, Schimmer's test was done and it was found to be low, ma'am. And even tear breakup time was low on the other eye.
Right. So dry eye is one thing, along with opportunistic infection, that can set up a problem in the cornea in HIV patients. Is the fact that the patient is HIV positive that is important, or is anything else about the disease that decides whether the patient will have corneal or ocular complications? What about HIV is important if you want to link it up to the eye problem that you're seeing?
Ma'am, initially we wanted to rule out whether any trauma was there, ma'am.
You're not understanding my question.
Yes, ma'am.
I have understood that your patient was HIV positive. Mere being HIV positive, like merely being diabetic, does not mean that the patient will have some problem. There are some metabolic parameters which decide whether diabetes will affect a given organ. Like that, if I have to ask you for one parameter of the HIV status, which can tip the balance for the patient and produce complications in the cornea or the eye, which parameter of HIV testing will that be?
CD4 count, ma'am.
All right. Was that done for that patient?
A patient lost follow-up, ma'am. We had asked her to do that, but she didn't follow up after that, ma'am.
So while all that you have put together in your presentation is actually valid, there needs to be a thread of communication. Just because the patient had HIV, you cannot say the patient had dry eye, and just because the patient had thinning, you cannot conclude that perforation happened because of HIV. So each one needs to be substantiated. Did we?
Yes, ma'am.
Did we seal the thinning? Okay, with the tissue fortification. Did we do a CD4 count for this patient? Was the diagnosis of dry eye established? So you have put across all the points, but this is a case that you're trying to present. So you must be able to connect the dots when you're making a presentation. Otherwise, excellent.
Yes, ma'am.
That's all I have to ask, Meena. Do I have a few seconds more, or should I wind up?
I think we're already running short of time, Dr. Radhika. Thank you for your time.
Thank you so much. Yeah.
Thank you.
I thank all the speakers for this session. Special thanks to the panelists for staying back and also for the keynote lecture. And I now leave this session for the next session. Thank you, everybody, for staying. And I also thank Ramya for moderating the session along with me.
Thank you, ma'am.
And also the judges, and we will be receiving the marks from the judges to Dr. Ramya. Thank you, Dr. Meeta, Dr. Uma Sridhar, and to Nidhi.
Yeah, so now may I request the next session moderators to take over the session, please?
Yes, sir. Yes, ma'am. Good afternoon. Thank you for the wonderful opportunity given by WOS today. So now we have Dr. Parivardhini Annadurai, who will be presenting on glaucoma progression and role of early setup of a glaucoma clinic. Suguneshwari, ma'am.
Yeah, can you hear me?
Yeah, yes, ma'am.
Yeah,
I'll start sharing my screen. Yeah, thank you. At the outset, I would like to thank the Women Ophthalmological Society for giving me this opportunity. I'll be speaking about glaucoma progression and the role of early step-up. Glaucoma, as we know, is a heterogeneous group of progressive degenerative diseases characterized by a specific pattern of axonal death, resulting in optic nerve head cupping and visual field defect. It is the leading cause of irreversible blindness and a major diagnostic and treatment challenge to ophthalmologists all the world over. So the prevalence of glaucoma is increasing, and it has been estimated that by 2040, 112 million people will be affected by glaucoma in the age group of 40 to 80 years. And this is going to be disproportionately distributed in the Asian and the African continents, which has more of developing countries. This slide here I have put to emphasize that even in the developed countries like the US and Australia, the undiagnosed glaucoma cases are more than 78%. In a developing country like ours, the prevalence of undiagnosed glaucoma is more than 90%. Currently available treatments for glaucoma cannot reverse the glaucomatous damage to the visual system. So early diagnosis and treatment can prevent the progression of the disease. This is a famous graph showing the retinal ganglion cell loss in different types of glaucoma patients. This green dashed line shows the effect of aging alone on the RGC cell loss. This B graph line shows the older patient, and this yellow line shows a younger patient, both having same rate of progression. Patient who is young will have a severe functional impairment even though the patient has the same rate of progression. Also, a patient who progresses rapidly also will have the risk of severe functional impairment. So patients who present with advanced glaucoma, younger patients, patients who are rapid progressors will need aggressive treatment and closer follow-up compared to patients with little or no risk. So the treatment goal of glaucoma is to maintain the functional vision throughout the patient's lifetime with minimal effect on the quality of life. Intraocular pressure is the only known risk factor whose manipulation will alter the glaucoma progression. So we have evidence from the various landmark trials to show that lowering the intraocular pressure slows the glaucoma progression. However, if you pay particular attention here, the percentage of intraocular pressure reduction is not similar in all these studies. This goes to show that not only lowering the intraocular pressure, but also reducing the intraocular pressure to the target range is what slows the glaucoma progression. Target IP is nothing but the intraocular pressure estimated to slow the disease progression. This is determined from the baseline intraocular pressure, the stage of the disease, the estimated progression rate, and the life expectancy. This has to be individualized for each patient, and it is a dynamic range. So when we mean individualized, we mean that patients who progress faster, who have advanced damage, who have additional risk factors or have long life expectancy need lower target intraocular pressure. And patients who have early damage, slow rate of progression, short life expectancy, and no additional risk factors need a higher target intraocular pressure. So what about patients who are newly diagnosed when we don't know the rate of progression? In them, we base the treatment on the level of damage they present to us and also any other risk factors, like if the patient has a thin central cornea, they have a positive family history of glaucoma, or if they have pseudoexfoliation, we consider these in setting the target intraocular pressure. And usually it takes 2 years for us to establish the rate of progression. 6 fields in the first 2 years is sufficient to detect a 4 decibel change in mean deviation over 2 years. So we start with medical treatment in glaucoma patient. And somebody has to mute. And this is an algorithm showing the medical management of glaucoma. We usually start with the monotherapy. The first choice is usually a prostaglandin analog or a beta blocker. We don't start with multiple AGMs in primary glaucomas. So once we start with one AGM, if it is well tolerated, effective on the intraocular pressure reduction, and the target IOP is reached, we periodically verify the endpoints. If the AGM is not tolerated, or if it is not effective on the intraocular pressure, then we usually switch it to some other drugs in the same group or different group and don't keep adding the anti-glaucoma medications. However, now if this doesn't reach the target IOP, we add a second drug, and again if the target IOP is not reached, then we switch over to surgery or laser. So I want to emphasize here, if the intraocular pressure reduction is not sufficient, the patient does not tolerate the AGM, we should not keep adding AGMs, but we have to switch to another drug. So which AGM to choose will depend on the drug properties and the patient characteristics. Usually pay attention to how much efficacious the eye drop is going to be. What is the cost implication in this patient? Once we start the anti-glaucoma medications, we should make sure that the patient continues to use the drug. So the prostaglandin analogs are the first line of monotherapy because they are potent IOP lowering efficacious. They have a convenient once a day dosing and they are well tolerated systemically. So when we compare among the prostaglandin analogs, this meta-analysis in 1,600 patients showed that bimatoprost was more efficacious compared to latanoprost and travoprost in controlling the intraocular pressure. However, hyperemia was seen more with bimatoprost than the other anti-glaucoma medications. And then anti-glaucoma medication should not only reduce the intraocular pressure, but it should also control the mean intraocular pressure and the 24-hour circadian IOP curve to prevent glaucoma progression, because large diurnal fluctuations are also an independent risk factor for glaucoma progression. So if we look at the prostaglandin analogs in this study, when the patients were randomized to latanoprost, bimatoprost and travoprost, it was seen that all three were efficacious in reducing the intraocular pressures from the baseline. Also, they did not show much of a fluctuation. So we know that once we start the patient on monotherapy, it might not be enough to sustain the target intraocular pressure, as seen by the OATS, but that by 5 years, 40% of the patients needed more than 2 intraocular pressure medications. And in SIGIS, it was seen that by 2 years, more than 75% required more than 2 anti-glaucoma medications. So rather than giving 2-3 bottles of additional anti-glaucoma medications, a fixed drug combination will reduce the number of daily instillations and reduce the total number of preservatives and also reduce the cost for the patient. So fixed combination, the patients seem to prefer more, and they seem to be more adherent when we give them fixed combinations compared to unfixed combinations. So when we try to choose between the fixed combinations, timolol is the most common anti-glaucoma medications available with carbonic anhydrase inhibitor or alpha-2 agonist, or even we have now alpha-2 agonist and CIA inhibitors. We will concentrate more on prostaglandin analog and timolol fixed combinations. In this study were 82 patients with open angle glaucomas who were not under control with monotherapy, were randomized to bimatoprost timolol fixed combination and latanoprost fixed combination. And at the end of 12 weeks, it was seen that bimatoprost timolol fixed combination was associated with a greater intraocular pressure reduction from baseline compared with latanoprost, and this was maintained at 3 months. So what about travoprost, the other PG analog? In this study, patients who were on latanoprost timolol fixed combination were randomized to bimatoprost timolol and travoprost timolol, and a crossover was done at 3 months and studied at 6 months. It was seen that both of them had an additional reduction in mean diurnal intraocular pressure. However, bimatoprost showed a significant greater reduction than the travoprost timolol fixed combination at the end of 3 months. So once the patient requires a maximum tolerated medical therapy to control the pressure, we usually switch over to a surgical option to control the intraocular pressure. So I would like to summarize here that glaucoma remains a prevalent global problem and a leading cause of irreversible blindness worldwide. Management usually begins with monotherapy, and additional agents are added only when the monotherapy is effective, but it has not achieved the target IOP. Fixed combinations will offer us advantages in terms of convenience and adherence. So the next options are laser trabeculoplasty and surgery when topical medications have failed to achieve the intraocular pressure. Thank you.
Thank you, ma'am, for the interesting talk. So,
thank you, Pratika.
Thank you, ma'am. So now we move on to the next session. So I would like to invite the judges of our next session. First is Dr. Lakshmi Mahesh, ma'am. She has been in the field of orbit-oculoplasty for the past 29 years, and she's a visiting consultant in many hospitals, including Netra Dama and Chakra World Hospital, Bangalore. She was a consultant earlier in Manipal Hospital, and she has had so many publications and presentations. And she's one of the visiting scholars in a Chinese university and was a past president of OPI, OPIAL. You, ma'am. We have Dr. Rajat Maheshwari. She's a consultant surgeon at Netrasawa, Jalna, Maharashtra. He did his primary fellowship in Shankar Nethralaya in 97 to 98, and then he did a second fellowship in the University of Alberta. And he's an excellent surgeon, and we welcome you, sir. And next we have Dr. Marian Purley. She's one of my very good friends and colleague in ophthalmic plastic surgery, who did her fellowship from the prestigious Shankar Nethralaya, and she's currently the senior consultant and head of the department in orbit oculoplasty in the Giridhar Eye Institute, Kochi. We welcome you, ma'am. And we have an excellent set of panelists for this session. The first of the list is Dr. Namita Bhuvaneshwari, who was a retired director of RAO GOH, Chennai, and currently in the Meenakshi Medical College Hospital. She has got so many awards, to name a few: Best Teacher Award from MGR Medical University, Dr. Joseph Gnanadikam Award, and the Best Gold Medal in IIRSA. We welcome you, ma'am. And next we have Dr. MVS Prakash, who was the current director of RAO GOH, and he heads the Department of Orbit Oculoplasty. His special interest is in anterior segment and oculoplasty. He has many publications, and he has won many awards. We welcome you, sir. And then we have Professor Dr. Hema Nandini, who is the HOD, UVA and Medical Retina in RAO GOH, Chennai. We welcome you, ma'am. Then we have Dr. Kalai Selvi, Professor RAO GOH, whose special area of interest in neuro-ophthalmology. We welcome you, ma'am. Then we have Dr. Yogeshwari, who is the Professor of Orbit Oculoplasty Department, RAO GOH, Chennai. We welcome you, ma'am. And we have Dr. Smita Praveen, who is currently the Director of Academics in Shankar Nethralaya, and she heads the Department of Neuro-Ophthalmology. She's a Senior Consultant in Neuro-Ophthalmology in Shankar Nethralaya. We welcome you, ma'am. And we have Dr. Shikha Bashi, who is the Deputy Director and in the Department of Neuro-Ophthalmology, Shankar Nethralaya. We welcome you, ma'am. And we have the Dr. Vatsalya, who is the Consultant Orbit Oculoplasty Surgeon in Goa Medical College. We welcome you all, and let's start the session without wasting the time. So we have the first presenter, Dr. Alhana, who is going to present us on spontaneous subluxation of globe. So, and Dr. Namita ma'am will be moderating this presentation. You can go ahead, Alhana.
Okay. Good afternoon, ma'am. Can you see the slide, ma'am?
Yes.
Okay. Good afternoon, everyone. Today I'm going to present a case of spontaneous subluxation of globe. I'm from Dr. Alhana, MN Hospital. My mentor is Dr. Pratibha ma'am. Just have a small introduction on the spontaneous subluxation of the globe. The definition: it is an ocular subluxation which occurs when the equator of the globe protrudes anterior to the eyelid aperture. So the most common risk factors are thyroid eye disease, shallow orbits, floppy eyelid, and obesity. There are so many other risk factors. The most common is this one. Coming to the pathogenesis, this mainly due to the lax orbital septum and tendons, and also the shallow orbit, leading to the spontaneous globe subluxation. Here we are going to see a 44-year-old female who came with complaints of anterior subluxation of globe in the left eye. The past history: she has two similar episodes in the past, and she also has a history of thyroid disease on treatment. And she also complains of severe pain and blurring of vision. On examination, the anterior segment and fundus examination are with the normal limits. There's no relative afferent pupillary defect. Since it's an emergency, some manual reduction has been done. For doing this procedure, the patient is asked to relax. Sometimes the patient can be given analgesics, anxiolytics, or even topical anesthetic agents. After relaxing the patient is asked to maintain the downward gaze while the clinician pinches and pulls the upper eyelid upwards, and you have to use the index finger of the other hand to provide the gentle pressure, which will be the pressure should be towards the downward and backward towards the globe. So there's a continuous pressure is firmly given, and then the help of left hand, the hand which pulls the upper eyelid is slightly pulled forward, and the patient is asked to look up, and the reduction is completed. Here you can see the left eye picture in the first image. There's a subluxated globe, whereas after reduction you can see the globe almost equal to the right eye. The patient has been reviewed after 2 days, where the further investigation has been taken since she has been on thyroiditis to know about the activity and severity. The visual field tests are within normal limits. Here you can see the MRI image, the axial section of the MRI image, T1 weighted image. It shows an shallow orbit with a mild enlargement of the extraocular muscle. Comparing to the right eye, the left eye is slightly increased. The below image is in sagittal section of an T2 weighted image. There is no activity has been seen. So coming to the management, the emergency, the manual reduction has been done. For a permanent, whether the two types of treatment is available, whether lateral traso can be done or lateral decompression. It depends on the patient, on the and willing, and also on the disease condition, the management can be selected. Coming to the discussion, the sequelae of the globe subluxation lead to the corneal exposure and aberration. Keratopathy can happen. The patient will have a severe pain that can lead to the traumatic optic neuropathy. There will be a renal venous congestion and vision loss. This is all due to the subluxation of globe, that the optic nerve and the venous occlusion will happen at the orbital apex. The most common preventive measures are to avoid the eyelid manipulations, to avoid contact lens wearers in most prone patients, and to reduce weight, and to monitor the systemic thyroid levels, and also the surgical management. So the take-home message: the spontaneous globe subluxation is an alarming event. So immediate management of the reduction and conservative treatment is necessary. So management can be treated based on the individual patients. So the risk and benefits of both temporary and permanent procedures should be explained to the patients. Thank you.
Hello.
Yes, ma'am.
Hello. Hello. Good afternoon, everybody. That was a very good presentation, and a case of subluxation is a very good case. And when did you reduce the subluxation? How long did you take from the time of subluxation to the reduction? Hello?
The presentation you're asking, ma'am, the patient.
Yeah, the patient. The patient.
The patient presented like 1 day, ma'am.
Within 1 day, you were able to reduce?
Yes, ma'am.
Okay, so such a long time, there was no injury to the optic nerve. It's quite surprising. And cornea was not exposed. No exposure keratitis. That's again surprising. When was a previous episode? Similar episode earlier, no? Twice it has happened?
Yes, ma'am.
How long before was it? Frequency.
Frequency.
Yeah. You said the same patient had earlier subluxation twice before?
Yes, ma'am. I'm not sure, but it's like 1 year back, ma'am.
1 year back.
1 year.
Is her mental status is okay?
Yes, ma'am. Yes, ma'am. Her mental status. Yes, ma'am.
Okay, everything else looks normal. But why I'm asking is, we had a patient years back in RIO where the patient from IMH, Institute of Mental Health, came with bilateral subluxation like this.
Okay.
But we were able to reduce and give back some sort of a vision. But because of the optic nerve was stretched, the patient had some little setback in the vision.
Okay.
But since it is recurrent, probably you may have to do some permanent measures to prevent such subluxation.
Okay.
The patient is willing?
No, ma'am. The patient is not willing.
Okay. That's a very good presentation. Good.
Okay. Thank you, ma'am.
On to the next presentation by Dr. Divya Shri on infantile proptosis, the great masquerader, ocular tuberculosis.
Good afternoon, ma'am. The previous participant hasn't stopped sharing, ma'am, so I couldn't share. Just a minute, ma'am. Yes, right. Is my screen visible, ma'am?
Yeah, it's visible.
Okay. So, okay, thank you, ma'am. So, good afternoon to all. So, my topic is infantile proptosis, the great masquerader, ocular tuberculosis. My mentors are Professor Dr. U. Vijay Shanmugam, sir, and Dr. N. Parvadasundari, ma'am. So, we have a 3-month-old child referred for right eye swelling, admitted in the PICU for respiratory distress. History of resting illness, the child had a history of gradual onset progressive diffuse swelling of both upper and lower eyelid. It is associated with the enlargement of the right eye for the past 3 weeks. The swelling started first, followed by the respiratory illness. Positive history, the child had a fever and there is a history of recent vaccination and history of local treatment with ocupal eye ointment for the past 1 month. And negative history, there is no redness, no discharge, no history of trauma, no history of similar swelling elsewhere noticed in the body, no history of similar complaints in the past, no history of contact with TB or COVID. General examination, the child is irritable and drowsy, hence the vision of fixing and following couldn't be elicited. The CVS is normal, RS the child is tachypnic, paraabdomen, hepatomegaly and splenomegaly were noted and CN is normal. So on examination, right eye, we had a diffuse periorbital edema of both lids with localized soft, ill-defined, non-reducible swelling of upper lid in the medial 1/3 of size 1 × 1 centimeter with a mechanical ptosis and proptosis, which is more evidential on CT. And conjunctiva normal, cornea clear, pupils were reacting, both direct and indirect, lens normal, and orbital margin, there was diffuse tenderness elicited. The left eye is normal and unremarkable. On going through her fundus examination by indirect ophthalmoscopy with 20 diopter lens, on right eye, we came up with a 2 well circumscribed exudative lesion of about 2 to 3 disc diopter inferior to the disc and also 1 supranasally with associated rod spots and flame shaped hemorrhages. The left eye fundus is normal. So we proceeded with systemic investigation. CBC revealed pancytopenia, peripheral smear showed hypochromic microcytic anemia, and lymphocyte subset analysis further showed marked decrease in the T cell count. So, initial diagnosis of primary immune deficiency were made. Viral markers were negative. Then we proceeded with ultrasound imaging, where hypoechoic lesions were noted in the right lobe of liver, suggesting of it to be an abscess or a metastasis. At that time, we came up with a differential diagnosis of it being a retinoblastoma, or tuberculous granuloma, or neuroblastoma. And then CT scan was done, where subperiosteal collection of pus with bony erosion of roof of orbit was made out, so suggesting it to be an abscess. MRI done for right orbit, osteomyelitis of right frontal and sphenoid bone with subperiosteal collection of pus was noticed, and also other body MRI showed multiple granuloma of brain with meningitis, TB spondylitis with spinal meningitis, multiple liver granuloma, so showing a secondary dissemination. So we proceeded with the FNAC, ultrasound guided FNAC of the right lid first, and we sent a sample for culture and staining and also for CB-NAT. On staining, the acid for bacillus was noticed in Ziehl-Neelsen staining, and CB-NAT was positive for MTB. So the diagnosis is a case of disseminated secondary ocular tuberculosis in a primary immune deficiency syndrome. Management, as per pediatric tuberculosis management and consulting with thoracic medicine, initially we started the child on rifampicin 10 mg per kg followed by INH prophylaxis. After 1 week of the regimen, the swelling started regressing and the child is planned for further bone marrow transplantation for addressing the immune deficiency. However, the child expired in the course of treatment. So discussion, ocular TB as the initial manifestation for tuberculosis is a rare event, which is less than 1%, with the incidence of intraocular TB being 1.4 to 1.8%, and posterior uveitis is the most common form found. Hematological spread of TB along with the immunosuppressive status led to the disseminated series where multidisciplinary approach is needed for proper diagnosis and management. In this case, a favorable response to treatment demonstrated by shrinking of lid edema highlighted the masquerading TB in immune suppressed state as a cause of presenting complaint. Thank you.
Thank you, doctors. Can you please stop sharing? Request Dr. Hema Nandini to moderate the session and ask questions, please.
Yes, that was a good presentation. Good afternoon, everyone.
Good afternoon, ma'am.
Yeah.
Very happy to be a part of this WOS. Doctor, was there any family history?
No, ma'am. Both our parents, initially we tested them for MAN2. Both of them were negative, and the elder sibling was there, and the child is also negative.
Actually, this is a case of primary immunodeficiency wherein the tuberculosis was an opportunistic infection. Am I right?
Yes, ma'am. And
So
it
you
was also
cannot actually call it as ocular tuberculosis, no, because the child had multi-system involvement.
Yes, ma'am.
And you also said there was no past history in the 3 months.
Yes, the child had.
Because the baby was 3 months old, and this was the presenting feature was only now.
Yes, ma'am. For the past 3 months,
Usually for primary immunodeficiency, they say what is the criteria you like to highlight? They should have ENT infection at least 2-4, no?
Yes, ma'am.
To diagnose a primary, most commonly involved is ENT and as well as pneumonia.
Yes, ma'am. Pneumonia, respiratory tract infections.
Yeah, then only you can diagnose it as primary. Of course, you have they have done the T lymphocyte subsite analysis has been done. And what viral markers did you do?
We did test for HIV 1 and 2, ma'am, and then VCTC, ma'am, and then Hep B, ma'am.
So apart from your diagnosis of this ocular tuberculosis, any other lesion? You have mentioned about liver granulomas and also CNS lesions.
Yes,
and tuberculous spinal meningitis. So was a CSF analysis done or anywhere else biopsy was done and it was proved to be tuberculosis?
The liver biopsy was done similarly in the ultrasound guided manner, ma'am. The biopsy yielded a pus, ma'am, where they sent it for culture sensitivity, and since culture took long, and the similar sample was sent for CB-NAT also, ma'am, and CB-NAT turned to be a positive for MTB, ma'am.
Positive. So you have another evidence of, and what about the CSF analysis?
They couldn't do CSF analysis, ma'am, since the child was in a poor state, ma'am.
Okay, so it was just a radiological diagnosis, this TB spinal
radiological and microbiological diagnosis. Yes, ma'am.
Okay. And you had mentioned this FNAC has been done, no? Ultrasound guided.
Yes,
Where exactly did you do in the lid? Because you had mentioned one soft cystic swelling. So
yes,
you went directly through that cystic swelling or randomly in the lid?
No, ma'am. Since I mentioned it, we did it exactly over the cystic swelling, ma'am. After doing a CT, after confirming it to be an abscess, so we did it, ma'am. After the aspiration yielded a pus, then they proceeded with liver biopsy, ma'am, like FNAC mediated liver.
Okay. Actually, it's a very good, it's a very rare case. We don't encounter primary immunodeficiency very frequently. And your ocular involvement is part of the immunodeficiency. I cannot call it as ocular tuberculosis.
Yes, ma'am. Secondary ocular tuberculosis.
Yeah, it is just an opportunistic infection which has occurred in a baby with the primary immunodeficiency. Just like you have opportunistic infection in secondary acquired immunodeficiency syndrome. It is just similar to that. So it cannot be ocular tuberculosis. Tuberculosis has been an opportunistic infection in this baby.
Yes, ma'am. Mentioned as secondary ocular tuberculosis, ma'am.
Okay.
Okay.
Okay, it was a very good presentation and it is a rare case also.
Okay, thank you, ma'am. Thank you.
Thank you very much, ma'am. Now, call upon Dr. Bharati to present on the road less travel.
Good afternoon. Good afternoon, ma'am. Am I audible, ma'am?
Yes. Share your presentation, please.
Yes, ma'am. Good afternoon, one and all present here. Ma'am, am I audible?
Hello, nobody will respond. Just go on. Share your screen and go on.
Yes, ma'am. I am Dr. Bharati from RIO GOH. My mentor is Professor Dr. Prakash.
Your
Today,
slides are not visible.
One second.
You have to share your slides.
Yes, ma'am.
You have a green icon there, no? To share screen.
Yes, ma'am.
Click that and share. Okay.
Yes, ma'am.
Yes, it is seen. You can start presenting.
Yes, ma'am. Coming to an overview of lacrimal gland fistula, the congenital lacrimal gland fistula itself a rare occurrence, and on reviewing literature, we found so far only 18 cases were reported. Most of the cases are presented with unilateral and intermittent tear flow, and few cases were associated with systemic anomalies. It is classified into two types. Lateral type, where the orifice is close to the lateral canthus and is not associated with the tuft of hair. Our patient is of lateral type, and this type is common among congenital lacrimal gland fistula. And second is the tarsal type. The orifice is situated in the convex border of the upper tarsal plate and is associated with a tuft of hair. Without further delay, a 7-year-old male child presented to the OPD with a complaint of watering from an opening near lateral canthus in the right eye every time he blinked. Since birth, on examination, a fistulous opening 1 centimeter lateral to lateral canthus of right eye with a clear discharge was noted. And here the second picture is the picture showing fistulous opening with a clear fluid. The child and his parent denied any history of pain or swelling, discharge of bony spicules at the site of orifice. And there was no other systemic complaints or any history of ocular or periocular surgeries or trauma in the past. And child was further evaluated by clinical investigations. Duct syringing was done, which was free, suggested no direct connection with this lacrimal sac. Fluorescent dye test was done, turned out to be negative, suggested there was no communication between the fistula and the conjunctival Cully saga. Probing was done, which revealed a 9 mm fistulous tract going upward and medially with a soft stop, probably arising from the lacrimal gland. So to confirm the above clinical diagnosis, MRI sinogram was done, which showed in the anterior aspect of right temporal region a subcutaneous plane with a focal fluid-filled collection of size 8 mm cross 2 mm with probable communication to right lacrimal gland, probably a fistula. Then diagnosis of congenital lacrimal gland fistula was made. Patient was referred to a pediatrician for systemic workup to rule out any other systemic involvement. His ocular and systemic findings were within normal limits. Pre-operative workups were done. Then patient was planned for surgical excision of fistula. The case was then operated upon under GA. Fistula was dissected and removed in toto with an external orifice. The first picture showing the intraoperative picture of entire fistula measuring of 10 mm of size. Then the tissue was sent for histopathological examination. Histopathological examination showed a fistulous tract lined by stratified squamous epithelium with a fibrocollagenous stroma and cyst lined by cuboidal epithelium with goblet cells, which is consistent with the fistula. Here is the postoperative picture of the child on postoperative day 14. He was asymptomatic and had no functional or cosmetic problem. Patient is now being followed up regularly for recurrence. And so take home message from this case is a congenital lacrimal gland fistula may be isolated or associated with the facial dysmorphism or with the multiple systemic anomalies like renal agenesis, ectopic pelvic kidneys, and bacterial anomalies. So all patients presenting with the lacrimal fistula should be thoroughly evaluated for systemic anomalies, and it can be completely cured by appropriate surgical technique. And fistulectomy is the treatment of choice for external fistula. For openings near the lid margins, the fistula tract is transplanted into the upper conjunctival fornix to prevent dry eye following fistulectomy. In our patient, we did not have the fistula opening in the lid margin, so we went ahead with the fistulectomy alone. Thank you.
I request Dr. Kalai to ask questions, please.
Yeah, good afternoon, one and all, and thank you for the opportunity. That was a good presentation, Dr. Bharati, and I just have a few questions.
Yes, ma'am.
Which is more common? You said there are two types, like tarsal or lateral.
Yes, ma'am. Among
the common type?
Lateral type is more common among these two types, ma'am.
Okay, and what are the postulated causes for this fistula?
Developmental anomaly, ma'am. Usually, the lacrimal gland develops around the surface ectoderm as an epithelial bud invaginating from the basal shaft of the conjunctiva. During this process, if there is any hindrance, development of fistula will occur, ma'am.
Okay, so you said you have dissected the fistula.
Yes,
and did you remove any part of the lacrimal gland, because you said it's stopped with the lacrimal gland? Usually, sometimes a part of lacrimal gland also is supposed to be removed. So did you remove any part of a lacrimal gland along with your dissection?
No, ma'am, we did not remove, ma'am. To avoid decrease in lacrimation after post-operative period, ma'am, we just dissected the duct and ligated with non-absorbable suture and sutured the wound, ma'am.
So is there any chance of recurrence?
We are following up the case, ma'am. So far, there is a yes, ma'am.
Does the literature or any other your previous say there's any chance of recurrence any of the patients?
No, ma'am. No, ma'am. As of now, there is no. Yes, ma'am.
So your patient you have been following for how long?
2 months, ma'am. 2 to 3 months, ma'am.
Okay. Okay. Thank you, ma'am. Thank you.
Thank you, ma'am.
Okay. Thank you, ma'am. Now I call upon Dr. Jnana Oli to present the presentation on the monstrous mystery of the eye, an unknown intraorbital foreign body. Over to you, doctor. And I invite Dr. Vatsalya to ask questions. You can start presenting, Dr. Jnana Oli.
Good afternoon, everyone. Slide. Good afternoon, everyone. I'm Dr. Jnana M, postgraduate from RIU GOH, going to present a case on the monstrous mystery in the eye, an unknown intraorbital foreign body. Foreign bodies in the orbit are a common association in road traffic accidents. They come in all sizes and shapes. Diagnosing them usually demands a detailed history and radiological modalities like CT scan. Here we present one such case of a 23-year-old male shown in the image. He presented to our casualty with history of road traffic accident 24 hours prior. It's a two-wheeler versus four-wheeler collision, and history was unreliable as the patient had consumed alcohol. On his ophthalmic evaluation, his uncorrected visual acuity of right eye was 3/60. On examination of the lids, which is shown in the image, a plastic foreign body entering the orbit is noted medially, displacing the globe supratemporally. Now with these findings, let's have a look at what we did to tackle this challenge. Gentle dissection was done to expose the entry site of foreign body, and careful traction was applied to remove the foreign body along its track of entry. Upon removal, the globe was found to be intact, and it was noted to be a brake handle of a bike. As the post-operative image shows, patient had mild enophthalmos, mild congestion in the conjunctiva, with a visual acuity of 6/60 in post-operative day 1. Fundus examination revealed macular edema, and post-operatively this was treated with IV methylprednisolone, topical antibiotics, and NSAIDs. His post-operative day 3 vision was 6/6. CT facial bone with orbit was taken, and it showed multiple facial bone injury with medial wall of both orbit fracture, floor of right orbit fracture. As the patient started complaining of diplopia, on multidisciplinary approach, the patient was taken for revision surgery for right orbital floor fracture repair through anterior transconjunctival approach with titanium mesh. Post-operatively, patient symptoms of diplopia was drastically reduced. Upon reviewing the literatures in the past, we found that a clear and composed analysis of situation and timely management in the form of removal of foreign body can go a long way in reducing the immediate and long-term complications possible from prolonged retention of foreign body. So, my take-home message is, what appears drastically damaged need not be vision compromising always, and proper follow-up is mandatory for these patients. Thank you.
Thank you, Dr. Jnana Oli. It was a wonderful presentation and a very interesting case.
Yes, ma'am. Thank you, ma'am.
I would like to thank the WOS for the wonderful session and also including me in the panel. Before I ask you a couple of questions, a few suggestions I would like to tell you.
Yes, ma'am.
I would advise you to crop the pictures appropriately so that the identity of the patient is not relieved. revealed. You can avoid showing the full face of the patient, and also try to respect the aspect ratio of the pictures so that you don't stretch the pictures or compress the pictures, so that the clarity of the findings are much clearly seen.
Yes, ma'am. Sure, ma'am.
So a few questions I wanted to ask you. Was any preoperative imaging done before you took up the patient for the foreign body removal?
No, ma'am. As the patient presented to our casualty, we have taken the patient for surgery because we found that the globe was intact and patient considering the risk of retained foreign body, and the patient had foreign body anteriorly without rupture of the globe. We have planned for surgery immediately, ma'am.
Okay. How did you know that this foreign body was just in the anterior orbit, or it had not pierced the medial wall or entered the sinus? How would you know the depth of the penetration without doing an preoperative imaging?
Ma'am, without imaging, we found that the other eye of the patient was normal, and we found that this patient's globe was intact, ma'am. Right eye globe was intact, and we found that it's a plastic foreign body, inorganic foreign body in the anteriorly found in the orbit, ma'am. So we have taken for surgery in without further risk of retained foreign body. We have taken the patient for surgery, ma'am.
I feel that preoperative imaging is very important because you will not know the relation of the foreign body to the surrounding structures like your extraocular muscles, or the depth of the penetration also, or you might even have an occult globe rupture, which may not be visible on your anterior slit lamp examination. So, and also when you're removing the foreign body before entering the orbit and doing any procedure in the orbit, it is important that you do an imaging to know the relation of the foreign body to the surrounding structure, so that while removing it, you don't injure any surrounding structures inadvertently. So I think, and also you would have picked up the fracture in the first sitting itself.
Yes.
Correct? Yeah.
Yes, ma'am.
So
Yes.
I think a preoperative imaging should have been done. And one more question I wanted to ask you was there any coexisting eyelid laceration or a canalicular injury? Because as seen in the picture, it was more in the medial canthal region and penetrating through the lower eyelid, right?
Yes, ma'am. It was entering the globe medially, ma'am, near the lid margins, but there was no associated lid lacerations or canalicular injury, ma'am. The foreign body was just entering medially. Only the conjunctival tear was noted medially, ma'am.
All right. Do you feel that you could have combined both the procedures together and operated, or was there any particular reason for doing it as a staged procedure?
Ma'am, the surgeon should weigh the risk of surgery against the risk of retention and delayed complications of retained foreign bodies like infection, ma'am. So first we planned for removal of foreign body, and after further evaluation with CT, we have found that there was a fracture, ma'am. So we planned for the second sitting procedure to avoid the risk of retained foreign body, retention of anterior foreign body.
Now, just another question. Why was IV methylprednisolone given postoperatively for this patient? What was the indication?
Ma'am, patient was found to have visual acuity of 6/60, ma'am. When patient was presenting, he was having visual acuity of 3/60, but post-operatively, when we found that patient had consumed alcohol, but that history of unreliable, ma'am. So on post-op day 1, when we checked, he was having visual acuity of 6/60, and through fundus examination, we found out there is a macular edema, ma'am. And to avoid traumatic optic neuropathy in this patient, we started him on IV methylprednisolone and topical NSAIDs, ma'am. And in post-op day 3, his macular edema was resolved, and visual acuity was found to be 6/6.
Okay, so basically, it was given for a suspected traumatic optic neuropathy.
Yes, ma'am.
But pupils have always been normal right from the initial presentation, right?
Yes, ma'am.
Pupil was reacting to direct and consensual, and there was no relative afferent pupillary defect, right?
Yes, ma'am.
Which is unusual in a case of traumatic optic neuropathy, correct?
Yes, ma'am. But considering his visual acuity and the history was unreliable, we have started him on weighing the risk of traumatic optic neuropathy. We have started him on methylprednisolone.
Okay.
Sorry to interrupt. We have exceeded by time.
Yeah, okay. No.
Finish the discussion. Okay.
Yeah, yeah.
Thank you, Vatsalya.
Thank you, Nanoli. It was a wonderful presentation.
Thank you so much, ma'am.
Dr. Nyanoli, please stop sharing your slides. And now we call upon Dr. Deepthi Prasad from Aravindai, Chennai, to present a presentation on pendular nystagmus, and we have Shika ma'am to moderate this presentation.
Good afternoon. Good afternoon, all. I'm Deepthi from Aravindai Hospital.
Presentation, Deepthi.
Yes, just a second. Is my screen visible?
No, ma.
No, Dipti, we can't see.
Just a second, ma'am. Sorry, one. Am I visible?
Presentations are not shared, ma.
Is it seen, ma'am?
No. Did you click the share screen option, the green one in your Zoom?
Yes, ma'am.
Or or we'll go with the next presentation, and I can share your presentation subsequently. Can we do that? I have it in my mail. I'll open it and keep it ready. Meanwhile, then can we call upon Dr. Muthu Sundari?
I think she's able to share the screen now.
Yeah, okay. Then we'll continue with this. Okay.
Yeah, yeah.
Yeah, it's visible, ma'am.
Yes, Miles.
Okay. Okay. Good afternoon, all. I'm Dr. Deepthi from Arvindai Hospital, Chennai. And I'm here to present a case of pendular nystagmus, and we call it twist and tango. From Triplicate in Chennai, who was apparently normal 2 years ago, associated with movement of his environment, which was suggestive of oscillopsia. And this progressively worsened over the last 2 years. And the patient also gives a history of progressive worsening of vision in both eyes since the last 2 years. The patient gave a history of scleral buckling in 2009. He had no history of gait disturbances, difficulty in walking, clumsiness, or numbness of limbs, no urinary incontinence, no history of head nodding or seizures, no history of difficulty in initiating movements, no history of tremors or difficulty in speech, and no history of substance abuse. On examination, the visual acuity of the patient was 1/60 in both eyes, uncorrected visual acuity, and the best corrected visual acuity was 6/12 in the right eye and 6/18 in the left eye. And on performing refraction, the spherical correction was -23 diopters for the right eye and -24 diopters for the left eye. Slit lamp examination findings, the significant ones were ocular movements. On examining the ocular movements, we found fine pendular nystagmus of the rotatory type in the right eye and fine pendular nystagmus of vertical type in the left eye. And there were significant fundus findings, which was myopic disc with peripapillary atrophy in both eyes and tessellated fundus with barrage laser in the infratemporal quadrant in both eyes and a dull foveal reflex. These
Deepti, you're muted.
Dr. Deepti, we can't hear you. Are you muted? Can you unmute yourself, please?
I think she has some network issues.
Dr. Deepti, can you hear us? You're moving your slides, but we can't hear you.
I'm calling her. I think she has network issues. She's not able to hear what we
Okay,
are.
okay. Maybe we could move to the next, or we'll wait.
I think you can go to the next one, but she'll have to disconnect for the other one to present.
Yeah. Dr. Deepti, are you online?
Yes, ma'am. Yes, ma'am.
We didn't hear the last few slides and we were actually talking. Did you
Hello?
not hear us speak? Do you hear us?
I'm so sorry. I couldn't hear. No, I could not hear you.
Okay. Shika ma'am, can we go ahead with the questions, because I think the video presentation was not, because of internet issues, the video was
Yeah,
not.
I know the case, so that's not a problem. We can go with the discussion. You can stop sharing the slides, Deepti, and could you just summarize your case for everybody? How does one evaluate a nystagmus case? What are the attributes of nystagmus that we are supposed to look for, and how do we look for those? Deepti, can you hear us?
So, ma'am. Yes, ma'am. Yes, ma'am.
Yeah.
So to begin with, on examination, we look for the movements. So you first look at the amplitude of the movements. So whether it is fine or coarse, and you look at and secondly, you look for whether there's a fast component and there's a slow component, or both are equal. So whether it is pendular or it's a jerk nystagmus.
So that is,
and
first you mentioned you look at the amplitude, then you mentioned the waveform. Wow, what kind of nystagmus is it? Then what else do you look for?
The direction of the nystagmus. So in case of jerk nystagmus, you look for the direction of the fast component.
Yes. What else? How do you evaluate nystagmus? Why I'm asking you these questions is the video that you showed for nystagmus evaluation was a slit lamp examination, right? So we're not supposed, if we have to do a proper nystagmus evaluation, we have to look at the nystagmus in the primary case. Then we have to make the patient look in all directions to see. And there's so many attributes of nystagmus, starting from you're looking at, what is going to worsen the nystagmus, what is going to aggravate the nystagmus. If we have to reach a diagnosis, see, before we go to the type of nystagmus, we have to first ascertain whether there is a nystagmus. You feel the patient had a nystagmus, at least in the video that you presented. All we could see was that, the pupillary hippus was more obvious than the nystagmus, I would say.
Actually, ma'am, it was very fine, but since he had a history of he said that his on viewing, the background or the environment would move up and down, and it would he had these rotational movements was the complaint, but on the nystagmus was per se not very obvious on.
Did he have vertigo? Are you confusing vertigo with oscillopsia? Does the eye movement is so bad that you can, attribute so many symptoms? You were saying that he was seeing everything was moving. So in these cases, you can also have vertigo. Did the patient have vertigo or oscillopsia? Was the history? First, you have to tell me, in the end, I went through your slides. In the end, you attributed it to high myopia. So you're saying that this is these sensory nystagmus, which are because of, poor vision. They set in early. They don't present as a quiet nystagmus with oscillopsia, do they? So where are we going? So
because since all the since most of the other causes, the patient per se had visual disturbances and movements of these very fine movements, and he said that his vision was deteriorating over the last few years. Since his ocular examination, other than
did you do the visual fields for the patient? You said the patient was complaining of reduced
fields
624, 612, right? He's presented to you with decreasing vision, and he's complaining of things around him moving, right? That's what he's presented to you with. And the videos twice that you sent also, personally, I really couldn't see any nystagmus. Very, very, at least maybe it's not recorded properly, but the nystagmus was not clear. There are something called micro tremors. Why you had to use a slit lamp to pick up the nystagmus? Because it was really subtle, isn't it? It was so fine. It was like micro, isn't it? So the first thing usually in evaluation of nystagmus is you have to confirm whether the patient has nystagmus. On the other end of the spectrum, we have ocular flutter and opsoclonus, where there are very wild eye movements, which are not actually nystagmus. And this is on the other end of the spectrum, where it's a very micro, you've noticed some movement on slit lamp examination. Probably you've noted that, and the patient has presented with a progressive decrease in vision. And how do we combine everything? At least the presentation is not explaining, the nystagmus evaluation. You're supposed to do in a particular way. You're supposed to make the patient look in the primary gaze, then explain what is the amplitude, what is the frequency, and what is worsening it, convergence, what is the effect of convergence, what is the effect of making the patient look in all directions. So all that is lacking. You've just shown a slit lamp movement. Okay, so anyway, you couldn't complete your presentation too, so you need to do it again some other time. Okay.
Sorry to interrupt.
I think I'm short of time, Pratibha.
Yes, ma'am. Yes, ma'am. We have crossed time.
Yes.
So, can we move to the next presentation, ma'am?
Yes.
We'll move to the next presentation by Dr. Muthu Sundari. So she'll be presenting to us on My Heart is Beating, but Still, Why Can't I See? I invite Dr. Smita ma'am to ask her questions. Dr. Deepi, stop sharing, please. You can see the slides, Dr. Muthu Sundari. Put it in full screen and we can start presenting. Dr. Muthu Sundari, please unmute yourself, ma.
Yes, ma'am. Good morning, ma'am. I thank for this opportunity, ma'am. And I would like to thank Dr. Anand sir and my mentor, Professor Dr. Shankar sir. My topic is, my heart is beating, but still, why can't I see? These were the words told by the patient. Actually, the patient presented to casualty for a cardiac problem. And then the patient underwent cardiac angiography and landed up having left-sided homonymous hemianopia. Going to the case. 35 years old male presented to our casualty with complaints of sudden chest pain, giddiness, with dyspnea on exertion. He was a known diabetic with good glycemic control for the past 6 years. He is not known hypertensive. He is not a smoker, not an alcoholic. He had no previous history of visual impairment. Blood investigations were normal. He was diagnosed to have the left ventricular dysfunction with low ejection fraction, and he was requiring coronary angiography. He underwent an emergency coronary angiography for coronary artery disease with left ventricular dysfunction, wherein the diagnosis was single vessel disease. Following 1 hour, there was a sudden progressive loss of vision in both the eyes. On examination in the cardiac ICU, bedside, we could find that the visual acuity was greater than 6/60 with a left-sided temporal defect and right-sided nasal defect by the confrontation method which we did there. And he had no other neurological deficits, and anterior segment was found to be normal at that point of time and was referred to our OPD for further investigations. Next day, on examination in the OPD, anterior segment was found to be normal with pupils reacting equally in both eyes. Visual acuity was 6/9 in 6, but with defective color vision, and contrast sensitivity was normal. Fundus examination with dilated fundus was found to be normal in both eyes. Neuroimaging showed right parieto-occipital acute infarct with no hemorrhagic transformation. We did a perimetry and which showed the left-sided incongruous homonymous hemianopia. The extraocular movements were full and free. The lids were normal in both eyes. Conjunctiva was clear. Both the eyes, cornea was found to be clear. The anterior chamber had normal depth and was quiet. Iris was normal. The pupil was reacting and equal in both eyes, and lens was found to be clear. Visual acuity was 6/9 in both eyes. And this was the picture of perimetry, which showed left-sided homonymous hemianopia. Right parieto-occipital, this was the MRI finding. Right parieto-occipital acute infarct with no hemorrhagic transformation. And surprisingly, on the 4th day, he had no field defects. We followed him every day, but on the 4th day, he addressed that he had no defects, and we confirmed it with the perimetry. And confrontation method was done every day when he came for follow-up. On follow-up, the perimetry showed that he had no field defects. On follow-up, after a week of discharge, the patient did not complain of any visual impairments. He was followed even the next month, and he came for follow-up even after 3 months. He has completely recovered with no residual field loss. Transient cortical blindness, because of the complication of coronary, the dye used in coronary angiography, characterized by a rapidly progressive loss of vision and with complete return of vision within a few days. Very few cases of cortical blindness have been reported after coronary angiography. The exact underlying phenomenon is not known. And the probable pathophysiology due to cerebrovascular vasoconstriction resulting in infarction in the cortex, and maybe due to a breach in the blood-brain barrier with neurotoxicity of the contrast media. Omni-opaque, the non-ionic contrast media was the one used for this patient. And the reaction that occurs is approximately 10% of procedures, and severe forms in studies given were 0.1% for this particular dye. An unknown mechanism, delayed reactions can occur even hours or days later too. So incongruous homonymous hemianopia due to parietal lobe involvement after coronary angiograph resulting in transient visual impairment has not been reported. We have studies reporting cortical blindness, transient cortical blindness. So this is a rare complication which is to be addressed pre-procedure during the cardiac angiography. We are like this shows that we have to get a consent from the patient regarding his visual status also. Thank you.
Okay, so good presentation, Sundari. I have a couple of questions. Did you also check his color vision once the fields had recovered?
Yes, ma'am, and it came back to normal.
Was color vision normal?
Yes, ma'am.
Okay. How soon after an acute infarct do homonymous hemianophias recover, usually? In your literature search, you must have found some, right?
Yes, ma'am, 8 hours to 10 hours.
With an acute infarct?
Even reports have shown 2 days recovery also, ma'am.
Of visual field?
Yes, ma'am.
Okay, so I'd rather call this a transient homonymous hemianopia rather than transient cortical blindness. But do you know any other causes where you can have transient homonymous hemianopias? Because this is not very, it is a known entity, but not very common. So I'm sure when you did your literature search, you'd have come across some.
Any shock or...
What sort of shock?
Any trauma?
Does this person have another risk factor which could contribute to transient homonymous hemianopia? Is it diabetic?
Diabetic, ma'am.
Was his sugars normal?
Yes, ma'am. Under control.
It was checked?
Yes,
okay,
that
should also be mentioned because one of the other causes is non-ketotic acidosis, especially in diabetes. Okay?
Yes, ma'am.
Why do you think color vision is affected in strokes? Or where is the color vision center in the brain?
It is in the occipital lobe.
Which part of the occipital? Relax, okay, this is not an exam. Okay, last question. Have you heard about blind sight? What is blind sight? Go and read about it, okay? What is blind sight? That's more, when you do cortical blindness, you'll come across blind sight. To WOS, everyone, thank you for having me. Great session.
Thank you, ma'am. Okay, then Dr. Muthusundari, please stop sharing your slides. So we have Dr. Nandini, who's going to present to us on micronutrients and IIH. And Dr. Prakash sir will ask her questions at the end of the presentation.
Am I audible, Dr. Pratibha?
Yes, sir, you're audible.
Thank you.
Good afternoon, everyone. Thank you for this opportunity. Are my slides visible soon?
Yes, visible.
My topic is micronutrients and IIH. And I'm from Puducherry Institute of Medical Sciences. My co-authors are Dr. Veni Priya and Dr. Rainbow Srinivas. Idiopathic intracranial hypertension, also known as pseudotumor syndrome, it is a syndrome of headache, papilledema, elevated pressure of CSF beyond 200 millimeters of water, the normal neuroimaging, normal neurological examination in the presence of normal cerebrospinal fluid composition. Pseudotumor cerebri may be either primary or secondary to some conditions. Secondary causes of pseudotumor cerebri may include some medications, endocrinal abnormalities, autoimmune disorders, cranial venous outflow abnormalities, and anemia. Pseudotumor cerebri associated with anemia has been rarely reported. Case report 1. A 23-year-old male came with complaints of headache associated with history of blurring of vision in left eye for past 1 week. Vision was found to be 6/6 in both eyes when he presented, and anterior segment was normal. Dilated fundus showed early papilledema in both the eyes. He was prescribed tablet acetazolamide for a week, and when reviewed, he had established papilledema. Since papilledema did not resolve, further systemic investigations were done, which revealed vitamin B12 deficiency, and it was found to be 193 picograms per ml. On vitamin B12 supplementation, the papilledema was found to be resolved. In another case report, a 22-year-old female came with complaints of headache for past 3 months on and off associated with occasional vomiting. Patient had history of undergoing homeopathy treatment for polycystic ovary disease, in which the major constituent was vitamin A. Vision was found to be 6/6 in both the eyes. Anterior segment was found to be normal. Dilated fundus here also showed papilledema in both the eyes. Blood investigations were done, and the patient was found to have severe anemia, about 3.7 gram per deciliter. She was asked to stop the homeopathy, and she was advised to undergo blood transfusion and oil. On follow, her papilledema was also found to be resolved. Thus, my discussion is the exact etiological role of anemia in raised intracranial pressure remains unclear. Different mechanisms postulated include increased cerebral venous pressure secondary to a relative hyperviscosity state, altered cerebral hemodynamics, tissue hypoxia, which increases the brain capillary permeability, causing altered CSF dynamics and thus raised intracranial pressure. Iron deficiency anemia may result in reactive thrombocytosis due to the lack inhibition of thrombopoiesis, leading to increased venous pressure, which decreases the rate of CSF resorption, thereby resulting in raised intracranial pressure. To conclude, pseudotumor cerebri is an avoidable cause of visual loss both in adults as well as children. Permanent optic atrophy is a severe complication when patients do not respond to medical or surgical treatment. Nevertheless, despite adequate treatment, children can sustain loss of visual field and visual acuity rarely. Thus, early suspicion and prompt initiation of treatment helps in achieving favorable visual outcome. Thank you.
Thank you, Dr. Nandini. Prakash, sir.
Yes, good afternoon to all of you. Am I audible?
Yes, sir.
Thank you, Dr. Nandini, for a neat presentation. At the outset, I wish to thank WOS for including me in this session as panelist. So it's a unique program of the women, by the women, and for the women. It's an idea of the women, organized by the women, and the prizes for also. Dr. Nandini, as per literature, the diagnosis of idiopathic intracranial hypertension is only by exclusion because various factors have been thought of. It is very difficult to pinpoint and find out the cause. As per literature, it is found to be more common among obese females in childbearing age. What all investigations you have done? Have you done endocrine assessments for these patients?
Sir, the patient was tested for her thyroid status. It was all found to be
Thyroid, you have checked, huh?
Yes, yes, sir.
Okay. And another thing, the very title of your paper, little ambiguous. You say micronutrients and IIH. What all micronutrients you are implicating in this these two case reports? Because B12 is not a micronutrient, but a major vitamin. And the second one is anemia. Any specific micronutrients you are implicating?
Iron.
Pardon?
Iron, sir.
Iron, huh? So you said beta deficiency in case report 1.
First, yes, sir.
So even that beta deficiency would have caused anemia, and anemia may be the actual precipitating factor for this IEH, isn't it?
Yes.
And did you take an elaborate history of drug intake of these patients? For example, some drugs like, say, lithium or anabolic steroids vitamin A, excess of vitamin A can also cause such IAH.
My second patient, she undertook the Herbalife product, which comprised mainly of vitamin A, sir, for about 3 to 4 months. Sir. She didn't have any history of OCP or tetracycline. She was only on homeopathy treatment and not on allopathy.
Okay. Was there any history of transient visual loss, something like amaurosis pigax for a few seconds? Because that has been reported in such patients.
They just gave occasional blurring only, sir. Yes, sir. No, while only, examination, it was 6/6. Yes, sir. Blurring they gave, sir.
Not visual loss.
No, sir.
Like amaurosis. Okay. Then did you try field examination for these patients?
First patient we tried, sir. It was an arcuate field defect, sir.
Oh, you had arcuate, yeah, because it has been reported in the text. And even peripheral field constriction also has been reported. And I said there was no nerve palsy. You said neurological, no neurological deficit, no sixth nerve palsy or anything like that. Okay. Did you try anything, any like OCT analysis of the macula? Because apart from, say, an enlarged blind spot, there may be some changes in the macula, like choroidal neovascularization. That also has been reported. Did you try?
Is a OCT taken, sir, but it's found to be normal.
Nothing significant?
No, sir. Only papilledema was seen.
Pardon?
Disc edema was like
Disc
seems
edema,
not.
yeah.
Yes, sir.
Thank you. Thank you. Thank you for the nice discussion.
Thank you, sir.
Welcome.
Thank you, Prakash sir.
Thank you.
Dr. Nandini, yeah. Now we welcome Dr. Priyadarshini Parthasarathi to present us about shunt failure always present with papilledema. And I invite Dr. Yogeshwari ma'am to ask their questions at the end of it. Dr. Priyadarshini?
Madam,
are you sharing your presentation?
Priya is not ready, I think.
Dr. Priyadarshini?
Can you hear?
Do you have the presentation on desktop? Can you hear?
Yes, ma'am. 1 minute, ma'am. I'm trying to share this.
Yeah, it's visible.
It is seen, ma. You have to just click on that. Now make it full screen. Okay. Start presenting. We'll start the timer.
Make it
Not audible, Dr. Priyadarshini.
Yes, ma'am. Now it's okay, ma'am.
Start presenting.
Now it's okay, ma'am.
Yeah.
This one is seen nicely.
Yes, ma'am. A background of my case is
it's okay.
Yes, ma'am. Dandy-Walker malformation syndrome is the most common posterior fossa anomaly characterized by underdevelopment of the cerebellar vermis and cystic enlargement of the fourth ventricle. Most patients have hydrocephalus at the time of diagnosis, and shunt procedures are the primary treatment. But shunts remain among the most failure-prone procedures, with the failure rates of 30 to 40% at 1 year and approximately 50% at 2 years in pediatric patients. Papilledema is considered to be one of the cardinal ophthalmological signs of shunt failure. Other features includes headache, nausea, vomiting, irritability, fatigue, and increased head size. My case is a 7-year-old school-going boy. Was brought to the neurosurgery OPD with complaints of headache and defective vision for the past 10 days, and he is a known case of Dandy-Walker malformation syndrome, status post-ventricular peritoneal shunt since childhood. And on examination, the patient was lethargic. Both eye visual acuity was 3/60, and both the anterior segment was within normal limits, and pupil was 3 mm round, reacting to light, no RAPD. Extraocular movements were also full. Fundus examination showed normal fundus with no evidence of papilledema, with a well-defined margin with a 0.3 CDR, and CT brain showed VP shunt in place. On further follow-up, patient continued to have progressive loss of vision, and VEP showed prolonged P100 latency suggestive of demyelination. He was started on IV methylprednisolone 300 mg for 3 days, followed by oral steroids. Vision deteriorated to perception of light and perception of rays in both the eyes, following which Exploration of the shunt was done by the neurosurgeons and shunt revision was done. Post-operatively also, the patient remained perception of light and perception of rays was only the finding. And then on fundus examination, he started to develop mild temporal pallor in both the eyes. And after 3 months of follow-up, right eye visual acuity was improved to 6/60, whereas left eye was only hand movements, with the primary optic atrophy set in. The main discussion of this case is the prevalence of papilledema in shunt failure is pediatric age group results from 14 to 51%, but the development of papilledema requires a critical duration of intracranial pressure elevation, and papilledema is not a sensitive sign in acute elevation in intracranial pressure. Shunt failure can occur without the presence of elevated intracranial pressure in children, and therefore, patient symptoms, systemic signs, ocular signs, and neuroimaging must be considered together to diagnose the shunt failure.
Thank you. Yogeshwari ma'am.
Yeah. Can you hear me?
Yes, ma'am. Yes, ma'am.
Can you hear me?
Yes, ma'am. My network is poor. I'm sorry, ma'am.
Yeah. Can you hear me?
Yes, ma'am. I'm hearing. Yes, ma'am. You're
Yeah.
audible, ma'am.
It was a very nice presentation, Dr. Priyadarshini. I have few
Okay,
questions
ma'am.
for you.
Okay, ma'am.
The vision, it's good that patient has retained the vision, but has recovered from PL to 660. Was it due to
Yes, ma'am.
the per se due to your ICT, or was it due to the demyelination?
It's because of demyelination only, ma'am.
Can you hear me?
Yes, ma'am. It's because of demyelination,
Yeah,
ma'am.
please answer.
Yes, ma'am. It's because of demyelination, ma'am.
So is there a possibility that the patient has recovered vision due to the steroids and not due to the shunt surgery?
It can be both, ma'am. We have first
Was
possibility is because of the shunt revision, ma'am, and then it's also because of the steroids.
Yeah, was there any features of raised ICT?
No, ma'am. There was no features of raised ICT, ma'am.
No, nothing of that sort, like altered sensorium. Was
No,
there a
ma'am. Only he was.
did you do a OCT?
No, ma'am. We did OCT, but the macula was normal, ma'am. Only thing he was lethargic, but rest he was absolutely
Did you
fine,
do a
ma'am.
fields before?
No, ma'am. He wasn't cooperative
Yeah.
for fields, ma'am.
I do understand, but was there any previous records of his left eye or right eye? How was the vision in both eyes prior?
No, ma'am.
Was it a gradual loss of vision which the mother noticed only now?
The child said he noticed a mild diminution of vision only for the past 10 days. That's what the main complaint, ma'am. Before that, he didn't have any complaint, ma'am.
And there is no records also.
No records also not there. Yes, ma'am.
Anyway, but how about the other eye? It does not look like a primary optic atrophy or not even post papilledema sequelae. It looks like more of a temporal pallor. What I
Yes,
feel
ma'am.
the which we are focused. So how can you substantiate that?
First day, the margins were well defined with a normal color, ma'am. While following up only, mild temporal pallor started setting in both the eyes, but left eye, the disc was totally pale, ma'am. After that, we couldn't find
Totally pale.
Yes, ma'am. Diffuse pallor was present in left eye, but right eye there was a mild temporal pallor alone.
Okay, that was a nice presentation, and I thank WIS for giving me an opportunity to participate in this wide range of beautiful case collection. Thank you.
Thank you.
Thank you, Yogeshwari ma'am. Dr. Priyadarshini, please stop sharing. And now we have Dr. Priya Vadana to present to us on Mobius syndrome with multiple cranial nerve palsy. And Namita ma'am will be asking her questions in the end. Thank you. Dr. Priya Vadana.
Good afternoon, ma'am. Can you hear me?
Yes. Please start.
Yeah. Share your screen, please.
Yes, ma'am. Can you see my screen, ma'am?
No. Please share your screen. We are not able to see your screen.
Yes, ma'am. I'm trying to.
Yes. Full screen? Yes, start, ma.
Good afternoon, everyone. I'm Dr. Priya Vadana from Sri Venkateshwara Medical College Hospital and Research Center. And my mentor is Dr. M. Loganathan sir and Dr. Mullai ma'am. And I'm presenting a case on Mobius syndrome with multiple cranial nerve palsy. So the background is Mobius syndrome. The incidence is 1 in 50,000 to 1 in 5 lakh newborns. And it is a rare, congenital, X-linked, non-progressive neurological disorder. The cause is thought to be an underdevelopment of the 6th and 7th cranial nerves and characterized by weakness or paralysis of multiple cranial nerves. Facial weakness with abnormal ocular abduction is the most presenting feature, and there is delayed development of motor skills, presence of micrognathia, microstomia, cleft palate, tongue atrophy, dental abnormalities, and hypotonia is noted. Most children have a normal intellect. My case is of a 14-year-old school-going boy who had diminution of vision in both eyes, which he appreciated 1 year back, and he had history of watering in both eyes. There was no history of diplopia. There was history of difficulty in chewing, history of inability to smile, frown, pucker lips, history of difficulty in spitting, and history of difficulty in closing eyes. There was history of multiple hospital admissions in childhood for respiratory infection. During birth, the child did not cry soon after birth, and he had jaundice in the first week of life. And there was difficulty in breastfeeding because the child was unable to suck, and there was delayed motor developmental milestones. There was no history of similar complaints in the siblings. The bowel and bladder habits were normal. General examination. The patient was conscious, oriented to time, place, and person. He was moderately built and well nourished. There was no pararictus cyanosis clubbing, no lymphadenopathy and pedal edema. There was absent forehead wrinkles, loss of nasolabial fold. There was inability to smile, inability to clench teeth, inability to blow, or inability to chew food. He had a small chin, bifid tongue, and tongue atrophy was there. Head erect, facial asymmetry was there, and eyeballs. Right eye showed hypotropia, and left eye there was mild 15-degree esotropia, and extraocular movement in the right eye showed a severe restriction in elevation, mild restriction in abduction and dextrodepression, and whereas in the left eye there was severe restriction in levo elevation and severe restriction in abduction and mild to moderate restriction in dextrodepression and levo depression with overaction in depression. And this is the image showing lag of thalamus in both eyes with more in the left. His visual acuity, best corrected visual acuity was 6/18 partial in the right eye and 6/12 in the left eye. Lag of thalamus in both eye with more in the left eye. And Bell's phenomenon was fair in the right and good in the left eye. And cornea showed exposure keratopathy in both with inferior SPKs. The rest anterior segment was within normal limits. Both eye the pupils were 3 mm round, regular, reacting to light briskly. And on distant direct ophthalmoscopy, red glow was seen in both eyes. And fundus examination showed disc and vessels were within normal limits, 0.3:1 cup disc ratio, and macula foveal reflex was present. On cranial nerve examination, smell normal, and pupil reaction was normal, and he had a near normal visual acuity. Extraocular movement restriction was present. There was restricted movement of the facial muscles. Facial sensation was normal. Hearing was normal. Taste sensation and swallowing was normal. Shoulder shrugging was normal, and there was absence of tongue movement. The child had difficulty in protrusion of tongue. So, clinical pearls, this Mobius syndrome is more of a clinical diagnosis, and any case with abnormal head posture to be evaluated for multiple cranial nerve palsy, and hypotropia with restriction of elevation, bilateral restriction of extraocular movement without diplopia to be evaluated for Mobius syndrome. Thank you.
What are the main parts of the syndrome, Mobius syndrome?
It actually
How do
has
you diagnose Mobius syndrome?
Mobius syndrome is diagnosed by bilateral sixth cranial nerve palsy, horizontal gaze palsy in 50% cases, and occasional third and fourth nerve palsy is also there.
So how do you attribute this to Mobius? Is there any history of antenatal insult in the mother, like fever, any developmental anomalies during the first trimester?
I had asked the mother for any drug intake, but she denied any use of OCPs.
Fever, rash, or something like branchial arches, no? It looks like certain branchial arches have been affected congenitally. Such cases only won't have diplopia. It's not that cranial nerve palsies. Underdeveloped nucleus. It is not just the Mobius alone. Maybe it is something else. We need to probe into the details of the patient's presentation. Did you do MRI?
No, ma'am. We are yet to do MRI. The patient will be followed up, ma'am.
You need to know the muscles, musculoskeletal problem. It may not be just a nerve problem. It could be a musculoskeletal.
Okay,
so it needs a little more evaluation, not to brand the patient as Mobius. That's my opinion.
Okay, ma'am.
It's a little inadequate evaluation, I think. Okay, there's facial asymmetry.
Yes, ma'am.
Okay, what about the other things? Or other parts of the body are normal, isn't it?
Yes, ma'am. There was no limb anomalies.
Yeah, right. From neck downwards, everything else looks normal.
Yes, ma'am.
Mental faculties are fine.
Yes, ma'am. He had a normal intellect. He was studying 8th standard.
Yeah, that's what I'm trying to say, that it could be a developmental anomaly during the organogenesis system. We need to probe into the more history and little more evaluation and pinpoint for the diagnosis. Is it clear?
Yes, ma'am.
That's a nice initiative.
Thank you, ma'am.
Okay, ma'am. I thank this the opportunity of being together in this Women Ophthalmic Association. It's a great initiative by Dr. Ekta and Sugneshwari, and Pratibha coordinated so beautifully. I thank the opportunity to be with you all today. It was an excellent presentation by everybody. Great initiative, and it was a different grading and a different initiative. Congratulations for the organizers. Thank you very much.
Thank you so much, ma'am. So we are in the end of the session, and thank all the presenters for the wonderful variety of cases. And I should definitely thank the judges for patiently listening to all the presentations and judging calmly. Thank you, ma'am and sir. And thank you all the panelists. So now I hand over this session to Sugneshwari ma'am. I request the judges to kindly WhatsApp it to either me or Dr. Shruti once you are done with the markings. Thank you so much.
Thank you, Dr. Pratibha and Dr. Shruti. It was indeed an excellent moderation, I must say. And the panelists were indeed really, superb to put in a lot of academic feast for all of us. And the presenters who did really, really very well, and their mentors, to put in challenging cases. And it was a very nice initiative, by everybody. It was a team effort, I must say. And the judges who have been sitting through all the talks, untiringly on a Sunday afternoon. I must really thank everybody for being here. And right now, the tabulation of the results are currently going on. And I will request Dr. Ekta, who will be declaring the results also. And she will start her vote of thanks as of now, because we have too many people to be thanking about. And then when she concludes, she is going to be telling us the winner also. By then, the tabulation will get over. So may I request Dr. Ekta to start off the vote of thanks. And actually, right now, I think Dr. Renuka Srinivasan, has she joined? Renuka ma'am, are you there? I am not sure if she is there. So now it is almost, way too much in the early morning hours for Dr. Ekta. And I'm happy to have her here. Over to you, Dr. Ekta.
I thanks Subneshwari. It was an awesome presentation and a great show. And it was a team effort of WAS wing chapter of Tamil Nadu and Puducherry. And this basically the aim was to bring all the residents, to give them a platform, to encourage them. And this also is a part of a national initiative where the winners are supposed to go to the national conference and compete with the winners of other states. So great show from Tamil Nadu and Puducherry, and I'm happy. And definitely if we look at the people behind it, I really thank, first of all, the team was led by Dr. Mohita and Dr. Madhu, Dr. Maya. They were great inspirations who have helped us start this initiative in Tamil Nadu. Dr. Sugneshwari and Dr. Radha Annamalai, they were the backbones of this program. So they have done a lot of groundwork, and there are almost 67 colleges in Tamil Nadu and Puducherry, and we have tried contacting all these people. And then there was so many residents who actually were interested in presenting, but we could only choose 2 from each institute. So it was another Herculean task, basically, to select these people from the institute. And there was a preliminary round conducted by many institutes to send their 2 entries. So that was the groundwork which was going on behind Dr. Renuka Srinivasan, Dr. Chitra, Dr. Yogeshwari. They were all a big support. Then came the execution. The execution was basically from our moderators, who were really great. So a big thanks to Dr. Shruti, Dr. Pratibha, Dr. Shinisha, Dr. Shruti Suresh, Dr. Meena, Dr. Ramya, for their excellent contribution in sticking to the time. We also had a very good team of panelists who were able to guide all these students so well, and they took time to go through the cases and ask these questions. And a big thank you to all of them, our lovely judges, who have been scoring tirelessly for all the sessions to give us the results. So these are the judges who are from other states. They are not from Tamil Nadu, and they are scoring all the presenters. So this was a big effort. Again, our guest speakers, Mr. Bhageshwar from the WAS team, the Elergan, who has helped us organize this, and all our enthusiastic presenters and the mentors who have given them the case and the insight to present. So a big thank you to all of you. for being here on this platform. And the least I would say is like we have a lovely audience who have been connected with us to encourage these speakers. So thank you to them. I hope to see many more such presentations coming up from Tamil Nadu and Pondicherry chapter. And we'll keep doing this and we'll keep touching new heights. This was a great learning experience. So I'm still waiting for the final coding.
Just a few minutes, madam. In another couple of minutes, it will be done. We'll just hold on. I'm getting it ready, madam.
Sure.
I think right now Dr. Renuka is joining. That is what Dr. Hannah told me. If she is there, then she can probably share her views also in the meantime.
We can have actually everybody come along, the presenter, the panelists, the judges also, and they can share their views.
Yeah, Dr.
Hello,
Renuka
Dr. Renuka. You have been always an enthusiastic support for WAS TN chapter, and you have been there apart from the inception. So it's great. Good to be connecting with you.
Hello, just now Hannah told me that you all are going on with this because I am in the US, so it's good morning from me, and I'm not in a great state as such, but I missed it all because I slept. It's morning here. So anyway, that's why I opted out of this because it would be in the dead of my night here. So anyway, I was there in the initial part of the organization, and Dr. Suganeshwari and the rest, Ekta and the rest of you have done a great job with this. It's not easy to coordinate with so many people from all over the state because we have many medical colleges, and I think it has been very well represented. And I didn't listen to any of these. Probably I'll go through the recorded versions. In fact, I just got up and Dr. Hannah told me that this is going on, so I thought I'll just log in. So I really missed it. I'm sure it must have been a great experience, as she told me, and as all of you are now saying. Thank you very much. And I think we should keep it on. We started this during the Pondicherry chapter conference, which hosted the Tamil Nadu state conference in 2018. So that's when this whole thing started. And I was very much a part of that. And I continue to be part of this. And I 3 cheers to all the women who have taken part. And you people are great. And we need to keep the flag high because soon, or rather we are already in the majority. And so it has to be, the tides should turn to men in ophthalmology in the next 5 years. And we should be dominating the show. Thank you very much.
Thank you, Dr. Renuka. You have always been a big support, and it's awesome because we are such good team in Tamil Nadu that definitely we need to be doing this more often. And Sugneshwari, you are the spearheading person for this. So definitely it was a Herculean task and you did it so well. It was a smooth operation, as I would say. And we now have a good backbone to support us for such programs.
I must say I had the support of my friends. Most of my batchmates are here. Radha Annamalai is there, and Parivada Sundari is there, and my seniors, Yogeshwari. So all of them are like known faces, and it is so easy. And some of them in RIO, some of them in SN. So it's like all family. So it's nothing from outside, I must say. So it is really very easy to coordinate with people. And it was indeed a pleasure for me to go around these things, like I got to meet so many people. And in fact, like Dr. Vinata's friend, she kind of approached Dr. Rajat. So it was like so easy for us to move around among known people. That was something really nice. And nobody refused. That was the most important thing. Shruti, are you ready with the results?
Yes, ma'am. The last session going on. Just another minute. We are done. Just a minute.
Okay. So what you can also do is probably display all the whatever the hard copy the judges have sent. No, we have the soft copies rather. So you can put it on the desktop. Just show it. So that will be easier. So maybe the students may want to know also, isn't it?
I am yet to receive the score from Dr. Rajat Maheshwari.
Okay.
Dr. Rajat, sir, can you please send in the score to me for the third session? I think sir is calculating.
Okay.
Yeah, I'll contact him. Thank you.
So meantime, we have Dr. Lakshmi ma'am with us. Ella ma'am, you're there?
There.
Hi ma'am.
Hi. Can you see me?
Yes ma'am.
Yes. Hi ma'am.
Yeah, I'm very sad to be a judge. I don't enjoy. I think I should not have accepted to be the judge. I would have rather been a moderator. I enjoy being that because it makes my brain work rather than just put marks. Who am I to judge and put marks? So anyways, Sugneshwari, I think it's a wonderful show because case presentation is always very good, and for the last few years I have been a neuro-ophthalmologist also by default. When you work in a multi-speciality hospital, you have to be a neuro-ophthalmologist. So I really enjoyed all the presentation. I think just a little more time was needed in the presentation and to make it a little more, something like a learning process. Otherwise, I think the discussions and all were excellent. And Shika, I thank her for all the enthusiasm she shows, not only in neuro-ophthalmology, but even recently in the SN groups and all that. So I think it's a wonderful show, bringing all of us together. And I'm here in Karnataka, but a lot of part of me is in Tamil Nadu because I did major part of my schooling and education then. Thank you once again. Thank you all.
Ma'am, you will be here, don't worry. So what we are going to do is we are probably planning specialty wise sessions coming in the future. So what we will do at that point is, as we go specialty wise, we'll have more time for the discussion and more time for the presentation, so that it will be more of a learning exercise. Because this is a competitive session, so we had to rush in through everything. So from the next time it will be where we will have kind of monthly meetings, or that we will decide upon how we are going to do. So we can have representation from everywhere, need not be only from here, and then we can kind of share our knowledge and then put up a good discussion or have debate. So we can think about it like how we can go about in the future meetings using the same platform.
No, I think the management is very essential for our postgraduates because there are a dime a dozen medical colleges now. There are so many PGs now. I don't think we should really take pride in saying we are women ophthalmology, because very soon it's going to be only women in ophthalmology. Because even in SN you see the number of PGs who join, the women far exceed. So it's that we should not let it down in any way. With having so many, because we have to look into so many things. We are not just ophthalmologists, right? We have to look into so many other aspects. So I think the management part of it here, there was a little bit of lacuna in the completeness of the case. For instance, the child with tuberculosis, the child was lost. The child died despite good diagnosis and management. So Tamil Nadu and Pondicherry far excel the field of medicine compared to many other states in India. The quality of medicine practice, medical colleges, everything. I'm not putting anybody down, but I know that it is very good. So I think we cannot just say we lost a kid or we did that and this. We should have that completeness of the case for the understanding. So you are such a high volume retina surgeon, Sugneshwari, you know so many things, but I think for the benefit of the PGs, we should need the completeness of a case. In select cases which are complete, which have the complete discussion, investigations, etc. And there was a last column for judging where there is latest or the recent advances. There, unfortunately, in that part alone, I could not give much marks because nothing about that was discussed. So I think, if the initiative is excellent compared to so many other WOS groups, I think this was a really good learning platform, no doubt about it. I'm not biased, but I think this scope a lot for improvement.
Definitely, ma'am. I think that is a real good word that, we need to take the criticism so that we'll be able to mature and become better
No,
and
please
better.
don't mistake me. No, it's not criticism.
No, ma'am,
It's
this
only
is good.
it is suggestion. It's only a suggestion.
It's a constructive approach.
Yes,
Thank
ma'am,
you,
that-
ma'am, for your insight.
yes.
And we
That's
definitely
real.
appreciate that.
Hey, hi, Ekta. Nice
Hi,
to see
ma'am.
that you're so sitting up so sprightly early in the morning. Nice.
Yeah,
Nebraska,
it's
much more
yes.
back, I think. I think you are
It's
you are
like
still not yet early morning. It's not yet dawn for you.
Yeah, it started like it's around 4:45 now. Yeah, in the morning. Yeah.
Very nice.
So definitely, like it was, we would have loved you to be more active, but because this was a state and a resident program and a competitive session, and we needed judges from out of the state, so you were a big support. So it was difficult choosing people from out of the state who have the experience and who can judge these students. So thank you for sitting through and, patiently judging our residents for that. So that was a great effort. And it's so good that you are able to give us input on that.
I was
so that
recently attending the beautiful TNOA sessions which Dr. Mohan was organizing. Amazing. I think Dr. Vijay Raghavan, it was like a learning. It was really learning there. Nobody taught us neuro-ophthalmology so beautifully. He did a fantastic job. So I think there's scope for learning at any age.
Will you like to suggest to our presenters what all they can include further? Like, how can they improve their presentation?
They have to completely show their case, how they presented. They should put it up saying, okay, I'm having only this many months of follow-up and I need to see what happens next. But because many a poor PG is misled saying, this is the first time that such a case has been reported. This is the first time that something like this is happening, blah, blah. And if they have a set of cases and show, like one person had shown those 2 or 3 cases of disc edema, that is IAH. That was a very nice conglomeration of cases. So something like that. Every case presentation should have a take-home point. They should have a take-home message. And there should be the completeness of the case. There's no dearth for investigation. There's no dearth for talent. There's no dearth for good surgery. So I don't think we should just stop short halfway through and say, this is it. That's all.
I agreed. And I will also welcome some inputs from our other judges, Dr. Rajat and Dr. Marian. If you can also join and pitch in and give some input to our presenters.
Hi, Dr. Marian here. I really enjoyed a great initiative. Then, as Dr. Lakshmi Mahesh has told, we need some more time. I don't know, for plasty and neurophthal, we need some more time, especially regarding the management part and to discuss. It's a good initiative.
Dr. Rajat, are you around?
Ma'am, I have sent you the final scores.
Right. That's awesome. And that's again another Herculean task. And so I do have the results with me now. And let's start with the sessions first. So for our session 1, the winner is Dr. Himani Manglek. And she presented on the blunt ocular injury. And her mentor was Dr. Jay Prakash, and this is from Shankar Nethralaya. So congratulations. The session 2, the winner was Dr. Mridula Vijayaraghavan. Again, a mentor was Dr. Geeta Iyer. The topic was on topical chemotherapy for OSSN. And she's again from Shankar Nethralaya. For the session 3, our winner was Dr. Bharati S. Again, the mentor was Dr. M.V.S. Prakash, and the topic was the road less traveled, lacrimal fistula. And our overall winner is Dr. Himani Manglek from Shankar Nethralaya. Congratulations to all the presenters and Well done, Himani.
Thank you, ma'am.
Congrats, Himani. That was really very nice. And congratulations to the other winners also. And the winner of this session goes to the final rounds to compete in the national level. They will have a physical presentation. I guess Dr. Mohita Sharma will be giving out the details when and where they will be presenting. So
Yeah, we are having a conference in November, the annual conference. So of course we will share the flyer. So very well done all the presenters, and let's keep doing this more often. And thank you, Subneshwari.
Dr. Ekta, you're doing a great job from far.
Thanks, Dr. Renuka.
Great. Excellent. And you're kept awake. Oh, wow. Great.
Yeah, somehow
That's
time
good.
zone was
Anyway, I
not
just
matching.
came in 2 days back. So,
okay.
Good. Good. You're so enthusiastic. That shows, and passionate about the whole thing. Thanks very much.
I know Tamil Nadu is such a good platform, and we are so good in doing ophthalmology here, and we should be having a platform where, you know, all the ladies can present something. So definitely this is a learning platform where we can have exchange of views, we can have more discussions, and we keep growing. Is Dr. Subneshwari, do we have anything else, or?
No, actually, I guess we are done with the WAS Tamil Nadu and Puducherry chapter for 2021-22, the competitive rounds. I think then until we plan for the next thing, I guess we'll say bye for now. And thank you to everybody for being with us today. It's been a great pleasure. Thank you all. And thank you, Dr. EPR, for roping me inside.
You have been so enthusiastic, and thank you so much. So
yeah.
Congratulations to all the presenters. You were great. And congratulations to the winner.
Yeah. Thank you, Radha. It's been nice working with you back again, you know, to our MBBS times. We had 3 of our batchmates in the same thing today.
Okay, so that's a batch performance.
Yeah, batch performance actually, by and large.
Right.
Okay, Pratibha,
Okay.
bye. Thank you. Yeah,
bye everybody.
Bye. See you. Thank you. Yeah.
Bye.